Good morning and welcome. I think we're about ready to start here. Before we do, I'm going to ask Senator Prentice to lead us in the Pledge of Allegiance. All right, good morning. We're going to open the hearing on Senate Bill 408 relative to health insurance coverage for prosthetics. And I'm going to ask Senator Gannon to introduce his bill. We'll open the hearing.
Thank you, Senator. And I want to first thank Sue Prentice. She always helps me with anything I do, and that's a good thing. She comes over. Not to say my other legislation is bad, but these are bipartisan bills, and Sue is always there for me for the last decade, so I appreciate that. So this bill, and I've been focusing on other bills this morning, we'll just talk about me. My favorite topic. I'm a politician. I'm being funny. No, I'm not that funny. I used to be a great runner, really good. Not Division I. I wasn't going to the Olympics, but I was pretty good. So in my head, I'm still 160 pounds, and I can still do a 4:30 mile, but I can't. But if I had lost my leg earlier, and if even now, I really would love a blade. So I would jog a lot more. Right now, the leg I have is very functional. It does what it's supposed to do, but it's not helping me jog or go out. I was down in Florida for 2 weeks. I walked every day, 4 or 5 miles, and this leg just isn't made to do that. So it doesn't encourage me to work out as much. It makes it much harder. And if I was working out a little more, maybe I'd be in a little better shape. I probably would be. It would be better for everyone if I was in better shape, because then I wouldn't cost so much for heart problems, for diabetes problems, other things. So this bill does two things. At age 18 right now, you can't, they stopped giving you a prosthetic device for specific activities. So last year, and I'm not sure if she's here, there was a young woman. She is, okay. So I loved listening to her. I was in tears with all the things the young lady from Hannaford could do. But she realized at 18, she's going to get her last, she is missing an arm. And so she's grown up with, God, if she has the early arm she had, it's unbelievable the things she can do. She can climb face climbing she's into. She does a couple different sports at her school. She's into archery, but you need a specific prosthetic device for these activities. So I believe it was the Shriners up till now who paid for her arms, but at age 18, that stops, and you'll get a basic. Again, I'm very grateful I have the leg I have. It does the things I need, but specifically if I was younger, and even now, I really would love an activity-specific thing. I go down to Florida a lot. When I retire in a few years, I hope to be at a pool on days like today. And it would be nice if that was the activity I really liked. If you could have a prosthetic thing to help you swim and function, that would be great. But the young woman with her arms now, I'm not sure how she's going to get the things to do all the sports she needs to do. Maybe she's lucky and she'll be at a college that would provide it if she can play a sport or something. But most people are going to then not have the appendage. She was into kayaking. There's a special arm for that. So if she could at least have one activity that she knew she could do, it's going to improve her quality of life for the next, she's very young, so hopefully 70 years for her. And as you get older, you're much less apt to probably want that second thing. But even at my age, I'm 63, I really would love to have the blade type leg you've seen, just so I could jog easier. And it would make a huge difference in my quality of life. It would also, again, I think keep me much healthier and save insurance costs long term. So for everybody who's in a little bit of shape, we will not be needing that diabetes medicine, the heart medicine, all these other things, if we can get people to be able to work out a little. It's about, people behind me will testify more accurately, but as I remember it, around 50 people a year will be looking for these items. Most of the legs that I've encountered are like $10,000, 50 times 10. So we'll just say that's an average price would be 500,000. But the savings for the insurance company on the other end, if they look at it all that way, is going to be a multiplier. And it's going to improve people's quality of life. So I think, especially other people and especially younger people who might want these, it's really going to make a lifetime difference in their life. And it's also physically going to help them be in a much better place, which should save us all a lot of money and plus give them better quality of life. And so it's every 5 years. It's one activity-specific prosthetic they'd be looking for. Again, it seems like the beginning, it will be a little heavier demand because you're going to have people from 20 years old to 70 who have never had the opportunity. And so you will have higher demand at the beginning. They probably can give you better estimates. After a couple of years, the peak demand will have worn down and it'll be about your 50 a year. So I think it's a worthwhile endeavor. The insurance companies, last time I talked to them, but that was about a year ago, were willing to work with us on this, and Senator Prentice probably can give you a little better information on this. But I felt I had it over the line last year. It made it to the last day, and it got cut out in the budget hearings on a Friday. On a Thursday, I thought we were all set.
Yeah.
And Friday, I got the bad news that this got cut. So it's been passed before. I don't remember if it was unanimous in the Senate. I think it was. And we're just looking forward to making the pitch in the House and trying to get it over the finish line. Thank you.
Thank you. And as I recall, when we did pass this last year, Senate Bill 132, the version that we passed is identical to what we have here, and that version was a result of some working with the stakeholders that were involved. And I do believe it passed out of committee unanimously and out of consent out of the whole Senate.
Yeah, it never was really heard on the floor. We held it Senator Gray held it in finance.
Sure.
And by the time we just put it on, tacked it on the budget and
Yep.
tried to push it through that way. Then the other side was sort of resentful, Representative Hunt, that we didn't have a hearing. It hadn't gone through the regular process. So since he didn't get to hear it and the public didn't hear it in the House, he had a chip on his shoulder against it, and they had to cut things, and that went.
All right, very good.
Okay, thank you, Senator. So for the record, my name is Sue Prentice, State Senator from District 5. Always a pleasure to work with my colleague from District 23.
The wine district.
The wine district down in the more southern part of the state, and I come from the Upper Valley. So we're talking about Senate Bill 408, and I'm just going to lift off of some of Senator Gannon's points, things that were discussed last year that were concerns. Well, some of them were concerns, some of them were not. But let's just start by saying again, this is adult. So we got this passed for children. It was called So New Hampshire Kids Could Move. And at that point, we did an insurance mandate analysis because our premise going into this, which we're carrying forward, threading through to this bill, is that sedentary lifestyles lead to chronic medical conditions, which are costly. And I'm going to give you an example of the costs that are attached to, say, diabetes. But when we look at this, as the senator said, we're talking about adult-based coverage, medically necessary, every 5 years. And the state, we are not involving or including the state health insurance plan at this time. That was a concern in the fiscal note that we worked on last year, which I will address, which takes away any general fund-related costs. Those are the high points. So let's talk about some of the details. We've got an average cost per beneficiary of $27,000 per prosthetic device, which is reflective of what Senator Gannon has stated, and we know that this continues to hold. Our eligible population in New Hampshire is about 19,800, who are the folks that are living with limb loss. This is because of trauma. This is because of a congenital defect, the way they were born, and also because of cancer or another medical condition that could cause you to lose all or part of a limb. Only 45% of this 19,800 are enrolled in a fully insured commercial plan. So we're estimating that 8,900 adults are eligible at this point, and the expected utilization is 10 to 30%. And again, one activity-specific device every 5 years. Now, I want to talk about, we know that although it's still, there's some language in the fiscal note, there's language in the narrative, the number in terms of including this in a state employee health plan, which Administrative Services does consider when bills like this come across. We've asked for that to be set aside so we can get this over the finish line and then evaluate it in the future. So you won't see it in the table, but it is in the narrative. There could be some costs to local and county governments because they use some of the health carriers that could be impacted by this. But the key fiscal concerns are really around that downward pressure on our health insurance carriers. I have a colleague here from the Hanger Clinic, Maggie Barmer, who's going to talk about what that has looked like in other states. We're sensitive to those downward pressures, but believe that we can balance this, but by what it costs if we continue to live and work in a situation where that folks are not able to be more active and lead sedentary lifestyles. So let's look at a lifetime cost of a diabetic, $250,000 to $500,000 per person. That is just a lifetime cost. There are annual costs, so per year, depending on at what point, type 1 or type 2, you come into the mix, that's roughly $16,750. So my overall point to you is that insulin, diabetes medications, blood glucose monitoring, physician visits, and emergency care, including what this could lead to in terms of cardiovascular disease, kidney disease, and dialysis, are much more costly than an investment in activity-specific prosthetics. So as we wrap here, let's just do the high points of why this can reduce long-term insurance costs, improve physical health, fewer chronic conditions, which I've covered diabetes, but there's also complications for musculoskeletal health, cardiovascular disease, and this also leads to better weight management, reduced secondary medical complications, falls, injuries, joint degeneration, chronic back pain, skin breakdown and infections, and overuse injuries that will require and have required surgery. Mental health and behavioral health savings. How you feel about yourself can be directly connected to your level of activity and achievements that you make in an activity-related lifestyle. In my mid to late 40s, I took up CrossFit, something that I never thought I would be doing, flipping tires and lifting weights. But how I felt about my achievements in that sport, as well as how I was able to bring myself into better shape, really made me feel better. And I know folks that are in a more sedentary lifestyle because of medical conditions benefit even more, because at that point in time, and I consider even with my new hip, which is not covered under this conversation, I feel so much better about my life. Imagine folks who are not in that place, and we can get them to that place. Workforce participation and productivity. We talk about this all the time. People who can work, they want to work, and this has been a barrier to folks to be in the workplace. We can help them get past that barrier and bring them into the workforce, into a more productive lifestyle that's good for them, good for their mental health, and good for our economy. Cost controls are already built into this bill. We know what it's going to cost us. We know what it costs to treat long-term chronic conditions. We believe we can hold down the cost of long-term chronic conditions by addressing this. We know we've done it with children. And this aligns with the value-based care principles. This is a good thing for our patients. This is a good thing for our population that are suffering, or that are suffering, as well as have had many difficulties because they have lost a limb from at least one of the 3 conditions or areas that I've talked about today. All of this to say, we've done this for kids. We should do this for adults. We know what it costs. We know what our population is. There's always a ramp-up period. I've addressed the fiscal note concerns that came out last year, and I believe over time, from what we know about when we did the insurance mandate review for the children, based on some of the data that I've pulled here, that we can actually save the state and save our communities money and really take really great care of those who suffered limb loss. Thank you very much. Happy to take any questions.
Thank you very much. Senator, it's just you and I. Any questions? All right, thank you very much.
Thank you.
So we got about 8 people signed up to speak. Just want to remind you that if you have written your comments, please summarize them. We can read them. Just hand them over to our committee staff and give us a summary of those written comments. If someone has made a point already, no need to belabor that point. And we'll keep this moving right along. So with that, I'll call Trey Cimarelli.
All right. Good morning, Chair and members of the Senate Health and Human Services Committee. My name is Trey Cimarelli, and I'm a certified prosthetist with 4Motion Clinic here in Concord. Thank you for the opportunity to speak in support of Senate Bill 408 and the So Everybody Can Move initiative. While I'm not originally from New Hampshire, my wife and I moved here 2 years ago specifically because we wanted to live in a place where outdoor recreation and community are a part of everyday life. We recently bought a house here in Henniker, and we're looking forward to calling New Hampshire home and hopefully raising a family here. I take a great deal of pride caring for the local community here through my clinic in Concord, and I chose this profession because I believe deeply in mobility, not just as the ability to walk, but as the ability to live fully and stay connected to the activities and the people that matter most. My mobility is incredibly important to me, and being active outdoors are how I stay healthy both physically and mentally. And when I'm fully healthy, it allows me to positively contribute to the community in many ways. Someone once explained the So Everybody Can Move initiative to me in a way that really stuck. If I were to tear my ACL while skiing, my insurance company would pay for my surgery, they'd pay for my physical therapy, and they would potentially even cover a custom brace for me to return to my recreational activities. So the question is, why is recovery and prevention supported for able-bodied individuals, but not for people with limb loss or limb difference? The devices that our patients need to get back to these activities are currently not covered. We already recognize in New Hampshire that children deserve access to activity-specific prosthetic care. This bill would just be introducing that in adults and allowing adults to get that same care. For perspective, the majority of patients who come to see me for a prosthesis, their amputation was caused by diabetes and dysvascular issues. They will not qualify for a secondary prosthesis. They are simply hoping to walk in their home and through the grocery store. This bill is seeking to support individuals like Hudson, one of my patients sitting behind me who's hoping to come up and speak as well, active adults hoping to regain their mobility and positively interact with the New Hampshire community. From both a human and healthcare perspective, this is the right thing to do. Supporting physical activity reduces the risk of secondary conditions like arthritis, cardiovascular disease, chronic pain, and depression, all of which are far more costly to treat over time than providing the appropriate prosthetic care up front. Here at 4Motion, our mission is not just to help people walk, but to help them move forward towards the lives that they want to live. Senate Bill 408 would allow us to provide care that truly supports long-term health, independence, and quality of life for adults across New Hampshire. I strongly urge you to support this bill. I want to thank everyone who has already sponsored it. I would be happy to host anyone at our clinic here in Concord if you want to learn more about the O&P profession and what we do on a daily basis. And I just want to thank you guys for your time and consideration.
Thank you very much. Are there any questions? Senator Long.
Thank you, Mr. Chairman. Thank you for your testimony. I'm wondering, medically necessary, I'm wondering if psychologically, if you've had issues with the child that psychologically would want this to help them.
Yeah, absolutely. I would say that the majority or a lot of the patients that we take care of deal with psychosocial issues related to their amputation. Since the passing of the bill in children, I haven't specifically been able to provide one of these devices to a child. I just don't have a huge pediatric population here in my clinic in Concord. But I can definitely tell you that many of the adults that I do treat, deal with these issues and would really benefit from an activity-specific prosthesis for, many of the reasons that were already brought up today.
Great, thank you.
Any further questions? Seeing none, well done, thank you. Hudson Hammer? Did I pronounce that right?
Morning, Chair.
You want to hit your button? Your button.
Good morning, Chair and members of the committee. Thank you for the opportunity to speak today in support of SB 408. My name is Hudson Hammer. I'm a New Hampshire resident and a recent amputee. On May 9th, 2025, about 10 days after a traumatic motorcycle accident, I made a life-altering decision to have my leg amputated below the knee. On the very first night of my accident, the doctors told me it was very likely I would lose my leg. Hearing those words was devastating. It felt like my entire future collapsed in that moment. My mental health immediately spiraled. I wasn't thinking about healing or timelines. I was thinking about how my life is going to look from that point forward. How am I going to work? How am I going to stay active? How am I going to live the life? How am I going to live with losing something I relied on every single day without ever thinking about it? While I was in the hospital, friends and family showed me videos of Paralympians and everyday amputees using advanced specific prosthesis. For the first time since my accident, I felt something other than fear. I felt hope. I could picture a future where I wasn't just surviving, but actually living again. Today, I wear what's considered my everyday prosthetic foot. It allows me to walk and allows me to work. And I'm grateful for that. But it is limited. I cannot run, I cannot jump, and I cannot sprint. My range of motion and physical conditioning are restricted. And every limitation is a reminder of what I've lost. Activity-specific prostheses are not a luxury. They are a missing piece of rebuilding a full life. Our natural legs are like a Swiss Army knife, adaptable, responsive, and resilient. No single prosthesis can replace all of that. Each device serves a different purpose, and access to them matters deeply for both physical and mental health. The technology exists, it works, but currently activity-specific prostheses are not covered by insurance, placing them completely out of reach for people who need them the most. Passing this bill is not about extras, it's about restoration. It allows amputees to stay active, stay mentally healthy, and stay engaged in their communities. It helps prevent long-term health complications and reduces future healthcare costs. This bill doesn't give me anything extra. It simply gives me a fair chance to move forward, not defined by loss, but by possibility. Thank you for your time. I respectfully ask you to support.
Thank you for your testimony. Any questions from the committee? Seeing none, thank you very much. Commissioner Bettencourt?
Thank you, Mr. Chairman, members of the committee. For the record, DJ Bettencourt, I have the pleasure of serving as the Commissioner of the New Hampshire Insurance Department. I am here today in support of Senate Bill 408. Full stop. No technical issues, no problems we've identified, but I would like to explain a little bit as to why the department is in support. So as all of you, I think, know at this point, I am not a big fan or a fan at all of mandates. However, not all mandates are created equal. We had the pleasure of working very closely with Senator Gannon and Senator Prentice in putting this bill together, and we were able to carefully craft this legislation such that it avoids some of the traditional problems you encounter when you're talking about an additional mandate. So because it applies to the large group market, you sidestep the federal defrayal challenge that we often have to very seriously consider, again, when talking about mandates. And as a result of the mandate review that Senator Prentice mentioned that we did when this issue pertained just to children, we were able to update that mandate review to also apply to adults, and we were able to put cost containment measures in place, again, along the lines of what Senator Prentice mentioned, which is to say that the coverage for activity-specific prosthetic devices is limited to once every 5 years. So we cannot, we've avoided a situation where somebody is getting a new hobby every couple of months and wants a new prosthetic. There are cost containment measures in place that ensure that that's not overly used or abused. I would say that we were able to, as a result of the mandate study, we were able to identify the eligible population fairly well, fairly accurately. And so the total number of eligible people who would potentially benefit from this legislation is approximately 8,900 people. And then from the statistics that we were able to find, we were able to then determine that the eligible, so of those 8,900 people, the number of individuals who would likely seek out this benefit would be somewhere between 890 people to 2,600 people, which may not seem like a big number. But as I've heard from the testimony thus far, and I think you'll continue to hear in the testimony that will come after me, is a huge, big deal to those people, life-changing for those individuals. So while it may seem like a small number, its impact is, needless to say, quite significant. And so weighing all of that out, not to be repetitive of what has been said, my determination is that the policy benefits thoroughly outweigh the cost for this. Now, with that said, I'll leave you with just a word of caution. Please do not go crazy with additional mandates. This one, as I said, is very well done, very narrowly tailored. This system will be just fine. But you have to be careful about those additional mandates because they do add up and they do put a real pressure on the cost of premiums, the cost of insurance. So with all of that said, I'm happy to take questions.
Questions from the committee?
Thank you, Commissioner, for taking my question. Would it be fair to say that the insurance mandate review that we did when we were considering the first piece of legislation for children, for under 19 population, really helped inform some of the, I don't want to call them trade-offs, but when you're looking at chronic medical conditions and the costs of those versus the activities that then we were looking at the youth population, but would translate over to adults?
Yes, it was very helpful. We used an outside vendor to do the mandate review for children. When this additional expansion was proposed last year, we were able to in-house update that. And to your point, Senator, you know, it is oftentimes the case that people say, well, if you mandate this, there's going to be savings on the back end of things. Sometimes those claims have a more direct line than others. For me, in reviewing the material that we were able to gather and analyze, I do see a much clearer line between the cost of this coverage to the benefits to an individual's health, both physically and mentally, such that there very well should be cost savings in preventing other conditions that would exist absent the ability for the individual to get this prosthetic.
So one other question, I really do like your jacket. What do you think the Patriots are going
Thank
to
you.
win?
Go Patriots.
I'm getting over an illness and it's so cold. I said, you know, I'm going to see if I can get away without wearing the jacket. But if I wear the Patriots coat, I definitely think I'm in pretty good shape.
All right. Thank you, Commissioner. Appreciate
Thank
your
you.
time.
You bet.
Patriots. Thanks.
All right, thank you. It looks like we're on to Jason Lala.
Good morning, Mr. Chairman and members of the committee. My name is Jason Walla. I'm from Bow, New Hampshire. I've spoken before on behalf of Senate Bill 177, so many of you may have heard some of the things I'm about to say prior. I do have a written statement that I will submit, but I'm decided that in the interest of time, I'm going to try to touch on some points that I think are extremely important and valid to this scenario. I think I offer a unique perspective I'm a certified prosthetist for 4Motion clinics. We have clinics in Manchester, Concord, and Lebanon, New Hampshire. I've been practicing for approximately 20 years. But in addition to that, I am also an above-the-knee amputee myself. I lost my leg in a motorcycle accident 37 years ago and have gone on to live a pretty active and healthy lifestyle for a few different reasons. Early on, I was afforded the ability to receive a sport-specific prosthesis. I can tell you firsthand that that life-changing event, as Hudson previously stated, there are so many things that are just unknown. There is elements of depression. There is elements of questioning what you're going to be able to do, how active you are going to be, especially as being an individual who was extremely involved in sports throughout my life. At that point, that kind of opened up some doors for me. I became passionate about cycling, specifically mountain biking and skiing. And I can tell you again firsthand that that changed my outlook on life. I think the mental health implications were significant. And I was fortunate enough to have been able to receive that device through a foundation. Unfortunately, the foundations that exist are limited in their funding, and they're usually a one-time grant that you can receive in your lifetime. That being said, I'll fast forward a few years. I continued to be extremely active, and I actually pursued competing competitively in alpine skiing and went on to be able to compete in the Paralympic Games. After doing so, I decided to pursue becoming a prosthetist as a profession, recognizing the ability to be able to give back what I had been given myself and the rewards that were involved with that. We all know that being active has huge health implications. Being inactive, certain things like obesity, diabetes, heart disease, all of those things become much higher risk factors. It is said that approximately 50% of people with disabilities get no aerobic exercise, and that is directly results in some of the previous diseases that I just spoke about. Another thing that I would like to touch on is not only did the ability to be involved in these activities and remain active affect me personally as far as my own well-being and mental health, but I've now gone on to raise 2 children who also remain extremely active. I believe that we're talking about generational health implications. The ability to be involved in sports, to be able to introduce them to remaining active, remaining in the outdoors, exercising, staying healthy, I think is a direct result of the examples that we set as parents. While I remain, so I'm here today to ask that as New Hampshire residents, that we join the 11 other states that have already passed this bill, and that we invest in the health of individuals living with limb loss. I'm here to ask for your support of Bill 408 being passed into law. I will answer any questions that you may have.
Great, thank you very much. Are there any questions of the committee? Senator Long.
Thank you, Mr. Chairman. Thank you for your testimony. With the 3 locations you have you had an issue with a child who psychologically wanted an activity prosthesis?
Yeah, thank you for asking that. So actually, one of my patients, his name is Aiden, he came and testified and spoke on behalf of SB 177. And he is approximately 14 years old, an above knee amputee. And I can tell you that he ended up being granted or being, we ended up being able to fit him with a running prosthesis as a result of SB 177. Since that time, I was able to watch him kind of flourish. He was a pretty introverted, very quiet kid, but he is now playing soccer. He is participating in some of like these 5K running events and things of that sort. As a matter of fact, he tends to wear his running prosthesis almost more than he's wearing his everyday prosthesis. So there is a significant difference in those devices and what they allow you to do. I want to expand upon that a little bit as well. As Hudson previously said, an everyday prosthesis is certainly not designed to be able to do everything for an individual. On an everyday prosthesis, I can certainly walk, I can do yard work, I can do things of that sort. If I wanted to run a very short distance, like run across the road if I had to, I would be able to do that. But doing things like longer distance running, cycling, skiing, mountain biking, they are not designed to perform those tasks. I would also say that by attempting to perform those tasks on your everyday prosthesis, there is a significant increase in forces that are placed upon the body, and I believe that you have a far higher potential of injuring yourself trying to do those things on your everyday prosthesis. So I think there is both mental and physical health implications in that scenario.
Very good, thank you.
Any other questions of the committee? Thank you very much. Call Dana Clark.
Good morning.
Morning.
My name is Dana Clark. In 2021, I was in a horrific motorcycle accident. My life was changed and not for the better. I ended up with a below-the-knee amputation on my right leg. For the next several months, I was imprisoned in a wheelchair. That wheelchair was my prison. I was restricted to the mobility of that wheelchair. And I would often think, is this it? Is this where my life is going to go? This is how I'm going to spend my days? Where's the quality of life in that? There isn't. That's not living. That's existing. And I wanted more than that. But I feel I'm one of the lucky ones because being a veteran through the VA, I was able to gain access to a facility like Full Motion. And they guided me through the process of using a prosthetic and getting back on the road to getting my life back. I live alone. And if I had to spend my life in a wheelchair, I don't think that would be possible. Just think of the simple daily chores that one has to do without having a prosthetic. You can't do that from a wheelchair. Laundry, folding bed sheets, cooking on a stovetop, that would be impossible. Difficult at best. Because I have a everyday prosthetic, I can maneuver through the house, I can do yard work, I can mow the lawn, I can shovel snow, I can walk to the grocery store and grab items off the top shelf like I did before my accident. Through the VA, I was able to access a second prosthetic. This is my running blade. This is what a running blade looks like, and the senator had talked about. It's allowed me to get back on the track and help me maintain some sort of health. The prosthetic that my everyday leg allows me to get back into the woods to hunt, something I love to do. And I just spent a week in the woods tipping lines for the upcoming maple season. And I'm going back in a week to start tapping those trees, and you can't do that from a wheelchair. The ability to have two prosthetics mentally is huge. I have my everyday leg to do things I like to do every day, but then the ability to run, I can maintain some health, and that is important to maintain that health. As Trey had stated earlier, most insurance companies allow for one prosthesis, but by supporting SB 408, you'll be helping folks less fortunate than myself the ability to access greater opportunities and possibilities to help them get off the couch, out of their wheelchairs, and back to their lives. By doing that, you'll be changing someone's life for the better. That's what I have to say. If you have any questions, I'll be glad to answer them. If not,
Thank you.
thank you for the opportunity.
You're welcome. Are there any questions of the committee? Thank you very much.
Welcome.
I call Samantha Therese.
Good morning. My name is Samantha Torres. I work at Hanger Clinic in Portsmouth. I'm also a resident of Epping, New Hampshire. I'm here to ask for your support regarding Senate Bill 408. I'll cut to the chase. Everyone in New Hampshire who is eligible for an activity-specific prosthesis should be able to receive one. As we know, physical activity has a profound effect not only on your physical health, but also mental health. Many of our patients who experience amputation, whether it's a condition they were born with or it occurred later in life, grapple with the loss of their limb. Some of our patients have been scared that there isn't a way forward in life post-amputation, that they'll be stuck in a sedentary lifestyle. And the consequence of that could be costly hospitalizations, rehab stays, surgeries, and even the inability to remain in their home. This bill will be a lifeline for many of patients in our state that are affected by limb loss. Currently, my office is challenging an insurance denial for one of our patients who needs a microprocessor high activity knee. They have a current prosthesis. It's over a year old. They have progressed in their activities and their stamina. They are doing so well. But now there's an issue of safety on their current prosthesis. The one they have right now doesn't allow them to traverse uneven terrain. To go outside right now on ice, impossible. The insurance has denied, saying that they don't cover prostheses, it's a hard word, for personal comfort and convenience. They didn't see the value in her progression and the need for safer conditions to go outside in our state. So we are challenging that. Another patient of ours in Portsmouth is a quadruple amputee. They're provided prostheses through the VA. They're an avid walker, sometimes walking up to 6 miles a day. And being able to be active is extremely important for their overall health and well-being, not just physically, but mentally. As I think we can all imagine the toll of losing parts or all of 4 of your limbs can have on someone. The VA recognizes the importance, and they provide specific activity-specific prostheses routinely for this patient. This is the plan of care I'd like to see offered to all of our patients. We would be grateful for your support of Senate Bill 408 and your commitment to advocating for our patient population. We hope you recognize its importance to the well-being of our patients in our community. Thank you for your time.
Thank you, Samantha. And it's Samantha Torres, right? I pronounced
Yeah.
that wrong. I
That's okay.
apologize.
That's okay.
Are there any questions from the committee? Thank you very much.
Thank you.
Keith Adamick.
Good morning, Mr. Chair and committee. My name is Keith Adamick. I'm here to share my concern and the importance of the SB 408 bill and how it can help individuals like myself stay active so we can all live happy and healthy life, and that's physically and mentally. I've always been a very active person, whether it be working, building houses, or out riding my mountain bike, golfing, bow hunting, which includes walking through the woods, climbing trees, and especially snowboarding with my children, which was my biggest passion. In May of 2017, at age 55, I got some kind of virus that attacked my heart and landed me in the Boston hospital for several months. I ended up on life support, lost circulation of my extremities, which led to the amputation of my lower left leg. When I got my prosthetic, I knew I still needed to stay active mentally and physically for myself. As time went on, I was doing okay with most of this, but I was still struggling with the snowboarding, which was, like I said, one of my biggest passions. I got to a point where I was getting depressed and I was going to give up snowboarding altogether, which I've done with my kids and my now grandchildren. I talked to my prosthetist, that's a tough word to say. I don't want to say the wrong word. But Jason Lala informed me about other feet or other prosthetics that could be used for this specific sports, but they're not covered by insurance. We searched everywhere through foundations and through other things. We had no luck. Jason found that Spalding Rehab was offering a grant for a secondary leg like this. So we reached out, and luckily, I was lucky enough to get a specific sport leg for snowboarding. And by the way, it cost $13,000, which I never would have gotten without the grant. And with it, it's like night and day. I'm out snowboarding every week. I go out with my grandkids. And you talk about psychologically how people are affected. I'm here to tell you, it's a huge difference being able to do what you used to do and go out and do things to keep you healthy. So unfortunately, not everyone can get grants like I did. That's why I'm urging you to pass this bill, the 408, so everyone can get the prosthetics they need to live a happy and healthy life. Being able to stay active means staying healthy, which potentially saves money with long-term issues such as obesity, diabetes, and mostly depression. I appreciate your time.
Great. Thank you, Keith. Are there any questions? Thank you very much.
Thank you.
Giovanna Shembri.
Good morning, Mr. Chair, member of the committees. Thank you for giving me the opportunity to testify today in support of SB 408. My name is Giovanna Shembri, and I've been a resident of New Hampshire for my entire life. I currently live in Hanover, New Hampshire, and I attend the high school there. I was born missing my right hand just below the elbow after I suffered from what is known as amniotic band syndrome, or ABS. I received my first prosthetic device from Shriners Children's Hospital in Springfield, Mass. At about 6 months old. This prosthetic device was a basic prosthetic. It was about this long and was mostly to just kind of help to balance my weight. Throughout my life, as I've grown up, I've gone through almost a dozen different prosthetic devices with varying attachments and adapters for each to help me adjust to life. But I consider myself a bit of a resilient kid, but that doesn't mean that things haven't been difficult for me. For each thing that I've had to do, from pouring milk into my cereal in the morning to putting on my PJs at night before I go to bed, I've had to figure out how to adapt, and I've had to use prosthetics to figure out my life as an amputee. And in this world, it is designed for not only right-handed people, but also two-handed people, and I am neither. Growing up in New Hampshire, I've seen the very best that our state has to offer. I've played softball and I've gone mountain biking in the spring. I've swam in the lakes and the rivers in the summer, played soccer, and gone rock climbing and hiking in the White Mountains during the fall. And I've gone Nordic skiing and alpine skiing and played pond hockey during the winter. I've been able to play all of these sports because of prosthetics, and I've seen the very best that this state has to offer. In addition to the sports I play, I have a bit of a knack for the arts, I like to think. I started playing the violin in 4th grade and use a special prosthetic device for that. I've also taught myself a bit of piano, and I also use an adaptive prosthetic for that. As I've grown up, I've been lucky enough to have the freedom and the opportunity to experiment with different sports and activities. I've had the chance to figure out what hobbies I like and what I enjoy doing, even with the challenges that come with finding each one. And even though I've occasionally struggled with some of them, I've had my family and my friends who have been willing to help me out. And they've always been there to support me, even when I inevitably topple over or I almost break something when I decide to try cliff jumping or archery for the first time. But more and more as I get older, I find myself thinking about what it would be like to be normal, what it would be like to not have to worry about the 50,000 attachments and prosthetics I have to bring with me whenever I go somewhere, and not have to worry about how much it would cost me to replace my bike attachment or my arm if I fell. I'm still young enough to not have to worry about how high my medical bills would be, or how much insurance would cover for a new prosthetic, because I'm covered by Shriners. But what happens when I grow out of that? When that coverage goes away? What happens when I suddenly have to start thinking about prices and risks and how much I really need to do something? When I have to start debating which sports and activities that I have grown up enjoying that I will have to give up because as I continue to grow, the prosthetics that help me to do the things that I love do not fit me anymore. What happens when I have to start letting go of the things that make me who I am? When I have to start letting go of the things that make me love this state? Please, from the bottom of my heart, I ask you to support SB 408 and give me a chance at a brighter future. Thank you for your time.
Thank you, Giovanna. And you said something there. You are normal. You're far more active than I am, and I always appreciate you coming in and talking to us. You came in last year, and appreciate that. Are you missing school today?
Yes, I am.
Do you need a note?
I already got one.
If you do, let me know. I'm happy
I will.
to provide it for you. Are there any questions of the committee? Thank you very much.
Thank you.
So that's it that I have on my list. Is there anyone else that would like to speak on Senate Bill 408?
Move it along.
Good morning. I thought I did sign up. My name is Maggie Baumer. I'm here with Hanger Clinic. I'm a resident of Massachusetts, but I'm in a national role for Hanger Clinic, which is one of the largest providers of prosthetic and orthotic services in the country. We have several facilities here in New Hampshire as well. I'm also a member of the So Everybody Can Move national team, so I serve as the legislative affairs lead for that group. As others have mentioned, there have been 12 states so far that have introduced and passed So Everybody Can Move type legislation, including New Hampshire. SB 177 was the first bill that we passed in New Hampshire in regards to activity-specific prostheses. And there are going to be 28 bills introduced this session across the country. So this is definitely a national movement, and happy to see New Hampshire among those first 12. I too am a person with limb loss. I'm missing my arm below the elbow as a result of a trauma back in 2012. So as you can see, this is my daily use prosthesis that's made out of silicone. It's just a model, a mold of this hand transposed so that it fits me. You know, it's basically my arm. So it's the right size and shape. It's nice and lightweight, and this is what I use on a daily basis. But I also have this second device, which, as you can see, looks very different. This is my device for physical activity. Mostly I use it for yoga, weightlifting, and skiing. And I think there's just a misconception out there about prostheses and restoration. One of the previous speakers talked about restoration. And the issue is that we need it's certainly more than one device in order to be fully functional and restore full function. So the example we often give is that people who have an ACL tear, for example, the insurance will cover that surgery to restore them to full function. But typically, insurers only cover one prosthesis, which only gets you back to a certain level of function. Daily walking, daily activities, but not certain activities like hiking, biking, skiing, recreational activities, or even going to the beach. You know, some of those things we need a separate device for. So this is really just about fairness in terms of restoring us to our full function. Somebody else had mentioned Aiden Collier and his family who testified previously, and I actually ran into him at the Bionic 5K in Boston last year after he had gotten access to his new device. And the whole family was just, you know, thrilled, really happy. As Jason described, Aiden had really come out of his shell. He was so excited to be running the race and to be there with other folks. So we know that this has direct impact on people's physical health, mental health, emotional health. For me, I grew up swimming. I was also a runner and just an avid outdoors person. And so when I lost my arm, those were things I relied on in my recovery to get me back to myself after, you know, going through this life-changing event. So I'm lucky to get access to this type of device because of the company that I work for. This is a benefit that we provide as a prosthetic provider, but not everyone has that same access. So we want to ensure that. New Hampshire also has a history of passing insurance-related laws related to prosthetics. So back in 2003, it passed the Insurance Fairness, or ONP Parity Act, which ensures adequate coverage on a basic level for prostheses. And then we amended that bill with SB 177 to provide access to kids for prostheses for physical activity. And as others have stated, you know, the cost is relatively low. We estimated that the increase in premiums would be between 1 and 5 cents per member per month. At Hanger, we did an estimate of what we thought the cost would be to the state to add adults. I'll defer to the insurance commissioner because I'm sure his data is better than ours. But we estimated that this would only cost about $275,000. And for those folks who have to pay out of pocket, that can be anywhere from $80,000 to $150,000 to get access to the appropriate level of care. Because sometimes when we work out or do physical activities without the appropriate device, it leads to increased healthcare costs. So I think, you know, most people have given you the information we need today to really make this decision, and I'm just here to back that up as a member of this community and a member of Hanger, which is a national provider. So respectfully request your support of SB 408.
Thank you very much. Are there any questions? No, thank you very much.
Thank you.
Peter Bragdon.
Thank you, Mr. Chairman, members of the committee. For the record, Peter Bragdon, recovering state legislator, senior policy advisor for Parity Strategies here in Concord, representing, as you know, Harvard Pilgrim Healthcare, the state's non-for-profit health insurance company. My short-term memory is very bad. I don't think I signed up either for or against the bill. I just signed up to speak because I guess the comments I have are more of a umbrella statement that this bill probably falls under, because there's, I believe, 8 coverage mandate bills in the legislature this year. And I commend Senator Prentice because of those 8, I think 7 of them say the cost is indeterminable because nobody asked the insurance department to actually do a mandate review, which they did on the prior bill. And so this one's much more defined. So my comments are more for the issue of coverage mandates in general. For 2026, insurance rates health insurance rates in New Hampshire went up on average of 15%. For some plans, it was as high as 35%. And a lot of things impact health insurance rates. Among them are coverage mandates. And like I said, there are 8 of those this year. And, you know, one might say, well, what do you care about what the rates are? Because, you know, in one sense, it's just we get bills and we pay bills. That's all there is to it. But what really happens, and I think, as a former legislator, I understand the issue of needing to balance priorities, and just keep in mind that what happens when premiums go up is that employers could potentially either drop their insurance coverage or more likely get insurance plans that have higher higher cost sharing by the employees. And so what you have happened is, if first off they drop coverage, then people don't have insurance at all, which has future effects because then there's less people to share the costs, which means the next year more of those drop out and you get into a vicious cycle of people just dropping insurance coverage. Or if they go to a higher cost share, people are more likely to avoid or delay proper medical care. They're more likely to not follow the medication dosing instructions for prescriptions that they have. So again, the overall concern is that things that push premiums higher end up having significant short-term consequences. There are long-term benefits to a lot of things being discussed. And like I said, I know there's a balance between what the right policy is to the effect it has. There's some long-term benefits here. Just keep in mind the short-term for coverage mandates in general, and this one is fairly small compared to many. The overall impact is people have less insurance at all, and that's a big problem as well. So just ask that you keep that in mind. And then lastly, just for consistency, the legislature has, for years and years, even when I was in the legislature, passed a number of bills for health insurance mandates, but they don't include the state plan employees. They don't include the risk pools. And I think for consistency's sake, if you're going to pass a mandate on the group plans, then you should also include the state of New Hampshire health insurance system for state employees, as well as the risk pools for town and school employees. It's not a 28A issue because you're not putting a cost on the districts and towns themselves, but the risk pools should have to cover this. And in reality, it's difficult for us to compete against the risk pools because the legislature keeps passing mandates that we have to follow and they don't. So just for consistency's sake, I think it would be good to include the state employees and the risk pools as well. That's all I have. Happy to answer any questions.
All right, thank you. Are there any questions?
And again, I have no particular concerns on this, just the umbrella statement for coverage.
Absolutely. Yeah, I'm sure you'll be back.
I think you'll hear from me in the future. This is only the first of 8.
Thank you very much.
Thank you.
With that, I'm going to close the hearing on Senate Bill 408.
Motion to move into exec.
I got a motion. Do I have a second? Do I have a second? All those in favor of going into executive session, say aye.
Aye.
Any opposed?
Motion to approve.
Let's just wait to see where Sophie is.
Motion to pass.
We got a motion ought to pass on Senate Bill 408.
Seconded.
We got a second by Senator Prentice. Are there any further discussion? All right, so we're going to call the vote. All those in favor say aye.
Aye.
Any opposed? 4-0.
Consent.
Senator Avard moves consent. I'll second that. All those in favor say aye.
Aye.
Any opposed? No. So it's on consent. Senator Prentice, would you like to take this out?
Absolutely.
All right.
Motion to move out of exec.
Seconded.
All those in favor say aye.
Aye.
Any opposed? We are out of executive session.
Oh, where'd everybody go? Oh, it certainly is. Yes.
All right, we will open the hearing on Senate Bill 454, and I invite the prime sponsor, Senator Avard.
Thank you, Madam Chair, and committee members, all of you. It's nice to see you all. I am the prime sponsor of SB 454, and I'm Senator Kevin Avard, District 12, presenting this bill. SB 454 basically is requiring the Department of Health and Human Services to update existing relevant public health outreach programs by incorporating information to aid public understanding and awareness of Alzheimer's disease and other dementias. SB 454 will require the Department of Health and Human Services to update and incorporate into existing relevant public health outreach programs to aid people's understanding and awareness of Alzheimer's disease and other dementias and improve public health, to educate health care providers on the disease. And basically, the state is facing right now a crisis of at least 10% of the population over 65 years old with Alzheimer's in the state. Just for the record, I happen to chair the subcommittee on Alzheimer's, and we have had lots of discussions about things that people just didn't know about. If you're treating somebody, if you're caring for an individual who has Alzheimer's, this is a 24-hour, 7 days a week, ongoing commitment. And the awareness of some of the resources that are available is critical just for their mental health as a caregiver. We talked about that in one of the other bills about the caregivers. Well, if somebody's going 7 days a week and they don't have any respite or they don't know where to find help or other resources, there's a potential of breakdown. And so we as a committee, a lot of the members know somebody or have been engaged with individuals that have suffered from Alzheimer's. I personally know a few. I have neighbors that are a few. We had one individual that came to our committee and spoke about how that one of the hospitals in Nashua offers relief, but nobody knew about it. And so, what do you mean by relief? Well, if you're caring for somebody for 7 days a week, you need mental health time off. And they offer that help to take care of your loved one or your spouse or the person that you're taking care of for a period of time so that you can have a respite. But if the public doesn't know about this, it has a long-term effect, and it's not good. Due to the high need for care for those in later stage of this disease, it places a significant strain also on our healthcare system. Under the subcommittee Alzheimer's direction, I had in my notes under my direction, but I can't say that because we've had Jen Horgan here and everybody in the committee who's really been fully engaged. And You know, it's not one of those things where you come into the committee and, okay, it's a duty. This is a love of the individuals that are coming to testify and to be part of the committee and to be fully engaged. So under their direction, the Alzheimer's Association and the Department of Health and Human Services work together to develop an amendment to achieve objective priority, prioritizing Alzheimer's and dementia in our public health efforts, while also ensuring the language would appropriately work with the department and to be implemented with a little to no cost. I think our fiscal note is about 10 grand or something to that effect. So I know there are multiple individuals here who want to testify on the importance of this bill and the language and the amendment that I have for you. It is a replace all. So I would ask you to direct the questions to them, and I hope you will join me in supporting this important to no cost, high impact step that the state can take to make Alzheimer's and dementia awareness and to become mainstream in our public health priority. Supporting those living with the disease and families while also reducing the long-term system cost. Again, one of the things that came to my attention being the chair of the subcommittee is the fact that New Hampshire has the second oldest population in the country. Second. And with 10% of our population already suffering from dementia, it is critical that we get ahead of this and working with the departments on public awareness in early onset. How do you treat that? There are a lot of things that go along with this because people are ashamed. And you got to break that barrier. You got to break the barrier. If somebody's losing cognitive focus, they don't want to have to deal with the fact or admit the fact that there's early onset. So we have to break that barrier. We have to let them know that there's help out there, and this is a way to preempt some of the long-term struggles that people are going to be going through. So I'm asking you for your support. There is an amendment. I believe we passed it out. We have some very, very smart people behind me that want to talk about it. I'm just a pretty face. I just come up here and give you. So, and with that, thank you, Madam Chair.
I just have one question.
Yes.
So on this list, should I bring, do you want me to bring Wendy up from DHHS to walk through the amendment
Absolutely.
first?
She's really good at this.
Okay.
Yeah.
All right.
All right, thank you.
Any other questions from the committee?
Negative.
Wendy?
So many people thought last week that the red meant off, so thank you for the note. Good morning. My name is Wendy Altman. I am the Bureau Chief for the Bureau of Adult and Aging Services at DHHS. I also am a member of the Subcommittee for Alzheimer's Disease and Related Dementia. I'm here today to say good morning to the chair and the members of the Senate HHS committee and talk a little bit about how what the department's role would be if this bill were to pass and how we may implement that and be able to answer some of your questions. So Senate Bill 454 directs the Department of Health and Human Services to incorporate information related to Alzheimer's disease and related dementia into existing public health outreach programs. And the bill also directs the department to include information for healthcare providers on early detection and timely diagnosis of cognitive impairment using validated assessment tools and the use of existing resources such as Medicare mechanisms related to cognitive health to be screened. We want to thank Senator Avard for the collaboration and the partnership and appreciate the opportunity to provide feedback and work together in partnership in this bill. In terms of fiscal impact, as reflected in the fiscal note worksheet, excuse me, the department does not anticipate a fiscal impact associated with this bill. Typically, the figure that was mentioned in the fiscal impact reflects the work is minimal and can be absorbed within the existing resources that the department has in partnership between the Bureau of Adult and Aging Services and Public Health. I also want to provide some context in terms of our input towards this bill. The topics addressed in Senate Bill 454 are consistent and are in alignment with all of the themes that have been identified through New Hampshire's Legislative Brain Health Project, which highlighted the importance of early awareness, consistent public messaging, and provider education related to cognitive health. Senate Bill 454 provides that statutory direction and how those topics are incorporated into public health outreach. The bill does not expand on any eligibility for services or create new benefits. It provides that focus on awareness and education using those existing tools and systems. And I just wanted to touch very briefly on the key findings from our Brain Health Project to just demonstrate the alignment to the bill. The key findings relevant to Senate Bill 454 include early awareness being inconsistent across the state, families reporting entering the system too late in terms of planning, public health messaging does not consistently include brain health. So we found opportunities to fill those gaps, and the Senate Bill 454 helps to do that. Providers want clear, standardized messaging and tools. So we see that the findings within our Brain Health Project and the Senate bill align in terms of being able to do that. Identifying the Medicare annual wellness visits, we found that they were being underutilized for cognitive health. So making sure people are aware of that opportunity to work with their care provider. And also that early education supports planning and not what we see as over medicalization. In other words, emphasizing early awareness does not mean labeling or institutionalization. And our campaign focused on that with the individuals that were highlighted and their experience. Also, caregiver stress increases when dementia education comes late. And we want to be planful and also integrate that low-cost outreach approach, which this bill helps to do. And I'm here to answer any questions that you may have.
Thank you, Wendy. Any questions from the committee? Seeing none. Thank you. Jenny Horgan?
Good morning, everyone. Thank you, Madam Chairwoman and members of the committee. For the record, my name is Jenny Horgan. I'm the Senior Public Policy Manager for the Alzheimer's Association here in New Hampshire, and I'm here in strong support of Senate Bill 454. First, I want to also express our gratitude to Senator Avard for championing this bill for us and for his incredible work guiding us on the subcommittee, as well as thank Wendy and the rest of the department for their really thoughtful collaboration on the language in the amendment that Senator Avard has provided to you all today. Just to give a little more color and context for the need and importance to this and really build off of the important points that Wendy made, in New Hampshire, there's more than 26,500 individuals living with Alzheimer's and dementia, which, as Senator Avard pointed out, is over 10% of the population 65 and older. That number is likely higher as many individuals struggle to get a diagnosis or hesitate to seek evaluation due to fear and stigma surrounding the disease. As our population ages, the impact of the disease will only continue to grow on families, on our healthcare and long-term care system, and on the state as a whole. The Brain Health Know Early, Live Better Brain Health campaign that Wendy mentioned was incredibly successful, as she pointed out, ran from January to June of last year. And it was the first statewide initiative to promote brain health, reduce stigma, and encourage that important early diagnosis and detection. It was a public and provider-focused campaign and generated over 16.6 million impressions, exceeded contract expectations, and produced measurable improvements on public knowledge and attitudes. So now that that campaign is concluded, we want to make sure that we're really keeping that momentum going, especially as research advances regarding treatments. The FDA has approved treatments that work best in the earliest stages of the disease. And the recent US Pointer study gave information that shows that addressing multiple lifestyle and health factors, including physical activity, diet, social and cognitive engagement, and chronic disease management, can better support brain function and may reduce the risk of Alzheimer's and dementia. So the bill with the amendment builds on that progress by integrating Alzheimer's and dementia into existing and relevant public health campaigns the state is already doing. It includes educating the public on the early signs of the disease, the importance of a timely diagnosis, connections to other chronic conditions, and lifestyle interventions that can promote brain health. For providers, it will incorporate in existing outreach programs to healthcare providers information about risk reduction strategies, validated cognitive assessment tools, biomarker testing, Medicare annual wellness visits, care planning tools, FDA-approved treatments, and available resources to patients and families. So as Wendy mentioned, the importance of that awareness and understanding for the public and the provider is really vital. Two other things that the amendment does that, again, we really want to thank the Senator and the Department for collaborating with us on is it would require the department to submit a report every 2 years to the subcommittee on Alzheimer's and other related dementia to give an idea of how the progress of integrating information on Alzheimer's and dementia has gone into these public health campaigns. And then also encourages the department to pursue federal and private funding to support ongoing implementation of the Healthy Brain Initiative Roadmap, which is a CDC initiative that's been in place since 2005. So overall, this is a low to no cost, high impact step to address Alzheimer's and dementia in the state. Earlier diagnosis benefits those with the disease, their loved ones, and reduces the high long-term costs of the disease for individuals and the state. A national analysis actually shows that potential savings of $63,000 per person with an earlier diagnosis. That breaks down to $30,000 in Medicare costs, $20,000 in Medicaid savings, and $13,000 in other savings. New Hampshire is already facing the high cost of the disease. As Senator Avard well knows, over $250 million was spent in Medicaid costs for individuals living with Alzheimer's in 2025. So that's $363 million. And those costs are only expected to rise as healthcare costs and the rates of the disease increase. Awareness is vital to the public and our healthcare provider as it saves money, supports granted staters, and improves outcomes for everyone. Senate Bill 454 will increase awareness and ensure New Hampshire continues to prioritize this growing public health crisis. Thank you very much for your time and consideration. Happy to answer any questions I can.
Any questions?
Just one. It's a great committee, right?
It is a great committee. The subcommittee is doing great work. We're really excited. We're working on our state plan, a needs assessment survey. So really excited about the work that we're doing on that. And they did include this awareness in their recommendations in their 2025 annual report as well.
So I do have a question about the subcommittee. Does that need to be reestablished?
Nope. So it's a permanent subcommittee that's in statute. So under Senator Avard's leadership, we're continuing to meet. We submitted our report to the Health and Human Oversight Committee, that is the committee that we report to.
Okay.
Yeah.
Good. Thank you. Any other?
Sure. Thank you, Senator Birdsall. Always good to see you, Jenny.
Great to see you, Senator.
Just a quick question. Has an EMS representative been appointed yet? You passed that last year.
Yes.
Okay.
Yeah, so they have not been appointed yet. We've been in contact with our friends over at the EMS board to try and identify somebody, as well as working on our and to identify somebody to serve on there. So those conversations are in progress and hoping to make momentum on that.
If I can assist you in any way, let me know.
Thank you. Thank you so much.
Any other questions from the committee? Seeing none. Thank
Wonderful.
you.
Thank you so much, Senators.
Olivia? I'm sorry. Go ahead.
Okay. Good morning, Madam Chairwoman and members of the committee. My name is Olivia Parzak, and I live in Bow, New Hampshire. I'm here today to urge your support for Senate Bill 454 to make Alzheimer's disease and other related dementias a top public health priority in New Hampshire. Alzheimer's and other dementias are not just personal tragedies, they are a rapidly growing public health crisis affecting families, caregivers, and communities across New Hampshire and our nation. Every day, families face emotional, cognitive, and the financial toll of this disease, often without the knowledge, tools, or support to respond effectively. Early intervention, prevention, and public education are critical to reducing the burden and improving outcomes. I bring both personal and professional experience to this issue. With my neuroscience degree, I've spent years studying the brain, driven by my experience as a caregiver for my grandfather who passed of Alzheimer's disease. I've created programs that educate and support those affected by Alzheimer's and dementia, including programs for our youth, because I saw a critical gap, generations who do not understand their own brain or what dementia looks like. This is why public education is essential, so individuals and families can recognize early signs and act before it's too late. Education in this topic is also critical for our medical field, where 40% of primary care physicians report feeling unprepared to accurately detect and diagnose dementia in their patients, which delays care and the necessity of early intervention. Senate Bill 454 addresses both of these gaps, giving Granite State residents and healthcare providers the basic knowledge and tools they need to protect their brain. Research, including the U.S. Pointer Study, shows that lifestyle interventions like physical activity, brain health nutrition, social engagement, and regular health monitoring can reduce the risk of cognitive decline. This bill ensures this information reaches the people and healthcare providers who need it most. I watched my grandfather slowly lose his memory and independence, and I witnessed firsthand the strain it placed on my family and many families like mine. That experience drives my passion to ensure no family faces this disease unprepared. Alzheimer's is more than a disease of the memory. It is a public health crisis. By supporting this bill, New Hampshire can lead the way in prevention, awareness, and hope for families. I respectfully ask for your support of Senate Bill 454. Thank you for your time.
Thank you, Olivia. Any questions from the committee? Seeing none.
Thank you.
Leah? Welcome.
Thank you. It looks like a lot, but it's 18 font, so it's so bad. Good morning, Mr. Chairman and members of the committee. My name is Leah Farley from Hopkinton, New Hampshire. I'm here today in support of Senate Bill 454, which promotes awareness outreach to the public and to healthcare providers. I'm speaking as someone with lived experience. In 2023, I was diagnosed with mild cognitive impairment due to Alzheimer's disease. I'm leading with that because the final diagnosis was the easiest part of the journey so far. What I want to share today are the hard parts that most people never see. In December 2019, I was the owner and director of a counseling group. I'd also just started a nonprofit foundation that helped women starting over after life-changing events. I was so happy and proud of what I'd built. At that time, I began noticing small but troubling changes. I struggled to find words. Sometimes in the middle of a session, the right term just wouldn't come. I made an appointment with my primary care doctor, who told me I was functioning at a high level, but referred me to a neurologist just to be safe. The neurologist did a brief cognitive test, did not review my MRI, and told me it was normal aging. He even joked that his wife once called the oven a doorknob. I wanted to believe him, so I did. But over the next 2 years, things got worse. I forgot important conversations. I lost my way driving home from work. I sometimes could not remember the names of clients I had worked with for years, so I had a notebook on my desk to cover when my memory failed me. I would double pay my bills or forget to pay them at all. I was not okay. I went back to my doctor, who again reassured me that it was likely stress. Another neurologist said the same and discouraged further testing. But I knew myself, and I knew something was wrong, so I pushed for more answers. Eventually, after extensive testing, including brain imaging, I received a call. The results were consistent with Alzheimer's disease. I was referred for a second opinion at Mass General, where I was diagnosed with mild cognitive impairment due to Alzheimer's. The doctor advised me to get my affairs in order and learn to cope. That moment changed everything. I closed my counseling practice and nonprofit and began trying to figure out what my life would look like moving forward. Looking back, I realized how fortunate I was to have a primary care doctor who respected my concerns enough to keep referring me to neurologists, but it still took 3.5 years to get a diagnosis. Until my diagnosis, I blamed stress, I blamed aging, I blamed myself, and wondered if I was lazy, distracted, or failing in some invisible way. When I raised concerns, I was reassured. I was told that this was normal aging and that everyone forgets. So I went home carrying fear I couldn't name and shame I couldn't explain. Living without answers changed how I saw myself. I became quieter. I avoided situations where my struggles might show. I worked harder just to appear normal. I knew I was changing, and that awareness without understanding was terrifying. While this should not be acceptable, it's not unusual, especially for someone under 65. Too often, both patients and providers think of Alzheimer's as something that only happens to the very old. But every disease has a beginning, and the earliest signs can be subtle, easy to miss in a 15-minute visit. That's why early diagnosis matters. It gives people time to make informed choices, to plan, and to live fully while they can. For me, it meant I could step away from my career with integrity, put my legal and financial affairs in order, and make lifestyle changes to support my health. Today, I'm intentional about protecting my brain health. I took what we now know from the US Pointer study, and I exercise regularly. I eat well, focusing on the elements of the mind diet. I keep my brain active with puzzles and audiobooks. I prioritize sleep and nurture social connections. Most importantly, I show up for myself the way I used to show up for everyone else. I make time to sit with friends, to be outside, to laugh, to travel. My husband and I are taking the trips that we were saving for retirement because we know that now's the time to live. An early diagnosis gave me clarity, and with that clarity came peace. I no longer had to wonder if I was losing my mind. I could stop questioning my character and start addressing my health. I could accept what was happening and focus on what I could still do. Today, diagnosis matters more than ever. We now have treatments that can slow the progression of Alzheimer's in its early stages, but only if people are identified early. We also know that lifestyle interventions can protect brain health, but only if people are informed and supported. SB 454 matters because awareness changes lives. It helps people recognize when something isn't normal. It helps providers feel confident doing cognitive assessments earlier, and it spares people years of fear, self-doubt, and silence. If someone had said to me sooner, "This matters, let's look at this more closely," my journey would have been very different. A doctor friend once told me that when it comes to neurodegenerative disease, time is brain, and every delay has consequences. I urge you to support SB 454 so fewer people walk this path alone, confused and blaming themselves. Thank you for your time.
Thank you, Leah. Any questions from the committee? Seeing none, thank you. Do I hear a motion?
You want to close the hearing first?
Oh, I am closing it. I've been out of commission. Closing the hearing on Senate Bill 454.
Motion to move into exec?
Second.
All in favor, say aye.
Aye.
Opposed?
Motion to pass?
Do we need to approve the amendment?
What?
Well, right. Yeah, gonna ought to pass first and then add the amendment.
I'll second it.
All right, I move amendment
1073S.
S.
I'll second it. Any discussion? Okay. All those in favor of the amendment, 0173, say aye.
Aye.
Opposed?
Motion ought to pass as amended.
All those in favor say aye.
Aye.
Opposed?
Consent?
Second. All those in favor of consent?
Aye.
Opposed?
Can I take it out?
Yes.
Motion to move out of exec.
Second. All those in favor of moving out of consent, say aye.
Exec. Aye.
You're welcome.
All right, what's 447 here? Why is that in here?
Okay.
That's late.
Wait.
We're not moving too fast, are we? All
Your vice chair.
right. Thank you. Let me know when you're ready. You ready? All right, so we are going to hear testimony from the prime sponsor of SB 441FN. I recognize Senator Sullivan. Whenever you're ready.
Thank you, Mr. Chairman, members of the committee. For the record, I am Senator Victoria Sullivan. I represent Senate District 18, which is Manchester wards 5 through 9 and the beautiful town of Litchfield. SB 441 requires municipalities that intend to transport or arrange the transport of a homeless person or a person showing symptoms of addiction or incapacitation from substance use to another municipality for the purpose of receiving treatment, housing, shelter, or related services must first have a memorandum of understanding with the receiving municipality. Our city's taxpayers are bearing the brunt of the financial responsibility of the state's addiction crisis. I know firsthand of people who were literally dumped in Manchester by other towns. They did not have any services set up for them. They were just brought to the city of Manchester and left on our streets. It's not possible to guarantee a better treatment without a prior agreement. People from as far as Massachusetts have driven people to our state to just leave people here for us to take care of. It further provides more control over the harm reduction organizations that function within any municipality. I just handed you out a packet from the New Hampshire Harm Reduction Coalition that the state is actually funding, sending funds to. And if you take a moment to look at some of these pages with me, I'd appreciate it. The first page is their year in review for 2023. And you'll see on here, there's that little cup for warming up drugs. There's razor blades for cutting up drugs. There are crack pipes with a little heart over it. There's syringes. We know about the syringe program, but there's so much more happening that I don't think many legislators are even aware of. They're impacting our cities. The next page of that packet says, take your time, use control by taking your time, use a tiny tester amount first. You can always put in more, but you can't take it out. This is an instruction manual on how to do drugs, illicit drugs. Rotate your veins. Use arms when possible. Start low, working your way up the veins toward the heart. Avoid arteries, wrist, neck, groin, feet, and hands. Make sure you can see the hole in the needle as you inject. Shooting up, not effing up. And then it says, we are New Hampshire Harm Reduction Coalition. And if you look, they have what appears to be their drugs of choice. I mean, that's how I would interpret it. If it's not, I'd love to hear a different explanation. But you see mushrooms next to one person. You see a bong next to another person. You see razor blades next to another person. This is an organization that we are using state funds to fund under the guise of harm reduction. And on the very last page is a kit that was sent to me, a picture of a kit. Again, the warming cups. Somebody who was actually doing outreach that's in recovery in our city sent it to me. You can see the other, at the very top, the little thing with the elastic around it is the tourniquet to shoot up. He sent it to me and said, Victoria, I am out here trying to save lives and this has triggered me. Like, this is everything in my hand I need to use. And this is what we're doing to the people that are out there trying to actually do outreach and help people. We're forcing them to a situation where they have to take all this paraphernalia in their hands, in their pockets, and hand them out to people. These programs, I would argue, encourage drug use. There's nothing in these pamphlets that says get help. Nothing. And this is what they put out there and they promote. So this bill would actually let municipalities decide what organizations they wanted to operate within their town or city. Because we as a city have been told that we have, I think we can agree that Manchester has hit the hardest and we're seeing the most from this. Our first responders, our first line of defense, and they are taxed doing this. And we have been told that we have zero control over any of this, that we just have to allow these organizations to come in and just hand this out wherever they want to. They tried to hand me one of these when I was going to lunch with my husband at 11:30 on a Thursday morning, where I was heading downtown to meet him for lunch, and someone tried to hand me a harm reduction kit. And they tried to hand it to an elderly gentleman that was walking down the street who had first took it because they were standing outside of a store on Elm Street, and he thought it was some promotional item, and then he looked very confused and handed it back. So I don't disagree with some forms of harm reduction, but the first line of harm reduction is to get people to not use drugs. And nothing in here is discouraging that or giving them pamphlets for help, telling them where they can go for treatment. All of this is encouraging it, makes it look like it's a really happy, fun thing to do. And again, the city is paying the price. Our taxpayers are paying the price for all of this. We have to take the burden of much of the state. I'll think Nashua, maybe some of the other cities are feeling some of it, but none more so than Manchester. Our taxpayers are dealing with it on a daily basis. We're the ones that have to pay first responders and our departments to go clean up homeless encampments because people are literally brought there and just left there. I've gotten calls as late as 1 a.m. from somebody that said, there's somebody outside of my house. I just watched a car leave them here. They said they were here for help. There's no one to help them. And so it's not helpful to even the people that are being brought here because there is no treatment set up for them ahead of time. I'm happy to take any questions. I want to speak to the fiscal note on this a little bit. I'm not sure where that came from. This certainly does not require a full-time DHHS employee. This is an agreement that will be between cities and municipalities. If there was a provision put in there that if somebody breaks the agreement, that DHHS would hold some funds that would be used for that. I am happy to work with the committee to take that out if that's where this full-time employee comes from, because it's just not necessary in my purview. This is just to set up agreements between municipalities, but also to give towns and cities the control that they want to have over these organizations that call themselves harm reduction organizations. I know Senator Avard, when you were playing in my city, we were at a beautiful event and we found a box of needles just sitting underneath the bridge and a child found it. I've got I elevated her, Alderman Cantor here to testify on what she's witnessed as an alderman in the city of Manchester as well. So I'm happy to take any questions.
Senator Prentice and then Senator Purcell.
Rock, paper, scissors.
I called you
Okay,
first.
thank you, Senator Avard, and thank you, Senator Sullivan, for bringing this bill before us. Having been in the past a local municipal official, I can understand the pressures that shift between community and different size communities and the resources one may have versus the other. So I think you answered part of, I really have a two-part question, but the first is, how do you, if this were to pass, and I know there's a harm reduction conversation that's, that you've related to this, but if this were to pass about municipal agreements, how do you intend to, say your city or any city, inform all the municipalities about this type of, them having to have these agreements in place in order to transport somebody to a city that may have services that another doesn't have?
Thank you for the question. I mean, the same way that whenever we change a law, they find out about it, right? We've got the municipal association. I'm sure we'll let people know what's happening, but they also, you know, there are people that watch the bills that we're putting out for the cities and towns to make sure that they're in compliance of what's happening. We change laws on them all the time.
Follow-up?
Yes, well, that's correct, but it doesn't always trickle down in a more expedient manner. So there may be a window of people getting caught up in this, which leads to my second question, which you somewhat touched on already. But maybe during that time period, or if a community is not aware and somebody is brought to that community, and you talk about your hometown community, and I completely relate because I talk about my hometown community in a lot of the work that I do. Am I hearing that there is a penalty for that? What? Can you just, so you started talking about it a little bit, but can you take me there?
Yes, and to be honest with you, I just discovered this penalty myself when I was reading the bill last night in preparation. It wasn't in the intention of the original bill that I put in. So, and I don't know if that's where they came up with the fact that they would need a full-time employee for that, because these, like I said, I'm happy to work with the committee on an amendment. These agreements really should be between the municipalities, and if somebody defaults on their agreement, then the municipality should deal with it like they would do with any other contractor. And that's basically, you know, the way that I view it. So I would prefer to let DHHS stick to the rulemaking on this only, and have that be the beginning and end of their contribution here, and let the municipalities actually deal with the contracts like they would in any other way.
Okay.
Does that make more sense to you?
Yes, I mean, I think
Okay.
there's still some work to be done on this, but I understand. Yes, thank you. Sorry, Var, just one, follow up. It's more of a statement than a question, but, you know, I do some work with the Overdose Fatality Review Committee, and I saw a report on the news, I think it was last week, that was actually based out of your city on that we've seen a significant reduction. I don't want to say significant, I want to say a reduction in overdoses and overdose-related deaths, which is a major accomplishment.
Thank you for that question. So the overdose deaths, I would say there's more, may be more factual. The overdoses in general, it's just, I wish it were factual. It's just, we can't track it because we're basing numbers back to when Narcan was distributed by first responders and hospitals. That's not the case. You can get Narcan online. You can get Narcan at any drugstore. The city gives it out if you want to come pick it up. We have no idea how many overdoses are happening still. We only know what's reported, which is, and the reported overdoses are far less. I work with this community. I have a nonprofit sober home in the city. And my day job that we all have to have because, you know, the salary we make here does not cut the mustard. I work with the most vulnerable in our city. And I know that they're telling me that they've seen the numbers and they don't know how they're getting those numbers because they're seeing people overdose all the time. So I would love to see, I think that there is a trend and I'm hoping for that that's a positive thing, but we can't take today's overdose numbers and compare them to 2016 because in 2016, every first responder was dealing with overdoses. Now, any person on the street can be dealing with no overdoses and they have Narcan parties. Well, they'll make sure that people make sure that they have Narcan on hand. They come together, they all do drugs. When people start to OD, they administer it for the party and they can do this. Back in the day, the first responders, when I spoke with, went to the same house 8 times in a day to keep reviving people. And now they're just doing it on their own because again, you can get them from Amazon, the Narcan kits. You can get them, the city gives them out, you can get them anywhere. So we really don't know how many overdoses are happening. I'm glad to see overdose deaths are down, but we still don't, and part of that is because Narcan is so available, right? I'd love to see it continue to trend. I would love to see a world where we don't have any addiction and we don't have to have these conversations ever again. But comparing today's overdose numbers that we have to 10 years ago is just not accurate.
Are there any further questions? Senator Long.
Thank you, Mr. Chair. Thank you for your testimony. So is this two-part? It's on transportation and it's also on the syringe service program?
It is, Senator. I think that they are they support each other though. This is giving the
Yep.
cities more control over what's happening when it comes to addiction in their cities, but it is twofold.
Okay, and follow up if I may. The department shall do rulemaking on both. Would that rulemaking include punishment or something for somebody who doesn't do this?
Yeah, that would be within their purview to do
Okay,
that.
so the rules committee would determine both.
Yes.
Okay, great. Thank you.
you.
Are there any other questions? I did have a question. I'm sorry if you answered this when I was out of the room. But in the fiscal note, it said that one full-time compliance officer is required for this. Could you speak to that? Are you aware of that? Was that your intention to do that?
Thank you for the question. We did touch on it when you were
Okay.
out of the room. It was not my intention at all. I'm happy to work with the committee on an amendment. Like I said, I believe that might be because of the penalty that was incurred. We can take that out and have that agreement be completely just between the municipalities, which leaves the responsibility from the department solely on the rulemaking. And so I'm happy to work with the committee on an amendment for that. Because I even if that were the case with that penalty, I still don't see how it would be a full-time position, honestly, but I'm happy to take that off away.
Thank you.
as their
And we
burden.
will be speaking, I believe the department is going to be talking at some point on this. So hopefully maybe we can dig into that a little bit too. Thank you.
Thank
Any
you.
other questions? Thank you very much, Senator.
Thank you.
Call Alderwoman Cantor.
Push your button. There you go.
Thank you, Chairman and Senators, for allowing me to speak in support of SB 441. I'm Chrissy Cantor, Alderman in Ward 6. I'm a mother, grandmother, concerned citizen, property owner, and as we know, drug addiction does not discriminate, and I've been affected by drug addiction, and I believe in compassion and accountability. Today, I want to talk about fairness, accountability, and the right of our city to protect itself while still caring for people in need. For far too long, Manchester taxpayers have carried the burden of the city's addiction crisis. Our hospitals, our shelters, our emergency responders, and businesses in our neighborhoods absorb the impact day after day. Meanwhile, other municipalities quietly send people to Manchester for treatment or shelter with no agreement, no reimbursement, and no accountability. This is not fair and it is not sustainable. While addiction knows no borders, funding does, and right now the burden falls disproportionately on Manchester. There must be a financial agreement in place. If any other community chooses to send someone to Manchester for services, they must share in the responsibility of the cost. And I'm speaking specifically because I'm from Manchester, but I believe it should be the same across all municipalities. This bill is also about local control. Cities and towns know their communities best. They should have the authority to determine what treatment centers operate within their borders, what harm reduction services are appropriate, and what messaging is acceptable. One size does not fit all. What may be presented as help on paper can actually be considered enabling and more harmful than good. We have witnessed this firsthand, seeing harm reduction kits handed out like candy to random people that include spoons and warmers used to prepare drugs for injection. Let's be honest about what this communicates. That does not lead people towards recovery. It normalizes addiction and entrenches it deeper into our neighborhoods. We have seen the consequences in Manchester, discarded needles in parks, near schools, and in public spaces where families and children should feel safe. This past summer, at one of my recent music events, a child found a box of needles. This should alarm everyone. Harm reduction should reduce harm, not shift the harm onto children, first responders, residents, businesses, and city workers who are left to clean up the aftermath. Section 5 of this bill matters, it allows the city to say clearly and legally that certain organizations are not welcome to provide harm reduction services if those services are causing more damage than good. This is not heartless, this is responsible governance. This bill does not reject compassion. It says that help must come with accountability and that local voices matter and that Manchester cannot continue to be the default solution for the entire state. We care deeply about the people struggling with addiction, but we also care about our neighborhoods, our taxpayers, our families, and the taxpayers who carry this weight for far too long. Manchester should not be expected to absorb the full financial and social cost alone. Our hospitals, social services are stretched thin, and our first responders are exhausted and stretched thin as well. Just wanted to share the needle pickup statistics from Manchester PD, Manchester Public Works Department, not including all the needles that are picked up from Manchester citizens and other organizations as well. DPW employees have picked up on an average of 7 needles a day since July 2021 to October 2025. DPW employees have picked up over 11,685 needles all over Manchester. These needles left behind irresponsibly negatively impact Manchester citizens and create more harm and risk to the innocent, to the actual innocent people. We can help people recover without asking one city to carry the burden alone. This bill is about fairness, transparency, and accountability, giving Manchester the respect and authority it deserves. I'm grateful to see Chief Marr here and can't wait to hear his testimony. As we know, MPD experiences this negative impact firsthand. Thank you for your time and for caring about the future of Manchester. Please support SB 441.
Thank you very much. I think Senator Abart has a question.
Good to see you.
Nice
Thank
to see you. Thank you, Senator.
You put on a good event in the summertime. We're happy to be part of that, and I actually witnessed the needles as well. I'm just curious, as far as the transportation part of your testimony, are you able to identify what towns they're coming from in New Hampshire, and how are you identifying that, if at all possible?
They're coming from all around and out of state as well.
Okay.
When I talk to people, they don't live in a lot of them don't live in Manchester. They just came here because of the services. So it's a problem. I mean, I could personally go out and get places, but there's a lot of organizations out in Manchester that could find out exactly where they come from. You know, people are open and honest where they, they're stuck. And it's really, really sad. And I'd like to help them get unstuck. And the harm reduction that goes on in Manchester, some of it may be good, but a lot of it's not good. And it's affecting everyone.
Thank you very much.
Any other questions?
Senator Prentice.
Oh, thank you. It's Alderman
Chrissy Cantor.
Chrissy Cantor, and I served as the city council in the city of Lebanon for 12 years. So thank you for serving locally. And there are 13 cities in the state, and they all serve as regional hubs to some extent. And healthcare is one piece that we can tie amongst all of those, because hospitals tend to be located either in or close by. So as I'm hearing more about this, I just wanted to ask you a question. So this is largely about municipal agreements, but are all the services that you're talking about, because you talked about hospitals and healthcare, are they all owned or have a relationship like with the municipality?
Well, I guess I'm talking about the general overall impact when people come from other towns to Manchester, and it's the impact of all of our services. I do know that we have homeless health insurance that comes through from the state to the city to the hospitals. Is that what you're specifically talking about?
Yeah. May I follow up, Chair? And so it just strikes me, and again, I understand both the burdens and joys that come with being a regional hub. But part of me wonders that some of the, say, different organizations that you've mentioned are not all municipal. And so should these relationships be with those receiving entities versus the municipalities? And secondarily to that, and the municipal association hasn't weighed in on the fiscal note, do we know what it would cost, the cities to administer, track, and follow up with other municipalities that may be sending?
I'm
I
not
think-
too sure on that. I would definitely probably reach out to the health department.
Okay. Good. And again, I appreciate you coming forward. I'm just thinking about it from, again, a regional hub perspective. So thank you very much. And we'll have some time to talk more about this.
All right, thank you very much.
Okay.
Are there any other questions from the senators? Thank you very much.
Thank you.
Chief Marr. And then we'll hear from DHHS afterwards.
Chair and members of the committee, thank you very much for this opportunity. I'll try to keep my testimony very brief. My name is Peter Marr. I'm the Chief of Police for Manchester, New Hampshire, and I'm here today in support of SB 441. Our city has shelters, treatment providers, hospitals, and social services. Because of that, we regularly receive individuals transported from other municipalities, often because that's where the services are. I want to be very clear about what that actually looks like in practice. We have firsthand experience with police cruisers from other agencies dropping people off at our shelter when there are no beds available and then just leaving them. The individual is now stranded in our city with nowhere to go, and my officers are left to manage the situation. This is not a rare occurrence, it's a very common issue. When that happens, the responsibility immediately shifts to our police department, our EMS, our hospitals, and our service providers without notice, without coordination, and without any agreement or responsibility or cost. This bill does not prohibit transport, it does not deny treatment, and it does not criminalize homelessness or addiction. What it does is require basic coordination and accountability. An MOU ensures that before someone's transported, the receiving municipality knows who is coming, the services that are being sought, and whether those services are actually available, and who's financially responsible. It's just common sense from my point of view. From a policing standpoint, uncoordinated transfers increase calls for service, repeat EMS responses, increase overdoses, and quality of life issues. Officer time is diverted from proactive public safety to managing the downstream effects of decisions that are made elsewhere with people that they just don't want to deal with. This bill promotes shared responsibility and not cost shifting. It also recognizes that municipalities have different capacities and must retain reasonable control over how those services operate within their borders. Cities like mine already shoulder a disproportionate share of treatment, harm reduction, and emergency response demand. Finally, I'm all in favor of the enforcement provision. I think without it, it just becomes a suggestion and rather than a solution. And the goal isn't punishment, it's compliance and coordination. SB 441 protects municipalities, it supports effective treatment, and actually ensures that when people are transported places, those places are prepared to actually receive them and they're not just dumped there. For those reasons, I urge you to pass this as ought to pass, and thank you very much for your time.
Thank you very much. Senator Avard, you have a question.
Thank you, and thank you for being here. Appreciate
sir.
your testimony. I too also served as a city councilor in Franklin, and one of the things I learned in my first year was a thing called mutual aid. And with the firefighters and whatnot, that they would go in from one town to service another if there was a need. What you just described to me is that police cruisers are coming in and dropping off individuals from other municipalities from New Hampshire?
Yes, and out of state.
All right, dumb question time. That's me. So doesn't if another officer is coming in or from out of your territory, from another town, don't they have to say, hey, look, I'm coming in?
Do they have to? No.
They don't.
No, they can come in anytime. These are only I have several instances, but those are the only ones that we actually come across and
catch them in the act or come across the person who's now been stranded in the middle of the night. The shelter won't let them in because they're completely full. And we now have to figure out what to do with them, when it's freezing out and how to deal with that.
So the easiest solution is to drive into Manchester, drop somebody off without notifying anybody. That doesn't sound very fair.
No, it's not. That's why I'm here, sir. That's why I'm in favor of this. It's not fair. We do realize that we have a lot of the services. We understand that, and all we're asking for is the accountability piece of this.
So that, may I follow up?
Absolutely.
Yeah, and thank you for this. This bill gets passed, how do we enforce it? Meaning, all right, you see another officer, they're your friends, right? And they're coming in, they're dropping off somebody that they're gonna unload their responsibility onto you. How are you gonna enforce this? How is this gonna be enforced? Are you gonna say, hey, excuse me, officer, you can't do that?
Sure. So I don't know exactly how it's going to be enforced. I think it should be enforced. And I don't know if that requires whether it's the health department, whether it's the police department that they contact. And I would suggest that they contact us. We can easily do a quick report. We can follow up. I would ask that they check with, if they're going to drop somebody at the shelter, they would call the shelter, get a name of who they spoke to, and whether or not a bed was available and waiting for this person that they're about to drop off. And if that's the case, they then call us, let us know, hey, we're, anonymous PD, we're coming in, we're given, this is the person that we're dropping off. This allows us to determine who this person is. It doesn't give us a right to say yes or no, but if there's officer safety concerns, if this person is wanted, if, whatever, we can check that person, make sure that they're good to go. And if they're not good to go, or if they're a dangerous person, at least we now know that this person's now in our city.
Good final question, if I may.
Final question.
Thank you. And so I'm thinking outside the box, and I don't know if it's in this part of the legislation, but if somebody's going to be dropping off an individual that needs care and it becomes a financial burden to the taxpayers in Manchester, would a fee for service be something that would be applied? You're going to drop them off. It's going to cost us money. How about a little stipend of financial aid to take this burden? Would that be acceptable?
I think so. I think if we're able to track all of this, this is something that we can come back, we can speak on it with actual data, and that can be solved, at this level of, whether it's state funds set aside to be divvied out among the different cities that this affects, or however the committee sees fit.
Thank you, Chief.
You're welcome.
Senator Burns.
Thank you. Thank you for coming in. So a question I have, you had said that there oftentimes you'll see your officers will see the people being dropped off. So you can kind of know those are the municipalities that are doing it. But are there cases where they're dropped off, you haven't seen them, and how do you know where they came from?
We'll ask them.
Okay.
So a lot of times we'll end up, they may not get dropped off at the shelter. They may get dropped off at a 7-Eleven, and the 7-Eleven now calls because they have a drunken, disorderly person there, or somebody that's refusing to leave because they're cold and there's nowhere to go. And a lot of times, I probably shouldn't say a lot of times, there's definitely been instances where people didn't actually even know what city they were being dropped off in. They didn't know until we showed up and told them, oh, actually you're in Manchester. That happens. I mean, I guarantee you that happens. But when we do come across them, it's generally our officers know kind of who the players are out there. There's not that many people out at 2 a.m, 3 a.m. When we come across them, we're asking them, who they are. Why haven't I seen you here before? And they tell us,
Okay.
oh, we were just dropped off here by, some agency.
Okay, thank you.
Senator Long.
Thank you, Mr. Chairman. Thank you, Chief. Quite familiar with this.
Yes, sir.
So you do realize that, for example, the main officer that dropped off, this doesn't affect them. This is for New Hampshire municipalities. Of the municipalities that have dropped off, I know there was another one. How many are there, have there been?
That we know of,
Yeah.
just in the past year. Not including Maine. 5 different agencies.
Okay, and of those 5 agencies, was it a treatment facility that requested a drop-off, or was it the municipality itself that said, let's bring this person to Manchester?
I would say, I don't know that answer, but based on my experience, I would say it's the agencies taking them there. We don't have, shelters aren't calling municipalities saying, bring your people to here, you know?
Right.
That's other places bringing their.
Okay, very good, thank
Yes,
you.
sir.
Further questions? I just have something, and maybe I missed it when the senator introduced the bill, so I apologize if this is redundant. Looking at the bill here, I went through it last night. There was one thing that, based on the title and where it was in this, I'm assuming this is just targeted towards individuals with substance issues, correct? Or is it general homelessness issues?
I think it should be general homelessness issues.
Okay.
And even, well, I can't imagine, if you come across a person that's, loud, disorderly, intoxicated, and local agency doesn't want to deal with them because they're in their town, I would say it would apply to them dropping.
Let's go into, all right, let's talk about general homelessness here for a minute and
Sure.
help me through this. And if I'm missing something, tell me, I won't be offended. But there was a case that I'm close with that happened just before Christmas where I get a call on a Friday afternoon of a mother and 3 children who are in a temporary homeless shelter up north. And they have guidelines where you can be there 90 days and then you have to get out, and that's just the way it is.
Right.
They were receiving some assistance from the town. I get the call saying, can you help us out and find a place where we can send this person? So one of the places that could accommodate a mom and 3 children was a facility in Manchester. And so if they had chosen to go to that facility and they were getting help from the town up north, would you envision that that town would have to have an MOU to send that family to? Not substance use related, just pure homelessness?
Yes, that's what I would encourage that. And that could be something as easy as, you have your standard MOUs that we have with, different agencies for mutual support and mutual aid. But, I'm not a lawyer, but I don't think an MOU has to necessarily be in that form. I think it could easily be an online form that we host on our website, and people can sign up for it, agree to the terms on the MOU, and that way it wouldn't be that bit of a lift for an agency or a place like that in order to bring that family to, I'm assuming FIT is where they went. So yeah.
Yes, a families in transition.
And as long as there's actually space, that's the problem. There's not a problem when there's actually space.
Well, that's the case. We had space. They had space, and that's what we had determined. So
Yeah.
what I'm,
So that's great. That's what Families in Transition is there for, and I wholeheartedly, agree with that. The problem is when people get sent to Manchester without any sort of plan, or dropped off without any sort of plan, and it's not just Manchester. It happens in Portsmouth. It happens in
Littleton. I mean, it happens where in
all
my
over.
hometown. Yeah.
So I think the more we can do to track it and be accountable is the better.
And I guess where I'm getting at is if we've got an emergency situation where you've got a mom and 3 kids that is gonna be living in a car and, you know, the MOU process being so cumbersome and lengthy and long that
I mean, if we put a
there might be an
provision-
open bed there
Yeah.
and now we're stuck in bureaucracy to get.
No, I think if there's a provision for emergency situations, that's put in the bill, that could easily handle that. Whether you call the local agency that you call FIT, and you give them the authority to make those emergency type of calls, I think that's one way around it.
Great, thank you very much.
You're
Any
welcome,
other
sir.
questions for the chief? Thank you.
Thank you.
Jenny O'Higgins. She not here? Oh, she's here. She's in the back row.
Give her a break.
All right. Had a lot of coffee this
Not
morning,
today.
so we're chomping at the bit here.
Good morning, Chair and members of the committee. For the record, my name is Jenny O'Higgins. I am the Legislative Liaison for the Division for Behavioral Health at DHHS. And I'm here today not to take a position on this bill, but rather to provide information about the potential fiscal impacts and operational impacts of the bill. So as you have heard, this proposed legislation would require municipalities transporting individuals for housing or shelter or substance use treatment to have MOUs with the receiving municipality. We did hear from the sponsor of the bill that there may be a different intent for this not to all sit at DHHS, but in particular, when we were interpreting the bill as written on page 2, lines 8 through 12 falls under the Opioid Abatement Trust Fund rulemaking. And so that is a current responsibility of DHHS, and the additional lines added there were interpreted as the rulemaking for the actual MOUs between municipalities sitting with the department. And that piece is the reason that you'll see in the fiscal note the additional need for staff at the department. There are multiple areas here that would be challenging for the department to operationalize, since we do not oversee, individual municipalities. But we looked at this as falling to the department for that reason in the way that the bill is written. Also on page 2, you'll see in lines 1 through 3, the piece around fines being payable to DHHS directly. So in looking at those two pieces and the way this legislation is currently drafted, that's the reason for how we drafted our fiscal note worksheet. So the piece around the fines that would be paid to the department, the piece around rulemaking for the MOUs sitting with the department is the reason that we went through and kind of tried to estimate if we were able to implement this, although again, operationally, it would be extremely difficult for the department to implement, that we would need both an IT system to track complaints, investigations, and fines, as well as additional staff to manage the compliance, the investigations, and the enforcement across all of these different MOUs. There are over 300 municipalities that we would then need to be monitoring and overseeing in this program. So there would be significant change in workload from what DHHS does today. And there are not new positions authorized in the bill, but would be necessary if this is meant to stay sitting with DHHS. And as you all are very aware, DHHS budget is not able to absorb these costs at this time. And so again, we just wanted to provide some estimates and assumptions to assist the committee in understanding these potential fiscal impacts, and would also be happy to take any of your questions.
Are there any questions of the committee? Senator Birdsall.
Thank you, and thank you for coming. So I understand that there's going to be a fiscal impact, and I know it might be a little bit difficult, but overall, we have municipalities that are we have other states as well as municipalities dropping people off into Manchester, which is hitting their budget, which is going to be hitting your budget. So isn't there kind of a cost benefit analysis there?
From the perspective of DHHS, our systems of healthcare infrastructure and substance use disorder and behavioral health, mental health are statewide. So they're meant to be accessible to people when and where they need them. So the services are not on an individual municipal level from the way that we implement them at the state. I understand the concerns raised today by municipalities, but we don't have that kind of local oversight.
Okay, thank you.
Senator Long.
Thank you, Mr. Chairman. Thank you, Jenny. I'm looking at the effective date of July 1st, 26. If this passes and the governor signs it in June, you have a month to come up with the rulemaking, the added person you may have. Would it be beneficial moving that to another date further, a January of 27?
Yes, I think there are other operational concerns as well. So the effective date would be concerning, but I also believe that how we would actually implement fines would be concerning. If the fines were not paid, how we would follow up on that would be an operational challenge for the department. It's not something that we currently do, nor do we really know if it's fully allowable for the state to then oversee these municipal relationships. So I think we'd need significant time to investigate how we would operationalize this. The estimates were really just if this were to be passed and become effective, an estimate on what we would think we would need in order to implement, but there are multiple concerns, including privacy and security concerns around who is being, moved to and from cities, how is information shared. There are specific ways that we protect privacy and behavioral health and that are extremely stringent around mental health and even more so with substance use disorder. So I think there's multiple layers here of how we'd need to look into how we could even implement this. The fiscal note is just to give you some idea of if we were trying to stand something like this up, we would certainly need additional positions. And especially because it's not mimicking something that we already do in our business today.
Okay, very good, thank you.
I've got a question. If you could repeat again, you mentioned it's Section 2 opioid abatement trust fund. You made a statement about that, and I missed that. I wondered if you could just repeat that.
Yeah, sure. It's just that we currently, that rulemaking falls to the department. So that was the reason that we interpreted the bill as sitting with us, because the rulemaking authority here sits with the department in this statute. And so when it adds then that we would adopt rules regarding the transportation of individuals and with substance use disorder, and the rules would include the enforcement of the MOUs between municipalities and the financial liability for such services, that section all falls to DHHS to adopt those rules. So as I heard the sponsor introduce the bill, I thought I heard that was not necessarily the intent, but that is how we interpreted the bill as written.
Because of the section that was in.
Yeah.
Yeah, okay, all right. I got Senator Birdsall and then Senator Abart.
Thank you. Thank you for taking my question again. So if DHHS doesn't see it in their purview, what would stop the municipality, let's say of Manchester, from putting in an ordinance of requiring an MOU in order for individuals to be dropped off?
So I don't know that there is something, I'd have to look into whether or not there was anything that would stop them from doing so. I don't believe that they have ordinances in other sections or areas of this bill in addressing syringe services programs. And Manchester adopted their own ordinance on that in 2024, even though there is a state law that authorizes that. So they may be able to do so. I do think, again, though, our healthcare infrastructure is such that every city and town does not have available substance use services, homeless shelters, hospitals, right? They are in more resource dense areas of the state. And so just taking into consideration how we access care if we don't live in one of those resource dense areas, I think it's a complicated issue.
Yes.
But that doesn't authorize them to drop people off into Manchester and then have Manchester pay for it.
No, I'm not suggesting that it does. Just thinking about the infrastructure of how we access healthcare. I receive my healthcare in Manchester, but don't live in Manchester. So I often, shop and eat and play in Manchester and receive all of my health care there, but it's not the place where I live. So just thinking about how do we think about the complexities of where we receive care versus where our residence is.
There you are.
Thank you. Thank you for your testimony. I'm just trying to wrap my head around who would be, if we struck out that section 2 on page, or the section 12, line 12 down, and we got rid of the rulemaking authority for HHS, where would rules come from? DOJ?
I'm really not familiar with how municipalities would enter into memorandums of understanding with one another. I'm sorry, I'm not able to answer that.
Yeah, okay.
I think what I know is that it's probably not us.
Right, then who? Okay.
Yes.
Somebody's got their cookie hands in the.
All right. Any other questions? Oh, Senator Prentice.
Thank you, Chair Rochford. And Jenny, this might not be for you. I think it's probably for the Municipal Association, but it just struck me that, we have agreements between municipalities, intergovernmental agreements already for things like, and I'm not making, a comparison, but say like a water supply that one community has that another doesn't. So there's an agreement for that. So I don't know, so I'm just getting this on the record now so I can follow up on it, but I'm wondering if the existence of the ability to already do that would allow for this kind of agreement to already take place without necessarily passing a law to do it. But I don't know what the scope is of all the intermunicipal agreements. I just dealt with them on about, again, water supply would be the one that comes to the top of my head.
Yeah, I think that there are probably other types of programs that you could look to in here, but it's certainly not the behavioral health expertise that I'm bringing to the table today. And so I'll stay in my lane on that and say I'm not sure. And I do think, though, that there's some complexities here, again, to bring up the specific pieces around mental health and substance use disorder and privacy and where treatment is located in the state. Is all additional things that we'd have to think about that may offer a different type of complexity than a water supply MOU might offer. And if there's some work that needs to be done around that, we'd be happy to be consulted in any way to weigh in on specifically, good quality access to care for folks to get well. Since we have seen reductions in behavioral health challenges in the state, we want to make sure that we're carefully kind of keeping our foot on the gas on the work that we're doing there. And I wonder too, in some of the language in here, that there is a section that says that it does not apply to emergency medical transfers or law enforcement with court orders and pieces like that, that may also not be getting to the heart of the why that we heard through other testimony today. So it's worth looking into, is this the solution to the identified problem?
I'll take that to NHMA. I just wanted to get it out there. Thank you so much.
Thank you.
They're long.
Thank you, Mr. Chairman. Again, thank you, Judy. The opioid abatement trust fund. I know Manchester reduces the tax burden with this trust fund. Do you know if this trust, for example, if Manchester wanted to do an MOU with Concord, could we agree with Concord that we would use our abatement trust fund money in servicing this person?
So this RSA listed in this proposed bill is talking about the opioid abatement trust fund at the state level. And the cities have opioid abatement fund dollars that are different and separate and distinct. And so it would not be within this RSA that you would be able to do that, but you could certainly investigate the ability to do that with local trust fund dollars.
Great, thank you.
You have another question?
No.
Oh, yes, it was. Any other questions? Thank you very much.
Thank you.
Always a pleasure. Jake Berry.
Can I see your schedule?
Good morning, Mr. Chairman, honorable members of the committee. My name is Jake Berry. I'm the Senior Vice President at New Futures. As I hope you all know, New Futures is a nonpartisan, nonprofit health policy and advocacy organization. We've been working for nearly 30 years to address substance use and behavioral health issues in our state. I don't want to get too much into what others have said today. I do want to stress our strong questions or concerns that we have about this bill. Regarding the MOU provision, we're very concerned about what would happen to individuals seeking substance use treatment in communities that do not have MOUs in place as required by this bill. Certainly, we know best practice shows us that when people present and they are ready to engage in substance use treatment, we have a very, very short window of time to capture them, to engage them in the treatment process. Any hurdles that are erected, any bureaucratic challenges that are introduced, such as this, really could severely impact these people's access to treatment and the success rates that we have for individuals in treatment in ways that would lead to negative health outcomes and further costs on taxpayers as we have to deal with the fallout from that. But mostly I want to speak about the harm reduction provisions of this bill. Our harm reduction providers are harm reduction is absolutely key, critical piece of our substance use treatment network that we have worked so hard to establish in the state, and that, as noted earlier, is working. Our overdose rates are declining rapidly. We are, half of where we were just 3 years ago. And that certainly is because of Narcan, it's because of the expanded access to treatment, but it is also very much because of the harm reduction programs that we have put in place. Our harm reduction programs are, for the most part that I'm aware of, they follow best practice, they follow evidence-based services. We'd be very concerned about anything that would allow municipalities to infringe on the way they communicate and the way they deliver their services. We know that most of our municipalities, they're well informed, they are engaged, and they want to do best, but they are not service providers themselves, and sometimes they are unaware or unable to access best practice and evidence-based standards, and anything that would allow municipalities to really infringe upon these services, these critical services, we fear would blunt their impact and would ultimately lead to more overdoses and more overdose deaths. It would undermine the work that we have done and send us backwards as far as the progress we've made. So we would ask you certainly look very seriously into this bill, consider unintended consequences that we fear could result. And we would love to work with you in other ways to strengthen our service system and continue to address the addiction crisis that we are facing. I'm happy to take questions.
Senator Abard.
Thank you, and thank you for stepping up and testifying. You mentioned best practices, but from what I understand, the form of best practice from other towns is just dropping people off in Manchester without any accountability. That doesn't sound like best practices.
So I can tell you, before heading into this hearing, I spoke with a number of treatment providers in Manchester and in Nashua. That was not their experience. Over the many challenges that they faced, they did not believe that people being dropped off in town was one of the primary ones. Certainly, I know it certainly sounds like the experience of Manchester Police may be different. I didn't speak with Nashua Police, but among the treatment providers, that was not a primary concern that they faced.
Are there any other questions? Senator Long? Oh, you had your light on. I didn't know if you were. Very good. Thank you very much.
Thank you all.
Jennifer Chisholm.
Oh, good morning, Chairman and members of the committee. My name is Jennifer Chisholm. I'm the Executive Director of the New Hampshire Coalition to End Homelessness. And so I am here excited to know that we're having conversations about collaboration for care and coordination of care. However, we do have concerns and do oppose this bill. So I did not come prepared, or I came prepared with testimony to speak specifically around people engaging in substance use treatment who are presenting at a municipality, and did not come prepared to speak about harm reduction, which I am a supporter of as an MLADAC and somebody who's been an outreach worker and first responder in the state. So my concerns to begin with is just around the barriers that it would create for people who are seeking substance use disorder treatment. So the bill would allow receiving municipalities to place limits on the number of individuals to be transferred to that town, meaning that individuals who need transportation assistance could be denied access to treatment by municipal leaders who are not qualified to determine whether the program in their town or city is actually the most clinically appropriate care for an individual. And so there are many different types of modalities of treatment for substance use disorder across the state. And so we want to just make sure that somebody is placed in a program that meets their individual's treatment needs, even if there's somebody who requires transportation assistance to that program, and that should take priority over what town or city the treatment program is located in and how many others have previously gone there from their town of origin. And so, as I said, I'm clinically licensed. I am a LICSW and LADAC, so I have my mental health license and my drug and alcohol license. I worked in Manchester, where I live and am an enthusiastic taxpayer and resident in Ward 2 in Manchester. And I've worked there 20 years, over 20 years as a social worker. And so it also really concerns me clinically that SB 441 could delay treatment or access to treatment for somebody, again, who's actively seeking help but just cannot provide their own transportation. And so we know best practice is that when you have somebody who is in action about their making positive change in their substance use, that you want to strike while the proverbial iron is hot, and take that moment. And so as the bill is written, an MOU would need to be signed before being able to transition that person into treatment. And so that could really close that window of opportunity for somebody who's actively seeking help. And so we want to make sure that that is not a barrier for somebody to access care. The other thing that I'll say is that we're concerned about just the administrative burden that this could create. And so as written, the bill specifically refers to homeless individuals or other persons showing symptoms of addiction or incapacitation from substance use. And so that can put municipal employees who are not trained in the assessment of substance use disorder in a position where they're having to take a look at that and make what I would call a clinical decision around how somebody is presenting. And so the other piece, and Jenny O'Higgins referenced this, that I was thinking about, and it wasn't clear from my reading of the bill, but thinking about the information, reporting, monitoring, tracking, and what sort of information would be collected. So as an MLADAC, I live in the world of having to think about the federal confidentiality laws that surround any kind of substance use treatment. So 42 CFR Part 2 is the name of the statute. And so it is kind of in parallel to HIPAA and deals specifically with substance use disorder treatment and the information around protected health information around that. And so it is a complex and quirky law. And so if municipalities are going to be tracking any sort of information that is considered protected information under 42 CFR Part 2, it becomes a whole nother ball of wax in trying to develop systems and a knowledge base of how to handle that information. And so again, unclear about what kind of information would be reported or tracked, but just know that that is a whole nother set of complexities that municipalities might need to deal with. And then in setting up the systems, making sure that the protections of that information are in line with the very complex statute. And so we just believe that the unintended consequences of this bill would prevent people from accessing care in a timely manner. And I appreciate your time, and I'm happy to ask or answer questions.
Yeah, Senator Abard.
Thank you, and thank you for your testimony. So you mentioned, there are a lot of barriers that this could potentially have. What is your solution? Do you have an idea of how we can solve this problem? It almost sounded like we're having two different conversations with what I'm hearing with the police officer and the alderwoman, and the prime sponsor, and your testimony, in that people are just being dropped off. And the officers seem to say, we just want, we want to know who's coming in, and basically from officer to officer, not necessarily anything on the individual per se, but they don't want to be blindsided by this. And there is a financial burden that particular municipality is having to shoulder versus the other ones that are saying, no, we don't want to deal with this, in layman's terms. How would you help us solve this problem?
Sure. Well, and as I said before, so my testimony really kind of focuses on the people who are actively seeking treatment and so are being transported to a point of care as opposed to somebody who might just be dropped off at the 7-Eleven, as Chief Mara indicated. And so that can be an issue. I will say kind of anecdotally, so I worked for the Healthcare for the Homeless program in Manchester for over 10 years. I was the behavioral health and outreach coordinator for that program. And so at one point, sort of in the middle to end of COVID, we started taking a look with other outreach teams to try and figure out exactly, because that has been a concern, right, of how many people are being served in a specific municipality from outside the municipality, and at that point at least. And so I know that, again, Chief Mara may have updated data for that, but anecdotally, the numbers of people who were not connected to Manchester in one way or another were very small. And actually, national data shows that people end up in communities that they do have some connection to. And it is challenging. Hub cities have more resources. And so if I'm coming from some place that doesn't have, the recovery supports in AA and NA, that I might end up staying there because it's going to support my recovery in the long term. So it is a complex question, I will say. Yeah.
Any other questions? Senator Long.
Thank you, Mr. Chairman. Thank you for your testimony. It's a good point. So just to be clear, these MOUs, if they were for substance use disorders, would have to be confidential.
Yeah, as I said, 42 CFR Part 2 is quirky and complex. And so we would just want to make sure that municipalities are looking at whether or not the information that they're collecting, tracking, monitoring, reporting on falls under that law.
Okay,
So,
great. Thank you.
Any further questions? No, thank you very much.
thank you.
We have Steve Tower next.
Good morning. I'm Steve Tower with New Hampshire Legal Assistance. I am the managing attorney of our Manchester office, and I am our director of our local welfare project. So as I read this bill, there are sort of two issues that are being addressed by the bill. One is the regulation of the harm reduction programs. I have no comments on that. My comments are primarily on this section about the MOU requirement and the penalty that can be imposed. And my comments on that are related to my concerns about how that affects the local welfare process throughout the state. And I am actually excited to testify about this because hearing Chief Mara's testimony, some of the concerns that he expressed, people being dropped off with aimlessly at a 7-Eleven, that is absolutely outrageous. And I understand why the chief is concerned and wants a solution to that. I'm not sure that this is the best way to do it. And I actually think that we can probably come up with a solution that I think we would all agree on that. So as this is written, it requires an MOU between a sending town and a receiving town for any homeless individual or person showing substance abuse or addiction when being transported for the purposes of receiving housing, shelter, addiction treatment, or related services. And so the situation that was described of someone being dropped off in a business parking lot, they're not being transported for the purposes of receiving housing, shelter, or addiction treatment. So I think this bill would not address that particular outrageous behavior. And my concern about how this impacts local welfare administrators is there's no requirement that the receiving town enter into an MOU. It is required that the sending town obtain one with the receiving town, but there's no obligation on the other side there. And as you are well aware, under RSA 165, towns' welfare administrators have a duty to relieve and maintain people who are poor and unable to support themselves. And the major need for that program when people are seeking assistance from the towns is some sort of rental assistance or shelter assistance. And many municipalities across the state don't have access to shelters. They don't have access to transitional housing. They don't have affordable workforce housing in their small towns. And so to be able to comply with their statutory obligations, towns are required to maybe provide shelter through a family homeless shelter that's in Manchester, or a transitional housing program in Keene, or any of these other larger municipalities that have these services. And it is a situation that sometimes occurs, that a local welfare administrator from a small town, who maybe their primary job is they're the town clerk and they have a couple local welfare cases a year in this small town somewhere, and they may be unfamiliar with their requirements and obligations under the law, and they'll send someone to Manchester and say, well, there's shelters in Manchester, you'll be fine. But from my perspective, that is not lawful activity from that town. They are required to relieve and maintain, and just sending somebody to a town and hoping they'll obtain shelters isn't meeting their obligation. And under existing law, under RSA 165, the person who is being sent to receive shelter or housing in another municipality, they retain residency of the town that sent them for until 30 days of them self-supporting and paying for their own needs. And under RSA 165, the local welfare town that is sending the person, where the residency is maintained until the person becomes self-sufficient, they have the ongoing financial burden of meeting those costs there. There is a little bit of a frustration sometimes, where if the local welfare town that's sending somebody to Manchester decides that they don't feel that they are financially responsible under the law, as the law says, they might not cooperate with Manchester local welfare to continue paying for those services. And there's a bit of a gap about how that problem gets resolved between two towns, where one of the towns, the sending town, is not being fully cooperative. And I've had discussions with the Local Welfare Administrators Association about how to fix that problem, so that, in this case, Manchester would not be getting stuck with the bill for someone who's being sent to a motel for a week in Manchester, and then the other town says, well, they're in Manchester now. And I think there's a good solution that we've worked out there that I'd be happy to share with the committee. But this section about imposing a $5,000 fine for any town representative that sends someone for shelter without getting an MOU, that could in effect make it impossible for towns that do not have homeless shelters or affordable housing in their town to meet their local welfare obligations. I think resolving the financial burden of that person who's being sent to the other town under the existing law, with a slight tweak that I could suggest to that existing law, is a better way of addressing the local welfare aspect of it. But there's also, as Chief Maher described, it sounds like there are times where a municipal police department may drive someone to Manchester or Nashua. And if that person didn't apply for local welfare, that is a separate situation, and perhaps limiting this sort of MOU to a police department that acts without a local welfare action might be a way of addressing that.
Just a quick comment. You said you have language that you could send us that might address that. If you could please send that to Sophie, and
Right.
she'll
I would be
distribute it
happy
to the committee. Thank you.
'Cause I think it's a great solution, personally.
Senator Abar.
Yeah, thank you. And I think you're really tapping into what I was trying to get at earlier, and I spoke with the prime sponsor on this, and I think the solution, I don't know if and I could use crude ways of saying it, but like maybe a co-op from other towns, from saying an agreement saying, look, if I have somebody, I'm going to have a stipend of, say, $500 or $200 or whatever that could be, based upon your actuary, what you've experienced in the past of cost of housing somebody. I didn't know that there was a 30-day obligation. So my question is that in line with what you're thinking of? Whereas if a town says, look, we can't house this person, there's a fee that we can pay for the city of Manchester to take this person in for 30 days. Is that in line with what you're saying?
So if I may, I can sort of explain how the law currently works, where the gap in the law is, and what my solution to it would be. And I'll try to be quick about it. So under the existing law, if say a family becomes homeless in Candia, there's not a homeless shelter in Candia. So Candia, the family applies for local welfare assistance with Candia Local Welfare. They say, yes, we will help get you into a family shelter. The nearest one is in Manchester. So we are placing you in the family shelter in Manchester, and until such time that you are self-supporting without assistance from the homeless shelter or the municipality for 30 days, you're our financial responsibility under the law. You retain residency here in Candia until you leave the shelter and are on your own for 30 days after that, or you are paying for an apartment for 30 days on your own in Manchester. And at that point, after 30 days of the family self-supporting, after they've been getting help from the shelter for maybe 3 or 4 months, during that whole 3 or 4 months, they still are a resident of Candia. If they're in a motel for 3 or 4 months being paid for by Candia, they remain a resident of Candia while they are in that motel provided by local welfare. And it's only after 30 days that they are not getting assistance from the shelter or local welfare, they are on their own for 30 days, then they become a resident of wherever they are. The current gap that I see in the law is where there is a dispute about where residency initially exists. The process for that being resolved is either voluntary mediation between the two towns or a lawsuit. And of course, towns are very reluctant to sue their neighbors, understandably. And so there are situations where a town might incorrectly think that, well, I sent you to the shelter in Manchester. You're a resident of Manchester now. I don't have to help you starting tomorrow because you're now in Manchester. That's incorrect under the law, but they may be mistaken, especially if it's a small town and they're maybe not an expert in the law. Or there could be situations where there is a genuine dispute about residency. An example might be someone gets evicted from their apartment on Thursday afternoon in Candia, and they spend Friday, Saturday, and Sunday in a motel in Manchester. Candia Local Welfare may be closed on Friday. So on Monday morning, they go to Candia Local Welfare and apply for assistance. And Candia might say, well, you don't have an apartment here, you're not living here, you have no permanent connections to Candia anymore, and you're in Manchester, so you're a resident of Manchester. And Manchester might say, you have no permanent residence here, your last permanent residence was in Candia, we believe that your residency is in Candia. And they could both be acting in good faith and genuinely believe that, but there's a dispute. And in those situations now, sometimes the family gets sort of caught in the middle, and ultimately at the end of the day, if Manchester ends up helping that family, they might feel some frustration where they feel that really this is a family from Candia, Candia should be paying for it. And the solution I have suggested and talked to Mr. Marsh and the other folks at the Local Welfare Administrators Association is creating a process by statute that is a fair hearing process, which already exists for applicants of local welfare who have some disagreement with the town about what services they're eligible for. And to allow two towns who have a disagreement about residency to have a brief phone call with a impartial third town local welfare administrator as a hearing to decide where the residency occurs and have that decision be binding on the two towns. I don't think it would cost towns anything more than a 10 or 15-minute phone call, and it would resolve this issue, and it would ensure that a town isn't getting stuck with the costs of a family where their residency is somewhere else. And so I think that that is a easy solution to that sort of problem.
But
follow up.
Yes, in your testimony though, you said, if I heard you correctly, that for them to just drop somebody off at 7-Eleven and take off, that's illegal.
If local welfare does it, someone walks into the local welfare office and then sends them to another town with no shelter plan in place, they are not relieving and maintaining that person under the state law because they have a duty to shelter them, and just sending them to 7-Eleven certainly isn't sheltering them. So in those situations, if that family that gets dropped off at 7-Eleven calls me, we call the town and advise them you can't do that, and if they don't do what they are supposed to and shelter that person, we consider legal actions against that town. And I believe that this residency process that I described would determine for certain where that family that gets illegally dropped off at 7-Eleven can get assistance, perhaps immediately from Manchester, but Manchester can, through this process, recover the cost of doing so from the town that dropped them off at 7-Eleven.
But if I'm.
Yeah, absolutely.
So if the police of Manchester sees another police officer from Candia come in and dropping somebody off and then taking off, but they catch them doing that.
Yeah.
What's recourse for them to do? I mean, and it's not welfare related, whether, then.
Yeah.
Is that a crime? Is that punishable with a fine? How
I
do we give them justice on this? Because it's not fair.
Yeah, I agree that when I was preparing my testimony, I was not thinking of that situation because in the world that I live in, it's usually local welfare that is sending someone to another town. But if a police department is doing that without, a local welfare application, I think maybe requiring an MOU like this between police departments who are acting without a local welfare determination or something like that would be a reasonable solution in that situation. Because the solution that I just proposed would not address, say, Candia PD picking someone up who's drunk on the side of the road and acting erratic and dropping them off in a different town. Sounds like kidnapping to me, but
Thank you.
Thank you so much, and I'll circulate that language with you.
Yes, please do. And Sophie can, and actually, are there any other questions? Senator Long, don't go anywhere.
Sorry.
I'm not sure if if you could answer this, but with respect to the MOUs, is it the governing body that would approve that?
Let me take a look at how it is. I don't think the bill explicitly states whether it would be the governing body. I imagine there's language in here about DHHS adopting rules regarding the transportation, so they would probably establish how that MOU would have to be worked out. And I imagine the governing body could probably delegate that to police chief or something like that to work out that MOU. My main concerns is that I think it would be inappropriate for this to apply to local welfare cases, but a case where a police department is acting on their own, I think that it's not an unreasonable solution.
Okay, thank you.
So the last person we have signed up is Todd Marsh. Todd, you have the distinct position of being the person that stands between us and lunch. So
Excellent. Well, it's a pleasure to spend the morning with you. Pre-lunch. I will go as slow as I can. No. No. All right. So my name is Todd Marsh. I am a resident of the city of Somersworth who does have a low barrier overnight warming center. I am the welfare director for the city of Rochester, who considers itself a hub as well, not to the extent of Manchester, but we are not a small town. We do have a shelter. We do have substance use disorder centers and so forth. However, I am testifying today as president of the New Hampshire Local Welfare Administrators Association. Our association appreciates this conversation. Also, we appreciate thinking differently about municipal services. It is clear this bill was drafted with good intentions, and we recognize that. However, SB 441 carries significant unintended consequences as currently written. for a problem that does not exist at the scale requiring these legislative changes. Because this bill targets a financial problem not reflected in municipal reality, we respectfully urge the committee to report SB 441 as inexpedient to legislate. Why? Our opposition is based on 4 reality checks. And some of it, by the way, was already covered, but please forgive me and let me continue here.
And covered already.
I'll try not to. I'll try not to. Yep. A solution for a problem not reflected in data. While there may be thought suggesting a need for the bill, not one municipal welfare administrator reports the transport of cost issues this bill seeks to counter. Furthermore, existing law, RSA 165, already dictates placement in a shelter or substance use disorder center, hospitals, correctional facilities, and so forth, does not constitute residency. And that was covered. I appreciated that. Does not constitute residency for the duration that they're in a homeless shelter and 30 days afterward. Okay. Now, harm reduction seems to be the focus in some of the testimony. However, as we know, the challenge is in the details. In this bill is much broader than the harm reduction testimony. Fiscal consequences and government expansion. The fiscal note created indicates a potential new position at DHHS, $5,000 fines against municipalities, also language suggesting MOUs include payment for some or all, I'm quoting, payment for some or all treatment or service costs. Substance use disorder programs are typically nonprofits, receiving an eclectic mix of federal, state, and private funding. They are not operated by, as you know, they are not operated by municipalities. Language that suggests local taxpayers fund these specialized clinical services simply because a person crossed a border, a town border, is a significant and unnecessary shift in municipal responsibility, potentially creating a double payment scenario for services already funded by federal taxes or state revenue. Drop-in drives, right? Yes, drop-in drives are unacceptable. And we have been, as a welfare association, we have been working with the municipalities across the state. We do have a best practice guide for welfare departments. It's in our, we train on it, it's on our website. Drop-in drive certainly is not part of the best practice. We need to confirm that a placement is available at a shelter in Manchester or whatever municipality we're sending people to, okay? And not just hope or assume that they're going to have availability. That is wrong. We absolutely condemn that. Impact on routine public transit. In Rochester, individuals approach our office for public transportation tickets to self-navigate to the warming center in Somersworth that I spoke of. They come in, I'm here for a bus ticket. Oh, where are you going? I'm going to the warming center. It's usually a 1 or 2 minute discussion, okay?
Bless you.
Gesundheit. Under this bill, handing over a public bus ticket to someone seeking their own placement could be interpreted as arranging transportation, necessitating a formal MOU and a mandatory substance use disorder assessment. And please be mindful of the language in there, requiring municipalities, municipal workers to assess a person for substance use disorders. Okay? This turns a 2-minute interaction into a complex legal and clinical requirement. The risk of delayed services. Determining symptoms of addiction or incapacitation through a substance use disorder assessment is not always feasible for municipal welfare or municipal employees in general. Symptoms are not always apparent during brief interactions. And even longer engagements may not present obvious symptoms for a non-clinician. Would we be fined $5,000 for getting it wrong? Most importantly, this potential increase in bureaucracy creates dangerous delays. When an individual is finally ready for treatment or shelter, timing is everything. If we jeopardize transportation with mandated paperwork or financial negotiations, we risk a changed mind. A delay in the moment of readiness can result in changed minds and unchanged lives. While this unintended consequence of the specific bill outweighs the perceived benefits, our association is looking forward to collaboration with senators to solution find for the known challenges that face our communities. I will stop there.
All right, any questions? Thank you very much.
Happy lunch.
Anyone else that would like to speak on Senate Bill 441? With that, I'm going to close the hearing. I've got 1 o'clock. Do you want to do a quick exec session?
Motion to move in exec.
Do I have a second? All those in favor say aye.
Aye.
All right, so we've got 608, which was Senator Waters' bill. And we got an amendment last week. He circulated another amendment this week, and this amendment that's coming around was a request, was done in collaboration with DHHS.
A motion ought to pass on the bill. So you can talk about the amendment.
Yes, so the motion is ought to pass on the bill. Do I have a second? I'll second that. So the amendment, so we're gonna have 2 amendments. Actually, no.
How many do we have? Amend the bill by.
You got 145, right?
And that's the one that we just got handed out, was 145. Oh, I guess 0089S was the other one. Oh, I got that right there. Yeah, okay, all right. So does 145 take the place of 89? It looks like it probably does.
Don't have the other
Which one do you not have?
one. The others.
You have 89?
Yeah. If I may, Mr. Chairman, I believe 89 was January 13th. The 145 was January 16th, both by Senator Waters.
Yes.
So
Yeah. Yes, look at that.
Amend the bill by replacing all after section 4 with the following, and the newest one does that as well, so I would think it was replace.
Yeah.
So one,
Replaces the one that he said.
correct. Okay. So I will move amendment 20260145S.
Second.
All right. Any further discussion on that? All right. So the motion is ought to pass as amended? Oh, yeah, all right. So the motion is ought to pass amendment 20260145S. All those in favor say aye.
Aye.
Any opposed?
Motion to pass as amended.
Second.
You guys are gonna have to play rock, paper, scissors over there.
You can have
All right, so that's Prentice, Avard made the motion, OTPA. Prentice seconded it. All those in favor say aye.
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 Any opposed?
Consent.
Motion to consent. All those in favor?
Aye.
Any opposed? Motion is, so it's on consent, and I will ask Senator Avard to take that out.
Motion to move out of exec.
Second.
All those in favor say aye.
Aye.
Any opposed? So we will recess until 1 PM.
District 17, and I'm here today to introduce Senate Bill 506. So this bill is seeking to get us in compliance with the work requirements from the federal Big Beautiful Bill Act that passed. But I have several talking points on it, but before I go too far, I do want to say that I'm going to ask the committee to hold this bill for as long as you can, because we were successful in putting the same language on a retained Senate bill that was in the House, Senate Bill 134 from last year, and they have essentially adopted the language we want. So as long as that bill tracks forward, like I think it's going to come back to us the way we want it, and, you know, the Senate is agreeable to that language, then this bill won't be necessary. But I can quickly run over the bill and what it does do, and I know there's a couple other folks that are going to testify. So this bill would, as I said, it would get us in compliance with the requirements for the federal act. So on or before December 1st of 2026 or an earlier date, within 30 calendar days after publication of a federal application template, DHHS shall submit to the Center for Medicaid Services required documentation relative to implementing community engagement and work requirements as a condition of the granted advantage eligibility in accordance with the One Big Beautiful Bill Act. Secondly, it suspends and deletes the provisions of RSA 126AA2 directly related to the community engagement and work requirements for the duration of the federal community engagement work and work requirements under Public Law 11921, Section 7119, is in 2025 as amended. So I'm going to let, excuse me, I know Director Lippman is here. I'm going to let him talk to more about the details, but I just wanted to give you a quick overview of what the bill does. The main takeaway is it'll get us in compliance with the feds. And again, my ask is that you hold on to it.
You got it? Questions? Yes, Senator Long?
Yes.
Senator, do you have the number of the bill in the House that we're looking at?
It was Senate Bill 134.
Oh, Senate Bill 134.
Yes, that we passed last year out of the Senate, and then it went to the House, they retained it, and then they've amended it. Essentially, we gave them the same language, and they amended it on the House side.
Okay.
So it'll be a little bit faster track.
Thank you.
You're very welcome.
Seeing no further questions?
All right, thank you.
Thank you. Henry? It says here you're in favor of this bill.
I am.
Okay.
We actually appreciate the work that the Senate and the House have done on this bill. I think most importantly, it allows us to implement it using a state plan amendment as opposed to having to do an 1115 waiver, which I think accomplishes two things. From a timeliness standpoint, it will allow us, I think, more realistically to comply with the very tight time frame of for, December 31st of 2026. We have to be ready, and there are system changes and things that have to be made, and 1115 waiver can take more than a year sometimes to get. And CMS had communicated to us that the state plan option would be much more efficient. And on a budget standpoint, it comes with less administrative costs, and those administrative costs can run into seven figures. So I think in terms of being able to do it flexibly and timely is a really important part what the bill does. I think it also allows us to be consistent with the federal statute and rules and regulations that come out, which I think, again, will, I think, make it clear to those who are subject to the requirement and also consistent with how other states will be needing to approach it. I think the other thing that it does for those people who worked hard on the original work requirement bill in 2018-19 period, it suspends that legislation as long as federal legislation is in effect. So I think it respects the work of the prior legislature as well. And I agree with what the senator suggested as a course of action for you.
All right. Thank you. Senator Long, any questions? No? We're good?
Thank
you, Henry. No further questions. Jim Monahan, not in favor, not against, not speaking, but you signed up. You just checking anything. So I think you're ambivalent about the whole matter, I imagine. Welcome.
Thank you, Senator Abar, members of the committee. I'm Jim Monahan with DuPont Group. Here today on behalf of the Community Mental Health Centers, but I also work with a larger group of Medicaid providers. So much of what I have to observe on this today probably applies to a lot of folks. I may not have checked in for or against the bill, but I think as a matter of principle, there's overall concern with the implementation of a work requirement on the folks that we care for. In particular, I wanted to, first of all, agree with Senator Pearl that holding on to this as long as possible makes sense. It's our understanding that a lot of the details on the working community engagement guidelines are still forthcoming from the U.S. Department of Health and Human Services, or CMS. So we'll know a lot more details as we hopefully get into March. We are watching for things like, we know that in the One Big Beautiful Bill Act, there are exemptions to the work requirements for people with mental under treatment for mental illness, but we don't know how frequently will they need to demonstrate that they're exempt. How will the mental health centers report into who that somebody is now well enough to be subjected to it? So there's a lot of details that we may want to have some legislative guidance on. The other issue that you all are going to be confronted with, whether it's this session or as you prepare the next budget, is it's very likely that because of the work requirement, thousands of people are going to fall off of Medicaid. And so for a mental health center, an FQHC, a hospital, there are state and federal requirements that we care for these folks regardless of their ability to pay. So we know, and we've shared with the committee and others before, that the mental health centers are annually carrying an uncompensated care cost of $15 to $17 million. We're in the process of doing some analysis of what we anticipate that being as a consequence of the work requirement and more frequent eligibility tests. The bottom line is we think the One Big Beautiful Bill Act is going to drive uncompensated costs very high. You will continue to ask these providers to care for folks regardless of the ability to pay. And so we are very likely to be back here talking about the fact that the financial instability that's being caused here is going to create difficulties in the state's ability to care for folks. And so we've talked about uncompensated care before. We're really going to have to talk about it as a consequence of this bill. And I think this legislation, if we hold on to it, may give us the opportunity to begin to lay the groundwork for how do we manage that. Ultimately, we think it's some combination of a more robust uncompensated care pool combined with the state working with providers to put resources into helping people stay enrolled. You all know that this program primarily, if not exclusively, applies to the folks that are in the Granite Advantage program. That is a great deal for the state. It's a 90-10 federal match. And so for small dollars, if the state can, there's not much of any savings associated with the state with people leaving coverage, but there's a huge exposure for the providers. So as I said, we're in the process of doing the economics analysis of what we anticipate that impact to be, and hopefully while the committee still has possession of the bill, we can bring that back to you.
Thank you for your testimony. Questions? I have a question. With regard to the Big Beautiful Bill, will that affect the Granite Advantage, the 90-10 spread that we have?
No, the 90-10 is still baked in, so the Big Beautiful Bill Act made no changes to that. There were suggestions that might change, back in May and June when they were debating it, but ultimately they did not make those changes.
Yeah, that was in the back of my head. Oh, thank you. Okay. No further questions? Nancy wants to speak. Biederman. Oh, I almost got it. But you're ambivalent about this bill.
Well, Nancy Biederman. I'm a member of the Rare Disease Advisory Council for New Hampshire. I am here representing myself, not the council.
Okay.
We have been recently working with the Every Life Foundation, and they gave me some talking points about this bill. If I understand correctly, I couldn't hear exactly what was happening with the first speaker and the senator. So
we're going to hold on to it for as long as possible.
You're going to hold on to it, but then did they also put some of this language into SB 134? Is that what he said, or am I confused?
I think SB 4 is the bill that the House has that they're sending back to us to concur with.
Okay, but it's going to have some of the same language? Or
Yes,
is this,
some
okay.
with some modifications, I believe.
Okay, I just wanted to know which bill I was supposed to follow now, if this is going to be put on.
134.
Okay, there we go. As a rare disease parent of a child that has multiple rare diseases, she likes to collect them, as I like to say. And as she's over the age of 18, I'm concerned as she goes into the work environment and what could possibly happen if her disease progresses and she can't work anymore. It's very difficult as a rare disease patient to even find a doctor that understands their rare disease, let alone to find any other person that would possibly understand it and understand what their daily life is like. Having a rare disease, it is a part-time, if not full-time job, just even managing that rare disease, let alone, doctor's appointments and trying to figure out insurance in the infusion center because of transportation issues. If this bill passes, I hope that in it that they would have a provision to educate patients about new requirements and provide robust consumer assistance. States should conduct proactive outreach and education to patients about policy changes, set up robust, accessible consumer assistance support to help people navigate new requirements, and provide ample opportunities for patients to provide feedback on these efforts. They should also promote a continuity of care. States should implement a smooth transition plan, including adequate notice for individuals who lose Medicaid coverage or transition into new coverage status. I will tell you, as a rare disease patient, just when my husband's company chooses a new plan, it's a nightmare when you go from one company to the next. States should maximize options and resources to connect newly uninsured individuals with other options for care. There should be respect to due process requirements. State processes to terminate people for noncompliance with work reporting requirements should provide sufficient time and opportunities for correction and comply with Medicaid due to process requirements. As a rare disease person, family member, caregiver, time is very precious and we don't have a lot of it. Every day, you don't know what's going to happen next. So if you're supposed to show up at an appointment or if you're supposed to go to court or whatever is being required for this, it can be very difficult to get there, depending on what your body decides to do that day. We also ask that you protect patient privacy. Applications should balance the critical need to collect information necessary to secure exemptions with sensitivity to patient privacy. The application materials and online portals must be ensured. My daughter's medical information was stolen through PowerSchool when they were breached last year. It wasn't just, as the IT guy said, oh, it just said she needed an EpiPen. I said, no, it had her medical diagnosis on there. So her information is out there and being shared against her wishes and against my wishes. And finally, we need you to prioritize transparency. States should make publicly available, including online, timely and detailed monthly reports of outcomes related to work reporting requirements, applications, renewals, and terminations, as well as metrics related to consumer assistance like application processing and call center wait times. Any questions? Thank you.
Thank you, Mr. Chairman, committee members. My name is David Trumbull, and thank you for the chance to speak today about this bill about work requirements. I have a few concerns about it. I hope that we'll be able to consider to maybe write a bill that's improved. First is that, just looking at it back from a policy point of view, the number of eligible people who will likely be disenrolled will exceed the number of people who would not be eligible, who would be taken off the rolls. And that was the findings from the Urban Institute study who looked at this program. They concluded that you would take more people off the rolls because of the paperwork requirements who should continue to receive Medicaid. How do they arrive at that conclusion? First of all, most people who are on Medicaid would meet the requirements. The Kaiser Family Foundation did a study, and it came out in May of 2025. 92% of people on Medicaid are working in school, caregiving, or have a disability. Only 8% are either retired or unable to find work. And that breakdown is school attendance 7%, illness and disability 10%, caregiving 12%, part-time work 20%, full-time work 44%. The second is that unless you have automatic eligibility, most people will have difficulty meeting these work requirements. And again, that was the conclusion of the Urban Institute study. And they found that that happened in states where this was implemented. They looked at Arkansas. This was done in the late 2018s. 18,000 adults were disenrolled in the first year, and the federal court stopped the program this following year. The third thing is that in New Hampshire, this is a little broader than work requirements. The Kaiser Foundation says that about 13% of New Hampshire Medicaid recipients will lose their coverage due to the new federal rules. Now, that's more than work requirements, but the work requirements are the largest component of that. That's 24,000 people in the state who will no longer have their health care. And we know that a third of people on Medicaid are children. So what would be done possibly to this bill, which things I didn't see in the text of the bill, I'm sure they're on your mind when you work with Health and Human Services, providing enough caseworkers and making sure they have a reasonable caseload to help people fill out the paperwork. So that's going to require money, and I didn't see anything in the fiscal note about that. Streamlining the documentation compared to what we did previously, and anybody who's had any involvement in the system knows that it's cumbersome. Investing in education and public outreach, which was mentioned by the previous speaker. Automatic eligibility for people with long-term and chronic conditions so they don't have to continue to reapply. If you're in a situation where it's not likely to change, you shouldn't have to do it so often, maybe once every several years. Or special attention to people dealing with mental health and substance abuse recovery. As people are progressing to improved health, trying to build a work history, it's not always a straight linear line. If they can't keep getting the Medicaid, they won't get the services that they need, which is what helps them stay on track. Then not only is their health care and their well-being threatened, but the state's goal of helping people recover from illnesses would be threatened. And lastly, how about job training and assistance programs for helping people find jobs? That's the few percent who really don't qualify, or people who can't find work. And that there is work in some parts of the state. In other parts of the state, it's not as plentiful, and it depends on what your training is. So if the goal here is to see how many people we can keep on Medicaid despite the federal bill, then part of the legislation should be efforts like this that will make sure that we spend the money we need to make sure that we don't see 20,000 people in the state lose their health care. That's all I have. Thank you.
For your testimony, questions from the committee? Senator Long.
Thank you, Mr. Chairman. The Urban Institute study was what year?
Okay. The Urban Institute did a report in March of 25 that analyzed a more limited 2023 congressional proposal for work requirements. And I'll turn in written testimony, which has everything I cited has a source that you can look it up.
Thank you.
You're welcome.
Seeing no further questions, thank you very much.
You're welcome.
Thank you, Mr. Chairman. Nice to see you. Good afternoon, busy afternoon. Thank you for allowing me to introduce Senate Bill 476 related to healthcare cost transparency. For the record, I'm Senator Tim McHugh. I represent Merrimack, Amherst, Milford, and Wilton, Senate District 11. And this bill builds directly on the foundation to deliver consumer-facing practical benefits to help consumers understand the true cost of healthcare. So New Hampshire was on the forefront of building an all-payer claims database years ago, and the department has done a great job supporting that. It's called Health Cost, and it's a portal that allows consumers to log in and see generally what things cost in healthcare. This bill expands upon that because the number you see isn't always your bill. It's a median price based on past claims, and it's useful for context, but it's not really your personal out-of-pocket cost. Your real cost depends on your deductible and what copays are right now. And the prices sometimes are often bundles. They don't show every bill. Some services combine multiple items into one estimate, and in some cases, health costs will do that. But it may not separate hospital versus doctor charges, and some services, like many x-rays, only include part of what are billed. Unbundled services can miss add-ons that are done on the same day. So you'll see wide variability if you look at health cost. So in other cases, uninsured discounts aren't verified by the state. It's very difficult to do that. So without building new IT infrastructure, the bill asks for a little more precision. For instance, diagnostic mammogram is a great example. The CPT code is 76091, and Health Costs found two different clusters of prices, some around $775, some under $325. So a huge, like more than double difference. So with that kind of split, the site couldn't predict what one patient would face. So with this implementation and access to the API interface with the plans, a patient would be able to more personalize their actual cost and effectively shop around if they're able to do that. So with very high and very low bills trimmed out, Health Cost tends to remove those. And that can really hide the unusual situations which cause those big surprise bills that we all see a month or so later. So that's what we're trying to control. And in plain terms, this is the same front door to access health costs, but it's a little bit of a different hallway, if you will. The health cost site would remain the state site, but it would route each member to their health plan's existing federally required estimator to retrieve a real member-specific pre-service out-of-pocket amount through those secure APIs that are already required. So no new state IT. We just connect the tools that carriers and hospitals already run under the federal rule. No new DOI system to build or fund, and no state repository of protected health information. So just a menu with prices, and families finally get to see what they're going to pay before they get the bill. That's the idea. It's just shine a little light on what things really cost, that people shop around, where increasingly people have healthcare savings accounts and really their own money, oftentimes that they can carry over from year to year. So we want people to really understand what it costs before they book a service. And also in this case, the uninsured wouldn't be left out. Folks that choose to pay cash for whatever reason would be able to get a little bit higher level of accountability. So that's what the bill tends to do. I'll keep it fairly close and short. I have some examples in my written testimony for MRI and routine colonoscopies and things like that. I'll let you read it at your leisure. I've submitted that in writing. Happy to take questions.
Sounds like fun reading. Questions from the committee? Senator Bertzel.
Thank you, Senator. So I'm reading, do hospitals already have to comply with the price transparency? And how does this affect your bill?
So to some extent, they do. They have some federal price transparency, but the issue is the individualization based on a given member's deductible that often changes, out-of-pocket limit, which of course changes as you utilize your benefit throughout the year. So it's that personalization on an ongoing basis. And so we'll marry the two sets of two data sets.
Okay, thank you.
Is there any fees with this?
No.
Just asking. I see no further questions. Thank you, Senator. Appreciate it.
Thank you so much.
Representative Julie Mills or Miles? Miles. Miles from nowhere. Love that song.
You can find a song for anything.
You can. That was a Cat Stevens song.
Hello, Mr. Chairman. Hello, committee members. Thank you. For the record, my name is Julie Miles, Representative Julie Miles from Hillsborough District 12. I represent the town of Merrimack. I'm a co-sponsor of 476, and I'm also an experienced critical care nurse. I'm certified in emergency care, and I have been at the bedside and doing insurance-related things for a very long time. Every day, I meet families who are trying to balance care with cost. At the bedside, price is invisible until the bill arrives. The price needs to be visible upfront, and without accurate, timely claims data and clear reporting, we can't design fair benefits. We can't price stop-loss insurance. We can't protect the most vulnerable patients in employer plans, the very people who depend on predictable coverage for cancer care, cardiac interventions, and life-saving medications. SB 476 is a practical step that improves access, affordability, and outcomes by turning our health cost website into a single front door that connects patients to their own plan's real pre-service out-of-pocket estimate. We can connect tools that health plans and hospitals already run under federal law, and that means a mom can see what she will pay for her child's MRI before she actually schedules it. It means a small manufacturer's HR director can compare sites and steer to high-value options. And it means plan sponsors get clean, clear, more consistent data so actuarial models and stop-loss layers reflect reality and not just averages from years past. Transparency is not a slogan. It is the foundation of good clinical decisions and good plan design. When patients know their costs, they don't delay care. When sponsors and reinsurers see accurate costs, standardized data, they can structure benefits in a way that reward quality and keep premiums stable. SB 476 honors the strong work of the Department of Insurance. It reduces duplication for hospitals and gives Granite Staters a menu with a price before they subscribe. I respectfully ask you to support House Bill 476. Thank you for your time and commitment to improving access, affordability, and outcomes.
Thank you, Representative. Questions from the committee? Seeing none. Thank you very much.
Thank you.
Sam Burgess, New Features.
Thank you, Senators. My name is Sam Burgess. I'm the Healthcare Policy Director at New Futures. We are a nonpartisan, nonprofit organization that seeks to solve New Hampshire's problems with policy solutions. I'm going to keep my testimony limited here today to the question brought up by Senator Birdsell, and that is, aren't hospitals already subject to federal requirements on this? And that goes back to the federal hospital price transparency rule. So while there is a rule that exists, the National Institute of Health has published a study reporting that many hospitals have failed to comply with CMS's requirements, which prevents patients from understanding their expected costs and comparing prices amongst hospitals. The study found that in a random sample of 100 of the approximately 6,000 highest revenue hospitals, 83 were non-compliant with at least one of the major CMS requirements. That's a compliance rate of 27%. The study published by NIH also found that CMS's enforcement mechanisms are weak, with a maximum punishment for hospital noncompliance of $300 a day. That gives CMS very little power to rein in noncompliant hospitals. I encourage the committee to take a look at the study published by NIH. It's in the footnotes cited in our testimony. Compliance issues are not only a national issue, they're an issue right here in New Hampshire. The nonprofit, nonpartisan organization Patient Rights Advocates reviews hospital compliance with the federal hospital price transparency rule, and it shares state-by-state data. In the November 2024 report, Patient Rights Advocates surveyed 7 New Hampshire hospitals: CMC, Concord Hospital, Elliott, Frisbee Memorial, Mary Hitchcock Memorial, Parkland, and Portsmouth Regional. All 7 were found to be non-compliant with the CMS requirements in at least one category. That sheet listing out the 7 hospitals is actually attached to the back of the testimony as well. So just focusing on this one point, I'd say that the federal rule went far in recognizing an important transparency issues for Granite State patients. However, it's clear that compliance in New Hampshire is wanting, and CMS has limited enforcement powers. For those reasons, I urge you to support patient autonomy and transparency, and I urge you to vote ought to pass on SB 476. Thank you.
Thank you for your testimony. So when you say non-compliant, the 7 hospitals, are they moderately non-compliant, or are they drastically non-compliant? In what area are they non-compliant?
Thank you, Senator. So if you take a look at that listing, the attachment on the back, you'll see the 7 hospitals listed. On the far right side, there's an explanation for specifically why they were found to be non-compliant with the CMS rule. For instance, I'm looking at CMC. MRF codes or code types are obscure and or inadequate for identifying items or services. For Frisbee Memorial, public website hosting the machine-readable file does not include or includes a non-conforming text file in the root folder. There's a number of reasons, and as you'll see, it goes through and checks yes or no on a variety of requirements pursuant to the CMS rule. I also encourage you, if you have any if you're curious, the website does a very good job in explaining some of the methodology they do in surveying these large acute revenue producing hospitals, including those in New Hampshire.
Any further questions? Seeing none.
Thank you.
Good afternoon again. For the record, Henry Lippman, the state's Medicaid director. The department supports transparency and sunlight initiatives. I hope there'll be an opportunity to work a little bit with the sponsor of the bill, a couple of issues that we'd like to
You just nodded
raise.
yes, so that's a good sign.
Thank you. So just to be specific, I think in terms of where we'd like to work, line 6 through 8 talks about what it means. Page, I guess it's 1 of the bill.
Page 1?
Yes, section 2, line 6.
Yeah.
Section 1, Roman 2, line 6.
Correct.
It's what it means to be a hospital in good standing, which kind of ties to the Roman 4 purpose of this in terms of adopting administrative rules. We'd like to work to clarify what that means a little bit more. And then in terms of the dashboard, we'd like to understand a little bit more about what that, that's on line 21, still on the first page of the actual bill, what that entails so we can understand if there's a cost component or staffing component related to that. And then on page 3 of the bill, I mentioned here to the sponsor that under rate setting guidelines, the administrative cost for creating the APIs would be something that we would have to recognize in our capitation rates. I don't have a figure for that. I need to look into what that would be, but would want to raise that.
So the whole page or just?
No, sorry. It's in 1 through 4. Sorry. And specifically line 2, paid by carriers, that unfortunately the way the federal rules work, we would have to recognize that cost. It could have some, I'm not sure what impact. I need to do some more investigation on that. And then I guess sort of the, again, depending on some of these things, the effective date in 12 months, I think the department has a huge lift with implementing OB3, and we might need some leeway there with respect to the work requirements and the concerns you heard earlier about doing that, with sensitivity to those who have healthcare needs. And lastly, just sort of as a, the compliance assessment, we want to make sure, depending on how the first comment I made about on page 1 on assessing federally compliant, is that we have the qualified staff to make that assessment. Okay. And that's it, and we support the concept.
So I see there's no fiscal note with this, but if
we need to do some work on that from our standpoint, but we need some more information to do a good job with it.
Any questions from the committee? Senator Prentice, no? I'm teasing you. I know you. I know, I was teasing you. All right, thank you, Henry.
Thank you.
Appreciate it. Ben Bradley with the New Hampshire Hospital Association. You're our final speaker.
Good afternoon, Senator Avard and members of the committee. For the record, my name is Ben Bradley. I'm the Vice President of State Government Relations for the New Hampshire Hospital Association. The Hospital Association has concerns about SB 476 and requests the committee adopt an amendment to address those concerns. SB 476 acknowledges that hospitals already are required to comply with federal price transparency regulations as noted on page 1, section 1, Roman 2, which states a hospital that is in good standing, compliance with federal hospital price transparency requirements, and that provides a patient-facing estimator, whether operated by the hospital or its vendor, is deemed to satisfy state transparency obligations. All hospitals in New Hampshire are compliant with these federal price transparency regulations. PatientRights.org, or whatever it's called, has no credibility for determining a hospital's compliance with federal CMS transparency regulations. They use a different rubric to drive an agenda that is very misguided. Additionally, the Federal No Surprises Act requires hospitals to provide patients with a good faith estimate of expected charges prior to a scheduled service. Hospitals in New Hampshire issue tens of thousands of these to patients each month. CMS holds hospitals accountable for their compliance with each of these transparency regulations. Therefore, reporting compliance to the New Hampshire Department of Health and Human Services as written on page 1, section 2, Roman 6 is unnecessary. The bill does not include a fiscal note for DHHS to collect this information because the bill passes that cost onto hospitals at the top of page 3, Roman 3, which notes these costs shall be paid by, among others, hospitals. Finally, in New Hampshire, the insurance department, as noted, hosts the New Hampshire HealthCost.org website, which is a patient-friendly platform that compiles data to show consumers what services will cost depending on where the patient seeks care. I've included in my testimony the insurance department's RAC card, which provides information about where your constituents can access this resource. Given the existing federal requirements, the New Hampshire Insurance Department's resources for price estimates, and the additional unnecessary cost burden on hospitals that was result from this bill, we respectfully request the committee support the attached amendment to remove hospitals from the underlying bill or consider recommending the bill inexpedient to legislate. Happy to
Where's that
take
amendment?
questions.
Do we already have? Do we
It
have?
should be in the testimony I provide.
Oh, okay, I got so many papers coming in here. I got it, thank you. Oh, we have another speaker, probably from a nonprofit organization. Questions from the committee? Have you worked at all with the prime sponsor on this, for the amendments?
No.
All right. I don't know if you're agreeable. Yeah, he's nodding his head yes, and maybe you can work with Henry as well.
Okay.
If that's agreeable by you. that'd be
Thank you,
great.
Senator Abar.
And if you could share this amendment with him as well, see what we can do. And we'll come back and have a discussion another day after we hear from our final speaker, which is Senator Peter Bragdon.
Thank you.
Welcome. Seeing how we had no further questions. Who? Oh, did you sign up? Anyway, Senator, go for it. Oh, you're welcome to, absolutely. So you'll be our final speakers then.
Hi, thank you. Thank you, Mr. Chairman. Back again. I've been bouncing around the city of Concord all day, back and forth between different buildings. Let's see, here representing again Harvard Pilgrim Healthcare, as you may recall, the state's nonprofit health insurance carrier. And just sharing some concerns that they had as well. It's a complicated bill, and then waiting to hear back from them takes a while to get some comments and stuff. But there's a couple of areas of significant concerns. And first of all, under section 4, which I suppose the concern is actually on closer to the top of page 3 relative to cost. Well, first we'll start off by saying that Harvard Pilgrim Healthcare has a cost estimator tool on their website that takes into account our members' cost sharing, deductibles, all that. So that information is already available. And not sure what is gained by forcing us to create some new kind of software program to interface with the Department of Insurance. I can say there's some concerns because to comply with the recent federal laws, I know cost over $1 million to comply with those laws on the transparency, to get everything put together, at which point the Fed said, oh, wait, we're going to change that. And you guys passed a bill earlier this year, one of the retained bills, that basically made some more changes, which is more programming costs, and now a whole new programming thing. And as I said this morning, all the costs that go into the system, the insurance ferry doesn't show up and repay those costs. It comes out in premiums. So we're increasing people's premiums. What are we getting for it is always the balancing test you need to make. So we're a little concerned about, top of page 3, it talks about costs associated with vendor configuration, which isn't defined, portal content updates, API routing. There's a lot of unknowns here, but they sound like they cost a good bit of money. What are we getting for that money? And secondly, in section 5, if I'm correct here, is, like I pointed out before, section 5, Roman 1 talks about each carrier shall ensure enrollees can obtain without charge consumer price estimate for shoppable services. And item A, through the carrier's existing self-service internet tool. So we already have that. Not sure why we're being asked to be doing more. And especially when developing anything that provides other access to anything, you run into security concerns and data privacy concerns. And those are the concerns that were raised to me upon the review of Harvard Pilgrim's people. So happy to answer any questions, though I'm not an expert on this for sure.
I didn't see any. All right, thank you. And Michelle and Jason, my apologies. You're actually the first on the list, but I had a check next to it, so I thought maybe I already took care of that.
Good afternoon, everyone. Michelle Heaton from the New Hampshire Insurance Department. I'm the Director of Life and Health, and I have here with me Jason, as is our Director of Data. Data Analytics?
Health economist at the
We
Insurance.
reorg a lot and names change, so So we, as a department, we are very supportive of transparency. It is a big part of what we do at the department, and we're always looking for ways to improve it. With respect to this particular bill, we just noted that there are some technical defects with it. We're more than happy to work with the sponsors to work through those. I think some of it comes because it looks like the language in here is trying to address some issues. The department had 2 bills last session that got held over. They recently just passed. And so they're now, I think, headed to the governor's office for her signature. So should those, fully be enacted, there could be some provisions in here that would conflict with those new laws coming into play. So we would need to just clean up some of the language to make sure that we're not conflicting with the existing law and we're still able to do what we need to do for cost transparency. So I'll leave it at that, but I know Jason is our data and transparency guru, so I'll pass it over to him.
Thank you. No, I just wanted to point out a kind of a gap in logic between the 2 types of data sets. It's really a specificity gap. The transparency and coverage data that are part of this bill, those are self-reported data from entities, hospitals, for example, and insurers. Currently, for New Hampshire health costs, we have an empirical approach that uses claims data, meaning, when the rubber meets the road, what actually did a patient get exposed to? And those are different, and I think that represents an opportunity for oversight and compliance and improved precision and pricing for the entire healthcare market. When we see the claims data, we can reconcile those against some of these hospital price transparency data and transparency and coverage data to see if in fact or indeed the patient is actually charged what the self-reported price matrices say. And that's important. We see this daily at the insurance department that despite our best laid intentions, that's not always necessarily the case because of so many complexities in healthcare financing. So that's noteworthy to understand. The claims are empirical, observational data. This is what the actual price exposure was. The other types of transparency data that are part of this bill are very important, but those are self-reported data, and they're not the same. There's a specificity gap. So I just wanted to point that out, and happy to answer any questions.
That did sound like a guru to me. Yeah.
Sorry?
Any questions from the committee?
I just had one more thing too about the advance notice of what you're going to pay. There are changes in law that are currently in place that do require for uninsured and insured patients. Patients are able to request those advance cost estimates. And for insured patients, that includes what your cost sharing would be for that scheduled service. We have also, in some of our rules that are in rulemaking right now, included additional provisions to build off of that. So that stuff just went into rulemaking recently, so I'm sure the sponsors didn't have the advantage of that when the bill was drafted initially.
So you'd be willing to work with the sponsor to give them a heads up on some of the changes that you find necessary? And I don't know if you can work with Henry as well, and all who are interested in this bill. The prime sponsor is nodding his head yes. So he would like some help so he can get this past the finish line. And are there any questions from the committee? Seeing none, thank you very much.
Thank you.
And you were our last speakers, so we're going to close the hearing on this and wait for our next bill. Yep. Hang on. And so we're going to open up the hearing for SB 477 here from the prime sponsor. I just want to remind people, do not assign any ill feelings towards any organization or character assassination. We don't tolerate that. And so with that, you're introduced, Senator Magoo.
Thank you, Mr. Chairman. One down, two to go. Good to see you. Again, for the record, I'm Senator Tim Magoo, Senate District 11, the great towns of Merrimack, Amherst, Milford, and Wilton. I'm here to introduce another healthcare cost transparency bill. This one is the 340B Sunshine and Savings Act. And borrowing a phrase from my good colleague from the state Medicaid office, sunshine is a great disinfectant. So the committee certainly has expert level knowledge and understanding of the 340B program. But for those watching, the program dates back to about 1992 when Congress created it as a safety net for providers to purchase outpatient prescription drugs at discounted prices so they could stretch some scarce resources and provide more care to uninsured and low-income patients. And throughout the years, utilization of that program has gone up, and unfortunately, the proportionate spending on free care, uncompensated care has gone down. So there's a bit of a gap there. It's administered by the Federal Health Resources and Services Administration, or HRSA, which is an agency within the U.S. DHHS, which oversees the eligibility and the pricing compliance, but does not require hospitals to report exactly how the savings are ultimately used. There's some reporting requirements, so let me just be clear on that. There are some reporting requirements. But it doesn't possess broad rulemaking authority in this area. So that gap is why some state level transparency is appropriate and necessary, and that's what this bill attempts to do. It doesn't change who qualifies for 340B or how discounts are calculated or how manufacturers participate. It simply asks the covered entities in New Hampshire to report in the aggregate how 340B savings relate to charity care, rural access, and patient services. That's about it. The bill supports uncompensated care for uninsured patients by making sure that the financial benefits intended by Congress are visible and accountable at the community level. And that's how we improve outcomes. It's a really great opportunity, actually, for hospitals and the providers to show everyone all of the great work that they do. One hospital I just learned today in my district, one of the larger hospitals, has just learned that they are likely now eligible for this program, and they intend to utilize it. And they're excited about advertising and sharing with the community how they will use this savings. They have no reservations. I just learned it moments ago, actually. Most New Hampshire hospitals, of course, are very well run and mission driven, and this is an integral part of their mission, the uncompensated free care, tens of millions of dollars in each institution. So importantly, this bill doesn't conflict with any federal law, and it's not subject to federal preemption. 340B statutes do not prohibit states from collecting aggregate financial data or regulating Medicaid claims administration or requiring transparency. Courts have consistently recognized that these are traditional state functions. So 477 is consequently very narrowly tailored. It avoids any proprietary pricing disclosure, and it's fully within the state's authority. So it's very much a patient-forward, transparency-first bill. It will preserve the 340B program and make it more effective by allowing the institutions to share with the communities exactly how they're utilizing it. I think it will inspire even more confidence and, most importantly, improve outcomes for New Hampshire patients. So I respectfully ask for your support. Happy to take any questions on the topic. I know that there are experts in the room on this committee on this topic for sure.
Senator Yvard.
Thank you, and thank you for your testimony, Senator. I'm just curious. So this is a federal program, the 3040B. So are we creating a new, if you don't mind me saying, layered bureaucracy to monitor a federal program?
So you could argue that, yes, we are. We're asking for some additional transparency currently not required by the federal government. We're well within our purview to do that. The courts have ruled on it before. So yes, we are asking for some additional light to be shown upon where the money is going. There have been, I'm sure you've seen in the news, lots of discussion on executive compensation packages, and not to make any commentary on who's worth what or how money is spent, but the facts are utilization of the programs over the years have gone up, and spending on free care has gone down. So there's a gap. So the question is, show me the money. Where is it going?
And so the federal guidelines doesn't disclose those gaps?
Not sufficiently.
Thank you.
Any other questions? I was late to the party here. I know that we don't have a fiscal note. Do we have that yet, Sophie, or?
Let's see.
Okay. Okay. All right. Very good. Any other questions? No. Thank you, Senator.
Thank you.
Representative Miles. Welcome.
Thank you, Mr. Chair, and thank you, committee members. For the record, once again, my name is Julie Miles. I represent District 12, the town of Merrimack, and I'm very honored to be a co-sponsor on this bill. If we go back to Florence Nightingale, we can all remember the first thing she would ever do would be go into a patient's room and open the curtains and let the sunshine in. Before serving in the legislature, I took care of many patients and families during their most frightening moments. I've sat beside families who were not asking about policy or reimbursement. They were asking how they'll survive, how they'll pay for their medications, how will they pay for the care their loved ones desperately need. I've also spent years performing clinical medical underwriting and appeals work. I've represented both providers and beneficiaries, and I've personally argued and won hundreds of administrative law judge appeals before the United States Federal Appeals Court. I've overturned hundreds of CMS physician determinations where care was initially denied multiple times, and I understand both the clinical realities and the financial pressures facing patients and health plans. The 340B program was created to care for patients like I have cared for in the past. People who are underinsured, uninsured, or just struggling to afford their life-saving and maintenance medications. When used as intended, the 340B program can expand access to care and reduce financial toxicity and improve outcomes. When those savings aren't transparent, patients are the ones who lose out. SB 477 is about making sure those savings are actually working for the patients. It doesn't simply reduce hospital participation. It doesn't cap spending, and it doesn't interfere with care delivery. It simply asks for clarity so policymakers and the public can see whether the discounted drug savings are being reinvested in charity care, rural services, and patient access. One of which I'll just mention would be mental health, which as a general rule, we all know now that the mental health space is lacking. We need more providers, we need more care, we need more accessibility, and we need to know if this money is being reinvested in that category, just to name one of them. Thank you.
Thank you. Are there any questions from the committee? Seeing none, thank you very much.
Thank you.
Representative Polizov.
Thank you, Mr. Chair. For the record, Yuri Polozov, representing Merrimack 10, Hooksett and Dunbarton. I'm here in support of this bill. It's my fourth year on House Health, Human Services and Elderly Affairs Committee. And I also had a similar initiative for 340B transparency in the House. The bill in front of us is very important for transparency. On page 3, you can see some important provisions for patients' notification and transparency, and also provisions for enforcement of this bill. This Sunshine effort is national. Last year, 6 states already had similar measures implemented, both Republican states and Democrat-controlled states. So it's very important that what intended for charitable use is actually used for charitable services. We have a dozen of critical access hospitals using this program, but total number of participating entities over 200. So we need some transparency in what's going on with this program. It should be, there should be some oversight on federal level, such as by HRSA, but it's not working. HRSA is being removed from overseeing this program in favor of CMS. There's some discussions of some federal reform, but it's not happening due to various reasons. So it's very important for us to implement this Sunshine measure. Thank you.
Thank you. Any questions of the committee? Thank you very much. Let's go to insurance. Dr. Aziz.
Good afternoon.
Thank you. Jason Aziz, Health Economist at the Insurance Department. I just wanted to be here for informational purposes and say I laud all of the healthcare transparency efforts. And I think I talked last week about a recent example of the benefits of healthcare transparency. We just want to know what the price we pay is, and I'll ask you to think about anything else that we consume in our society for which we don't know what the price is. Think about gasoline, household costs, and groceries. We always know what the price is, yet on healthcare, which represents about 20% of our per capita household expenditures, we have no idea until months later when we get some cryptic bill that we're not even sure if we're responsible for. So the bill sponsors are doing exactly what I hope happens and evolves in the healthcare industry, making prices more transparent. Happy to answer any questions.
Senator Prentice.
Thank you. Always good to see you, Dr. Aziz. So,
Jason.
Jason, good to see you. So the last bill and then this bill, somebody, and it might have been Ben Bradley or maybe it was you, you were just saying that that people need to know what the prices are and that they don't. But there is, and I personally experienced this year because I had a hip replacement, and ahead of time I got an estimate, like here are all of the costs, and this could be the high end and this could be the low end. Can you help me with what the intersection of these are?
That's one of the challenges with transparency. You never know what types of complications. So a priori, ahead of time price estimates, and we hear the New Hampshire Hospital Association righteously talk about some of the methodological challenges. You don't know what types of complications, excess bleeding, more hospital stay, excess medication. So they are estimates, is the implicit in the name. And so the more complex procedures are, the greater that variability becomes. But if you look across a continuum of healthcare expenditures, things like laboratory tests, radiological tests, primary care visits, vaccinations, there is much narrower price variability. So that's kind of a quantitative issue that needn't hold back price transparency efforts. And I think they've been overstated. A hip surgery, and I hope you're doing better with your hip.
great.
Stay moving. But that's a very complicated medical procedure, and it's probably up around the 90th percentile of such complicated cases. But the lion's share of our healthcare expenditures are much more simple and straightforward, and can easily be estimated before, like those examples: X-rays, MRIs, lab tests, primary care visits, and vaccinations, and in prescription drugs too, indeed. Yeah.
Thank you.
Just to add clarity, that this is specific to a specific program. This isn't, we're not talking about all prescription drugs. We're not talking about the hip surgeries. This is a federal program that is set out by federal government, federal guidelines. I just want to make sure we're on the same page.
This is a macroeconomic example of transparency, and we ought not sequester price transparency to micro or consumer level decisions. There's lots of consumers, and the federal government is a massive consumer of healthcare. And as our citizens, as our large employers, and state governments as well. So the consumer level and then the price transparency accordingly should permeate through all of those levels. And it's important that's why I laud this endeavor. And, I think as the bill sponsor stated, is we just want to know that these discounts are reaching the people for which the federal law intended them to reach, low income individuals. And so I laud that effort.
So so if it's a federal program, I mean, I'm all for transparency, but I mean, you and I share that same thought, and I think everyone should. But whereas it's a federal program, why wouldn't the feds require this when they implemented the program?
Thank you for asking that. What's noteworthy is that indeed the HRSA did have federal oversight over the program. I think they essentially got fired. The federal budget for 2026 is shifting over authority for oversight from HRSA to CMS, and I think it has to do with resource constraints. And so I just wanted to make this committee aware of that. There's a website, OPAIS, or the Office of Pharmacy Affairs, IS's information systems. You can go there and look at all of the myriad of different reports that are there and see some of the insights that the federal government has. But there are more and more states that are trying to take up what the federal government has not been able to do, is to sufficiently oversee that. So I laud the senator and representatives' efforts here to just try to get more transparency to make sure that these savings go to the right populations. And you might ask, well, what's the insurance department opining on this for? It's a good question. Think of prescription drug costs as an aggregate like a balloon. And if you squeeze one end of the balloon, i.e. make prices lower, 25 to 30%, it's the other side of the balloon that takes up the additional pressure. And that is, not lost on us every day in the work that we do in other areas of prescription drug price transparency. And we try to go on and on explaining what some of the drivers are of that inflationary effect. We're talking about one right now.
Thank you.
Thank you.
Senator Ibarra.
Thank you, and thank you for stepping up or running up to the plate. The representative had mentioned that this is adopted in other states, and we don't have a fiscal note, so we don't know what it's going to cost. However, there must be a cost benefit. Have you seen how it's worked? Have you monitored in any way the results that it's taken place in other states?
We don't have information on that. I think the insurance department did submit a fiscal note to the OLS. I didn't see it reflected in this. We're happy to have Jennifer Smith send it forwarded on over. But we don't trivialize some of the costs to reporting entities for being compliant with regulatory oversight. When I model fiscal impact, I generally try to do it in terms of the marginal cost, and there's certain assumptions that are necessary to make for that. One of them is the assumption of compliance, that these entities are, and manufacturers and covered entities are indeed compliant with federal law. If that assumption is wholly met, then one of the findings is that the marginal cost of submitting some of these same data to the state is non-zero but trivial, meaning it's not a lot of money. And so that's important to understand that's a key assumption. If readers of that message don't believe that assumption is met, then you may then believe that there is a higher marginal cost to submit these data to the state of New Hampshire, and why should we incur that inflationary effect? But I like to think these firms are altruistic and are indeed compliant with the federal law.
So I do have, yeah, you mentioned that buzzword, compliance. That seems to be a really hot topic these days. So with regard to compliance, if we do not know if this potentially would help us to let us know that we're compliant. If not, the federal government will let us know if we're compliant, correct? Or not?
As I said, the budget for 2026 just shifted authority from HRSA over to CMS. It's the signal to me that the resources allocated to that endeavor were insufficient. So that's when you see a shift in oversight, maybe from the federal law. That's why states are taking this up and as part of NASHP, National Academy for State Health Policy model legislation, because all of you hear these bills for prescription drugs coming up iteratively, and seems like every year, because there's a lot of problems and they're incurring excess costs to our citizens. Yet these therapies are so innovative and so important as part of our healthcare system. We need to know what they're going to cost and where all the money's going. And there's vacuums in the transparency paradigm. This aims to, I think, open up one of those shades that Representative Miles was talking about. Some of the transparency efforts are just opening one shade at a time. We need to open all of the shades to see the economics of prescription drug delivery and the cost of that. And that's why this is an important gap. And it's been inflationary to the commercial markets. That's why the insurance department's interested in that. Thank you for that question.
Are there any further questions? Thank you very much.
Thank you.
Henry Lippman.
Good afternoon again. For the record, Henry Lippman, the state's Medicaid director. I've had some conversations with the sponsor of the bill, and I want to, for the purpose of transparency, I think I want to share an important thing about 340B and how it works in New Hampshire compared to maybe in some other states. In New Hampshire, and I'm going to go through some piece of the bill, but I want to give a high-level thing, that in 2024, the Senate passed a bill to make sure that providers were not artificially limited from accessing 340B. We have policy, and a part of that is because it supports the services of our critical access hospitals, federally qualified health centers in particular. And in talking with the sponsor, the intent of his legislation is not to limit access. But why that's important to New Hampshire is that, unlike most states, New Hampshire, for any Medicaid patient that accesses an entity that's a 340B, the rebate revenue comes to the state of New Hampshire, which funds the Medicaid program. And so as a Medicaid director, I'm really concerned that, I'm not saying this piece of legislation, but other legislation that's out there, that's model legislation in the country, the intent is to limit the use. And it's often sponsored by pharma because the rebates that they have to pay reduces their profits, if you will. And so I think our concern is that there's tens of millions of dollars that support the Medicaid program. We want to make sure that it's clear that the purpose of this bill is to do what I think the sponsor is representing it to be, which is to share where the proceeds from the rebates that, other than Medicaid, go to supporting healthcare in our state. With that, I understand there may be a work session associated with this and would like to work with the sponsor and others on the bill. But going into the bill specifically, one technical issue is on line 7 on page 1 of the bill. And I've mentioned this to the sponsor, that the federal reference here covers both 340B medications and non-340B medications. We can certainly provide a technical fix there. Continuing on page 1, I think the line 7 is the definition of covered entity. I think it's the right thing here, but I think this is focused at hospitals. Hospitals are a subset of this reference. I'm not sure that has to be corrected, but just to point that out. I think the intent of this bill is focused on one provider type, not all. And like to clarify that if that's in fact the case. And on the reporting component, line 23, not an issue here other than to clarify whose fiscal year that the reporting entities are reporting on, because obviously there are a variety of, in the hospital sector, usually there's June 30th, September 30th, or December 31st. Moving on to page 2, lines 29 through 35 is what I was sort of, actually 29 is one issue, then 31 through 35 is another. In terms of understanding more what would be involved here, what the dashboard would be, and would there be costs to the department to build that out, rather than just using Excel and Access worksheets. We want to get an understanding what we'd be required to be putting up there. And 31 through 35 is sort of what I was getting at, is we have a prohibition when someone applies to HRSA that they want to participate in the 340B program. There's a box they have to check. Are they or are they not going to be claiming rebates on Medicaid? To get one passed for New Hampshire, you have to click the box that they're not going to do it for Medicaid. And so I think in terms of what some of this here, I think we could refine this a little bit based on how New Hampshire actually operates 340B under Medicaid. Again, depending on how the bill goes, I'm a little concerned with the January 1st effective date, given all the other provisions of OB3 that we have to implement with that effective date. And, talking with the sponsor, I think he would listen to our concerns there once we know a little bit more specifics. But I guess, sort of my takeaway here is I just want to make sure that we're not limiting those qualified 340B providers from being able to draw down the extra rebates. It helps them with the provider cost structures, and that we not do something that limits, in a material way what funding there is for the Medicaid program, because I don't see, a solution in terms of on the revenue side to fill in that gap. And again, I think, talking with the sponsor, I don't think that's his intent.
Thank you. So, I mean, you kind of hit on it when you closed and you said it opening. You were concerned that this may touch the Medicaid process, and we certainly don't want that. We know that the rebates are very important to keep the program functional. So, what specifically, is it page 2, lines 31 through 35 that give you the greatest concern as far as our Medicaid program?
I was thinking about this overnight since I've had conversation. I don't know if maybe simply clarifying in the purpose clause that, this is not trying to undo what was passed in 2024 in terms of limiting, qualified 340B providers from accessing the discount, nor is the intent to change the financing structure for the Medicaid program. I think those are two key things that in talking with the sponsor, I feel like we're not in different view there, but I do think just because there's other legislation that's referenced, I just want to be clear, what I think the intent here is to make sure that there's a better understanding of how the proceeds are used to benefit the community and patients specifically.
Sure. Thank you. Are there any questions for Henry? Thank you very much. Let's see, we've got Ben Bradley.
Good afternoon, Mr. Chairman and members of the committee. Again, my name is Ben Bradley. I work for the New Hampshire Hospital Association. On behalf of our 16 340B participating hospitals, the Hospital Association is opposed to SB 477FN, which enacts an exhaustive list of several unnecessary and burdensome reporting requirements for 340B participating hospitals, including all of the state's 13 critical access hospitals. Congress instituted the 340B program in 1992 for two major reasons: to stretch scarce federal resources for providers serving a disproportionately high number of low-income patients, and to help shield these providers from the major increases in drug prices that have gone up year over year. What do I mean by stretching scarce federal resources? Hospitals in New Hampshire are paid roughly 67.7% of the cost of providing care to Medicare patients. And in 2024, almost a third of our 340B participating hospitals had negative operating margins. The 340B program is one of the most consequential policy solutions to ensure that drug companies contribute to the healthcare safety net in communities across New Hampshire, while no federal or state taxpayer dollars are used to fund the program. As I noted, the 340B program also helps shield providers from major increases in drug prices, which are the most rapidly growing expense for hospitals. Some have called into question the rapid growth of the 340B program and blamed hospitals. However, nothing has affected the growth in the 340B program more than the high price drug companies charge for these drugs. Last year, I noted in this committee that for the first time in history, the median price of a new drug was $300,000 in 2023. The median price of a new drug that entered the market in 2024 was $370,000, an increase of 23%, which is the same growth rate that the 340B program experienced in that time frame. This underscores the correlation between the launch price and growth rate that drug companies' pricing decisions have on the 340B program, not hospitals somehow taking advantage of the program. This bill doesn't do anything to change the benefits, eligibility, structure, or federal accountability already required for the 340B program. What SB 477 attempts to do is make the state of New Hampshire the compliance officer for a federal program by enacting exhaustive, unnecessary administrative burden on hospitals at a cost to the state and to the participating hospitals. One of the pillars of our work this year to address affordability in healthcare is identifying the true cost drivers of providing care. A major area identified by our members is the cost of unnecessary regulatory burdens. The average size community hospital in the United States employs 59 FTEs for regulatory compliance, over 1/4 of which are doctors and nurses being pulled away from the bedside, costing nearly $7.6 million annually to support compliance with federal regulations alone. Hospitals in New Hampshire have been forced to expand significant resources, including adding additional staff and leasing off-site space in order to shoulder these endless administrative burdens. This bill would add to those costs unnecessarily when participating hospitals are already held accountable for their participation in the 340B program by the Health Resources and Services Administration, which oversees accountability for both participating providers and drug manufacturers. So the federal oversight and the accountability doesn't just ensure accountability for providers in the program, it also does that for the drug manufacturers that participate in the program as well. Existing federal accountability measures from HRSA are robust and include annual recertification, determine eligibility, compliance with federal regulations which prohibit duplicate discounts and rebates, and routine program audits with results of any adverse findings reported publicly online. Beyond the regulatory burden in SB 477, there are several technical challenges for the hospital's ability to comply with the reporting requirements outlined in this bill. For example, for many of these drugs, hospitals are paid by a bundled payment, which include administrative and professional charges. Hospitals would not be able to parse out the drug reimbursement from the bundled payment. Specific drug reimbursement cannot be reported from a bundled payment because the reimbursement is a single predetermined lump sum amount for an entire episode of care, which inherently merges all associated costs, including drugs, into a single rate. For these reasons, we would encourage the committee to recommend ITL. And for reference, I've included the participating hospitals in my testimony. I'm happy to take questions.
Thank you very much. Are there questions? Senator Bertzel.
Thank you, Mr. Chair. Thank you for taking my question.
Yes, Senator.
So in your testimony, it says the existing federal accountability measures from HRSA are robust, but we just heard from the Department of Insurance that HRSA is no longer covering the program. It's moved to CMS. How does that affect it?
So I don't know that that's what the representative from the insurance department was saying. HRSA maintains oversight of this program, the administrative oversight for this program, and accountability for both providers and drug manufacturers. And I can share some perspective on some of the auditing that's been done by HRSA recently. I know for a fact there's one hospital that has a scheduled HRSA 340B audit next month. These are complicated. They bring personnel from HRSA and inspect the facility, go through records, see what has been included in those rebates and whatnot. So they are exhaustive, and HRSA maintains that administrative oversight of the program.
Okay, I'll have to look a little bit deeper into it. Thank you.
Sure.
Any additional questions? Got something real quick for you.
Sure.
And and I don't know who said it, and quite frankly, I can't even read my notes, but we'll see if I got this right. I wrote something down here that said spending on free care has declined over the last several years. Would you find that to be true or not?
From the perspective that I sit at, I don't agree with that.
I'm sorry.
I don't agree with that suggestion that first, in some way, hospitals haven't actually increased their contributions to free, reduced community benefit, et cetera.
And then what has, we talk about uncompensated care quite a bit, and I know that factors into the formula. How has uncompensated care looked like over the last several years?
Well, I think that's where I'm trying to speak to the point about how Medicare only pays for a certain percent of the actual cost of caring for those Medicare patients. And so that gap is our uncompensated, is where we're missing.
33%, right?
So that, and then anybody who's unable to pay, we can set up payment options over time or whatnot, but often hospitals end up eating the cost for certain services, provided. But yes, so uncompensated care is a major issue, and this program, as I mentioned, is intended to spread those scarce federal resources and get drug companies to support the safety net system as their participation in the Medicare and Medicaid programs.
So I'm looking down the road, not too far, as we've seen some of the big, beautiful bill things come into play. And, I know in my part of the world, everyone's scrambling for Medicaid dollars, and we're worried about that, which I'm sure you are as well. adding, I mean, the number that I think, did you say each hospital has an average of 59 full-time equivalents for regulatory compliance?
Across the United States, the average size community hospital, which is around 120 beds,
So
employs 59 people for
I mean,
regulatory compliance.
we're always talking about storms in this committee, right? I mean, I'm wondering if, I support transparency. I think transparency is good. I like to know where the money is going, but at the same time, you're looking at some pretty big things on the horizon as far as costs, and this would be another cost to your operation
I believe so.
with, I think Henry said it, no revenue end on our end. I mean, there's no revenue coming back to the state for that.
Well, I would just clarify on a couple of fronts. One is there is no federal or state taxpayer dollars going to the 340B program. It's all paid by the drug manufacturers that participate in Medicare and Medicaid that offer the benefit that goes to the provider when they purchase the drug. Secondly, around what Henry had pointed out, New Hampshire limits the benefit going to the Medicaid program if it's a Medicaid patient. The provider does not take that benefit. New Hampshire uses that as to help support the Medicaid program. And that being the case, the concern is the more you put on providers that are participating in this program, the more in our opinion, unnecessary burden you have. The concern is, are you going to start chipping away at people's participation, and then does that affect the state's revenue in the state's budget? So I think it's a fair concern.
Great. Any other questions? Senator Prentice.
Great. Thank you, Chair Rochford, and thank you, Ben, for taking my questions. So part of what I'm hearing today, I mean, it's about reporting requirements that are the hospitals are already reporting. So I'm like duplicating my language there. It's hospitals, locations, the systems within those locations, but getting to the uncompensated care and then charity care is 340B dollars that we're looking to say shine the light on. Are they considered charity care, not the uncompensated care? Okay. Because if I may, just I run a not-for-profit and we have to do a 990, and there's requirements for uncompensated care, charity contributions in kind. So I was looking for, is there anything there?
Right. Well, I'm not sure what your question is. You're asking if we report on the benefit
My question is, is any of this reflected in the 990? Any of the?
I will have to get back to you. I don't know.
Okay, that's all. Yeah. Thank you.
Any other questions? Thank you very much. We have Beverly Goodell.
Good afternoon, Chairman and Committee. Thank you so much for allowing me to speak today. My name is Beverly. I'm with the Lupus Foundation New England. I represent the patients and families with lupus and other autoimmune-related diseases. Many of the people that I serve are on very high-cost prescription medications to manage their disease and maintain their quality of life. We support efforts to improve that transparency and accountability in this program. Transparency is fundamental to good governance, and all stakeholders should share the goal of ensuring that this program is there to truly help underserved patients access to the medications that they need. The lack of clear rules and reporting and requirements has created an uneven system, and some participants operate with little oversight, making it difficult to determine whether the 340B savings are being used to help the low-income and uninsured patients who I serve. Independent analysis has shown that patients directly received discounted medications in only a small fraction of the prescriptions eligible for 340B. people living with lupus, access to affordable medication is not an option, it's essential for their well-being. We believe that transparency helps and protects patients by ensuring that program benefits are used as intended. I respectfully and on behalf of my foundation that I work for, urge the committee to support transparency measures that shine light on how 340B savings are used, strengthen the trust in the program, and ensure that patients remain the center of this important policy. And thank you.
Thank you. You said in your testimony that an independent analysis has shown patients directly receive discounted patients, let me start that again. It said independent analysis has shown that patients directly receive discounted medications in only a small fraction of patient prescriptions eligible for 340B. Do you have that analysis you can share with the committee?
I don't have it with me today, but I can provide
Could you get it to the
Yeah.
committee? And so if you can get it to Sophie, she'll make sure that we get that.
Absolutely.
I'd be interested in seeing that. Thank you.
Thank you.
Any questions from the committee? Thank you very much. Is anyone else that would like to talk on Senate Bill 477?
Senator.
You make it quick.
Just give you. Thank you, Mr. Chairman. Just want to give you the raw numbers on some of the spending. 2010, $5 billion in 340B savings. These are HRSA numbers. 2023, $66 billion in savings. And I can show you the graphs too. I can give you a visual representation on this. In contrast, uncompensated care was about 3.3% of all costs, and that decreased. I only have numbers to 2017. I have some other numbers that are a little more, that go a little further. That percentage dropped in the same period down to 2.7%. That only goes to 2017, so it's not exactly the same period. 2011 to 17 versus 2010 to 2023, but it's dropping, and there's more comprehensive data that shows a more dramatic divergence, but those are some actual HRSA numbers. So,
Thank you very much. All right, we're going to close the hearing on Senate Bill 477. You want to hit that? Thank you. All right, very good. Yeah. We're going to open the hearing on Senate Bill 478, and we'll ask the sponsor to introduce his bill.
all right, save the best for last. I think this one will be the most fun, to be honest with you. Thank you, Mr. Chairman and members of the committee. Once again, I'm Senator Tim McHugh, District 11, Merrimack, Amherst, Milford, and Wilton, here to introduce yet another Healthcare Cost Savings Act, the fourth this session, the PBM Accountability Act. So this bill aims to end opaque spread pricing, require pass-through delinked PBM compensation, and protect patients and reinforce the 340B safety net care that we just talked about. It will also strengthen the maximum allowable cost transparency and the clean claims rules. This will give employers and carriers some confidential reporting to NHID, so savings show up at the counter or in the premiums. It will respect the markets, the free markets, and protect trade secrets and keep all the enforcement with the department. No private right of action, no gotcha penalties. So here's the problem. Prices at the pharmacy counter aren't falling. Everybody knows this. Neither are premiums, especially not premiums. If PBMs were reliably passing savings through, we wouldn't be here talking about this, let alone have 4 different pieces of legislation in one session. So one proven driver is the spread pricing. When a PBM charges more than the plan, more than it pays the pharmacy and pockets the difference. In Ohio, the state auditor found that PBMs retained over $200 million in a single year. On generics alone, the state responded by moving to transparent pass-through contracting. So here's how we drafted it. First, thank you to Commissioner Betancourt and Dr. Aziz for their consumer-first guidance. They said be precise, improve market-aware transparency, and avoid the ERISA traps. So we did. The amendment follows that, and we did amend it. Hopefully you all have it. It's 2026-0135S. It may not be the last amendment. There may be a couple more tweaks we need to do. But the amendment follows that with some targeted definitions, confidential filings, not public contracts, a plan year cadence consistent with the NHID's 2025 rebate framework. We also drafted carefully to be compliant with Rutledge, the Rutledge v. PCMA decision, which confirms, by the way, that states can regulate PBM reimbursement practices without intruding on employer plan design. All of the remedies, again, stay with the department. So why does spread pricing raise what the patients pay? Because it creates margin, not good medicine. It inflates the plan claim costs relative to pharmacy reimbursement, which flows right into the premiums. So list price linked incentives push patients towards higher list price drugs while their point of sale cost is calculated on the list price. This bill will delink the PBM pay from list price and route value straightforward, either off the member's claim at the counter or into lower premiums. You're going to hear some familiar talking points, even from last week. You heard some of these same things. PBMs don't set prices. Regulation raises costs. Same old refrain. True, PBMs don't set list prices, but their contracting choices determine the net prices and the patient's out-of-pockets. Ohio's experience shows that spreads were large. The fix was better contracts, not keeping the spread. The amendment tightens and clarifies 478 by defining and prohibiting spread pricing, delinking the PBM compensation with an annual CEO, CFO certification. It will strengthen the clean claims protections along with the existing RSA 318. It will prevent forced steering to mail order or affiliated pharmacies when an in-network retail health system can meet the clinical guidelines, and will prohibit any gag clause on the lowest price. It'll also reinforce the 340B non-discrimination. It'll reset the effective date. The amendment resets the effective date to be January 1st with the remainder on passage. So Senator Prentice just left. It's too bad because she knows I like a McDonald's hamburger. And I might even have a couple of frozen burgers in my office. But I wish Curtis Berry were here to hear this. He's my, oh, good, he came in. He's my dear old friend. I've known Curtis for, I don't know, 20, 30 years. But I got to tell you, healthcare isn't hamburgers. And nobody comparison shops for insulin like a combo meal. There's no Happy Meal substitute for a chemotherapy agent. So with all of this asymmetric information, our constituents' dollars, we need confidential, standardized reporting, and we need to ban this tactic, this spread, because it just simply adds costs without adding care. Preferred networks and mail order, we don't ban preferred networks. We prevent the forced steering to affiliated mail order pharmacies. You're going to hear that quarterly reporting is burdensome, so I listened to that. The bill aligns with NHID's cadence and keeps the disclosures confidential and aggregated so the actuaries can credit savings right into the rates. You're going to hear that this dictates private contracts, and believe me, I am loath to dictate the terms of a contract. But the state already sets market guardrails, and sometimes that's okay. Ending spread pricing and delinking pay are the modern guardrails that we as a legislature need to set to protect our patients and make sure the dollars buy medicine, not undisclosed opaque spreads. So here's what it will deliver for the grant staters. At the counter, the optional point of sale savings, clean claims protection, no post-claim clawbacks, no surprises. In the premiums, pass-through and delinking puts the concessions where NHID can verify and credit them. Hospitals and clinics, no 340B non-discrimination, rather 340B non-discrimination with reasonable audits. Pharmacies get timely MAC access and appeals. The plans preserve their confidentiality, their flexibility is retained, and the bill is drafted to be consistent with Rutledge. So no more hamburger analogies. It's about insulin, cancer drugs, seizure meds, and whether families see the benefits of the dollars we're already spending. I'd really appreciate you support this bill and the amendment and make any additional amendments that the committee sees fit. Happy to take any questions.
Thank you, Senator. We don't have an amendment. I don't know.
Oh, sorry about that. I did think it got distributed. I certainly have a copy here.
Okay. Thank you. Are there any questions from the committee? No, thank you very much. We'll call Representative Miles.
I'm going to go get a cheeseburger.
Yeah.
Thank you, Mr. Chair. Thank you, members of the committee. One more time, my name is Julie Miles. I represent the town of Merrimack, which is District 12, and I am experienced nurse with bedside and healthcare reimbursement insurance experience. So I've watched families stretch insulin, skip fills of medications they need after chemo. They ration their inhalers. And I've watched those same pressures show up in employer and municipal premiums when the claim system pays more than the medicine is worth. So SB 478, it addresses both the realities by ending the non-transparent spread pricing that was mentioned before. It is the dirty word in insurance, spread pricing. Delinking PBM compensation from a drug's price list, so we pay for service and not price inflation. This bill strengthens the transparency of the maximum allowable cost and clean claims protection so that community pharmacies can dispense without post-claim clawbacks. It protects 340B safety net care from discriminatory terms and also while allowing reasonable audits. It channels savings where patients can actually feel it, and at the counter through the point of sale options or in premiums when rates are filed, backed by confidential reporting and to the insurance department so that the math is real. There are transparent PBMs out there. There are many. And so for those who choose to continue being opaque and keeping the process and the numbers in the dark, I think they could take a note from the ones that are transparent. They're easy to work with. Their information is out there. There's proprietary software that allows any insurance company to see the lowest and maximum price of any number of PBMs. So the information is out there if one chooses to look for it. For the employers and municipal plans that I've worked with, predictability matters. And so 478, it keeps market flexibility and it preserves the preferred networks. And it also pays PBM a transparent fee for its service. It asks for clarity, not trade secrets, and it keeps enforcement with the department, no private lawsuits. And families should never have to choose between a mortgage or medication, food or medication. And SB 478 really does move us toward a system that pays for medicine and not margins. I respectfully ask the committee to move on to pass on this bill. Thank you.
Thank you. Are there any questions from the committee? Thank you very much.
Thank you.
I'm going to go with Michelle Heaton and Jason as is. And, oh, Jennifer, I thought, no, you stay back there and back up, right? Reinforcements?
afternoon, everyone. Good afternoon. Michelle Heaton, the New Hampshire Insurance Department. I'm the Director of Life and Health, and I have with me Dr. Jason Azis, who is our Director of Data Analytics at the department. I'm not going to recap really everything that the Commissioner went over. Is it last week already?
Last week, yes, a week ago.
It's hard to believe.
This is Groundhog Day.
We are aware that there are a number of PBM bills out there, and we are happy to work with all of the stakeholders to see where we can get some consensus on some of these issues. It's complicated. There's a lot of different policy options, and I'm just going to reiterate some of the things that the Commissioner tried to point out last week. As we're trying to make regulatory changes to this, we should really try to be more precise and not completely upend the structure which we already have in place. We have to be clear about the problems that we're trying to solve and realistic about whether these proposals are going to actually do anything to advance those goals. We would like to see a priority over transparency as opposed to setting prescriptive prices or price setting models. We have to be cognizant of the contractual relationships between carriers and PBMs and all of the legal issues regarding that. We want to be careful about staying within our jurisdiction regulatory wise. If we try to go beyond the fully insured market, there is a higher risk of litigation. And depending on what exactly we're trying to do outside of that fully insured market, there is a risk of federal preemption. I think I've touched on a lot of the things. I know the Commissioner went on a lot longer at length. I'm trying to be more succinct given the time of day. So
Long day.
I'm happy to answer any questions. I know there are some technical defects in the bill as introduced. Some of those things will conflict with other existing laws. There is just reminders. 402N, RSA 402N regulates PBMs. That is different than the regulation of prescription drugs under a healthcare plan. The regulation of prescription drugs is really better suited under 420J, our managed care law. And there are already a number of provisions in place, and we just want to make sure that as we are making amendments and tweaks that we're not conflicting with protections already in place. We are aware of the amendment. We have had an opportunity to look at it briefly. We have not done a deep dive into it, but the amendment still does have some of those technical issues that will need to be addressed. And we're more than happy to work with all of the stakeholders to get a bill that does everything that everyone's trying to do in the appropriate way. Jason, do you have anything else you want to add?
Just in retrospect, Senator Prentice, last week on a similar bill, you asked something about the cadence of reporting to the insurance department. And I responded back about 12 months, and I heard this bill sponsor mention that same cadence here. But you suggested maybe the advantage of a more frequent cadence. And I haven't thought a lot about that since you asked that. I think that is interesting to the insurance department to maybe have every 6-month reporting window. So I just wanted to rectify my response to you then and tell you that I appreciate that insight. Yeah. So keep that in mind if there were amendments that were to be made, that increasing the cadence might be something that can give us more granularity. Thank you.
Thank you. Any questions? So one thing that Michelle, you said is, it's important to be precise and not upend. This is our second bill. This is considerably longer than last week's. Do either one of these or both upend in your description?
There are good aspects in both of them, and then there are some more problematic aspects. Some of them are, I think both bills are looking to amend the definition of PBM, and doing that in and of itself opens up kind of a whole nother can of worms. Right now, the definition of PBM ties to the fully insured market, but a big part that is not included in that definition is if a carrier owns their own PBM, they don't fall within that definition of PBM. I think Some of these bills are looking to expand that definition, but by doing so, you're also expanding everything else in 402N, and that could cause some problems for federal preemption. So I think we need to be just more precise in what we're trying to do, clean up some of that language. I think there's some different ideas in each bill. There's some good stuff, and then there's some stuff that'd be a little bit more problematic that we'd have to work through.
And I've spoken to both sponsors and now 3 sponsors, because we've got a late bill that's going to be we're working on as well. And I said the same thing. I've read them. I haven't read the late bill yet, but there's certain things in there that I think are really good in each thing. But what we come out with, I'm going to really work with you closely on that because of the same issue that you talk about. We've got a variety of different places in law that this is. And, I think we'll be talking, I know where what I want it to look like, and then we'll probably work backwards from there. And using these 2 bills and pulling those things in.
Yeah.
Any other questions? Thank you very much.
Thank you.
Let's see. Henry.
Thank you for the chance to speak again. I'm Henry Lippman, State Medicaid Director. Under Medicaid, we've already, with our MCOs, banned spread pricing and clawbacks. Medicaid program, the rebates come to benefit to fund the program. We'd ask to work with a technical correction to exclude Medicaid from the bill. Because I don't think we fit into that because there's a very, very, very small portion of any pharmaceutical that's paid by the patient. So that's just our simple request. And I know there's a lot of things you need to deal with here, but I hope you would support that. I know in other drafts of this in other years we have been. And
Yeah, I know we did work last year on rebates and brand name drugs and, that took a lot to get through.
Yes.
It shouldn't have, but it did. So we don't want to, that was like a $9 million, benefit to the state.
Yeah.
So.
In the rate amendment we just did, it was almost $8 million actually that saved in this current budget.
Well, we will, we'll make sure we loop you in.
Thank you.
All right. Are there any questions? All right. We're getting to the end here.
Thank
All
you.
right. Let's see. Cam and Margaret. And I know a lot of the folks who signed up to speak today spoke last week, so I'm assuming the issues are the same, but if there's anything else in there that you want to talk about, that's what we're here for.
Thank you, Mr. Chairman, members of the committee. Good afternoon. For the record, I am Cam Lapine. I am the Government and Regulatory Affairs Manager at Warren Reno, here today representing Cigna. Alongside me is Margaret Reynolds. She lives in Amherst. She is my PBM guru. I said that last week. To distinguish between, so I'm going to focus on some of the technical issues in Senate Bill 478, which are different from the bill last week. Then I'll hand it over to Margaret to speak to some of the policy issues. So I handed you a copy of the actual bill, which I didn't. It's underneath here. So, page 3, line 11 of the bill. Page 3, line 11. Repeals RSA 402N2. RSA 402N2 is the statute that requires PBM registration. I don't see anywhere else in Senate Bill 478 that requires PBM registration anywhere else. And based on the sponsor's testimony, I don't think that was your intention to completely eliminate PBM registration, which might make it harder for the department to accomplish the goals. So I wanted to point that out to you. The prime sponsor said several times that there is not a private right of action, and that is on page 3, lines 17 and 18. No private right of action is created. However, if you flip to page 8, lines 28 and 29 say a person who is aggrieved by a violation of this section may bring a civil action before a state court of competent jurisdiction against a pharmacy benefit manager. That's a private right of action. So if the intent is not for there to be a private right of action, you would want to take that out on page 8. There's a renumbering issue on page 4, lines 4 and 5.
Cam, I don't want to interrupt your train of thought, but did you get the amendment that came out?
I have seen that. The only
okay.
the only piece of that piece that is the only thing I'm about to say that is addressed in the amendment is the very next thing I'm about to say.
Okay, all right, very good. That we just wanted to make sure you had it.
Yeah. So the amendment addresses this next piece, which is a renumbering issue, which I won't get into, but that's on page 4, lines 4 and 5. But that is addressed in the amendment. Staying on page 4, lines 16 and 17 address pharmacist gag clauses. Those already exist in RSA 420J8. I think that's 16 in Roman numerals.
Yes.
Thank you, Margaret. So this section of Senate Bill 478 is duplicative. Moving down here, let me see, page 4, lines 18 through 26, the section on 340B non-discrimination. Senator Prentice, I believe it was your bill in 2024, Senate Bill 557 created RSA 415-15A, which already prohibits discrimination in the 340B program. So that's another area of duplication in the bill. And then if you staying on page 4, lines 34 and 35. Yes, the prior authorization piece, RSA 420J7B2 and RSA 420J7B2B already establish turnaround times for prior authorization in drug benefit plans, and they're more stringent than the timeline in Senate Bill 478. And then this is my last piece here that I wanted to point out for you. Let's see. Page 5, lines 6 through 8 address out-of-pocket insulin costs. House Bill 1280 was passed in 2020 and codified as RSA 415-6E, 415-18F, 420A-17A, and 420B-8K, which already caps out-of-pocket insulin costs. So this is another duplicative section that already exists in statute. And so with those, I'll hand it over to Margaret.
Thanks, Cam. Thank you, Senator Rochefort, and members of the committee for allowing me to come here today. My name is Margaret Reynolds. I'm with Cigna. Express Scripts is a pharmacy benefit manager operating within the Cigna group, so my comments today are specific to Express Scripts, just so that's clear for the record. So as an organization, we have concerns with this bill. I'm going to try not to duplicate what Cam has pointed out, but we'll keep this high level. I did submit testimony to the original bill. Some of that is addressed in the amendment, so appreciate the efforts from the author on that. But when it comes to definitions, there's a definition of insurer, whereas in this statute, we would use health carrier, and the new definition of insurer references federal statute that could bring in ERISA plans. It was clear from the department that could invite litigation, so certainly want to point that out for the committee to consider. Also, the broad definition of pharmacy benefit manager, which the department pointed out, we think it's overly broad and could be unenforceable given who it could pull into the definition. Cam covered section 3. So moving to section 4, starting on page 3, paragraphs 1 and 2 together limit how a PBM can be compensated for their services and would ultimately prohibit spread pricing in contract. Paragraph 1 delinks market-based incentives such as rebates, discounts, and other price concessions from a drug price. These savings are passed directly to
I'm
health-
sorry to interrupt you. Where are you again? What?
Oh, I'm sorry. Section 4, beginning on page 3.
Okay.
Thank you. These savings are passed along directly to health plan sponsors, including employers, unions, small businesses, and government entities who use that money to lower premiums, reduce cost sharing, and offer more comprehensive benefits. Delinking legislation undermines performance-based PBM compensation frameworks and would result in a windfall to drug manufacturers. By prohibiting those payments from being based on list price, delinking legislation paves the way for drug manufacturers to raise prices without any negative financial consequences. While Express Scripts is moving to a bona fide service fee arrangement for our fully insured products in 2027, we still want to maintain that option to work with our plan sponsors and employers to determine how they want to structure their plan, whether it's spread pricing or pass through with a PMPM administrative fee. Specific to paragraph 3, so page 3, line 36, we would suggest amending the final sentence to allow a designee to sign these certifications. It may not always be practical for a CEO or CFO to sign these certifications, so we would just like to include that option. I believe the amendment addressed the effective date, but just want to point out that we already have contracts in place for 2026. The original bill would have this section effective upon enactment, and it would disrupt current contracts. So just want to be sure if this were to be part of a final bill, it would not go into place until at least 1/1/27. Section 5 on page 4, paragraph 1, after the term abuse on line 7, we would include a cross-reference to pharmacy audits in revised statute 318-62 through 66. That specific language is in my written testimony for you, but it just cross-references the statutes to make it clear. In paragraph 2, we would suggest aligning 7 days in both references and striking business on line 10. And then I did offer to Senator McHugh to perhaps for the committee to consider the specified thresholds, wholesale acquisition cost, or something that would be a metric that's available to suppliers across the drug chain.
I'm going to do it again to you.
Yes.
Where are you?
So I was on section 5, page 4.
Okay.
And yeah, sorry, that was line 10 was the striking of the business, and then specified thresholds on line 11. I just want this committee to consider perhaps what that would be, and I offered to Senator McHugh wholesale acquisition cost is a metric that would be visible to entities along the drug supply chain. So something to consider, nothing hard and fast.
So
I believe-
versus MAC pricing, WAC versus wholesale acquisition versus MAC. I'm looking at line 10, MAC list.
No, so Senator, we're looking on line 11. The bill just says when pricing changes exceed specified thresholds. What Margaret is suggesting is defining those specified thresholds in statute, perhaps relating them back to the WAC.
Yeah, all right.
Thank you. And then the amendment did address in-network retail and health systems in paragraph 3. This just allows us to still maintain our networks of pharmacy. The 340B modifier that was included in Senator McHugh's amendment. We did have concerns with federal and state standards because CMS utilizes NCPDP, which is not necessarily a federal standard. Other PBMs utilize that as well. So we just want the flexibility. But I believe the amendment that he offered to the committee does address that concern.
I mean, NCPDP is a national, I mean, it's not everybody uses NCPDP.
It's national. I wasn't sure if it fit into the category of a federal
Yeah.
standard.
All right.
So
We could address that.
yeah, if you want to play with
But
that.
that's how it's going to be transmitted. I mean, that's the,
Perfect.
it's the format, because that's, and I don't know whether we need to call that out or not, but that's what's going to, that's how everyone transmits data.
Yes. Great, thank you. Oh, yes, I believe his amendment addressed the modifier as well. Sorry, I don't have that right in front of me. Okay, I'm almost done. Section 7, Kim did point out that there are already tighter timelines. The CMS interoperability.
So we'll be, this is on page 4, lines 34 and 35, just for your reference.
Yeah, paragraph 5, thank you. CMS timelines outlined in the interoperability and electronic prior authorization final rule from January 17, 2024 was 72 hours and 7 days. But if New Hampshire already has tighter restrictions, it probably would be better to just cross-reference with what's already in statute. Section 8, page 5, on line 14, we would recommend inserting after lives for plans situs in New Hampshire. This makes it clear that there's no extraterritorial impact and that reporting and data collected by NHID would reflect the experience of Granite Staters.
Attributed to New Hampshire lives for plans.
Situs in New Hampshire. So plans based in New Hampshire.
Yep.
For section 9, that's pretty long, pages 6 through 8, the duty of care. I know last week we talked about a fiduciary duty. The duty of care in this legislation would assign the duty to enrollees, health plans, and providers, and then giving precedent to an enrollee over the other two. There certainly could be conflicting interests among those parties, and the PBM contracts directly with the health plan sponsor or the employer. So in our practice, that's who our duty of care would be the contracted entity. If an enrollee gets precedent over that, you could run into a conflict where the enrollee's requesting a brand name drug that's off formulary. Our contract would require us to carry out the formulary to that plan sponsor. But in this legislation, if it were operationalized, we would have to honor the enrollee's request for the off-formulary brand drug to the expense of the plan sponsor.
I'm looking, actually, section 9, I did have a question on. So, line 12, carriers shall offer to all enrollees an interest-free monthly out-of-pocket smoothing option that allows members to distribute high pharmacy cost sharing across the plan year. Kind of sounds like you're a bank.
Yeah, so with my Express Scripts hat on, it's a duty to the carrier, not the PBM. So
Yeah.
putting on my Cigna hat, I don't know how that fits into a PBM bill.
Yeah, I mean, I'm glad you said it, because when I read that first, I said, what is this, Chase? 30% APR, you know, it's,
Yeah.
I guess you don't even get to charge interest, but anyway.
It's a very interesting concept,
Yeah.
certainly something for the committee to consider, but that is assigned to a carrier and not a PBM, so I'm not sure it
Okay.
fits here.
Yep.
We would suggest, rather than the duty of care assigned to multiple entities, a standard of good faith and fair dealing between the PBM and its contracted entity, so the health plan or the employer. Section 10, the preemption clause, has an effective date of 1/1/27, whereas we would suggest that have an effective date upon enactment. And then I believe the amendment addresses the effective dates for sections 4 through 9 being 1/1/27. And with that, I will conclude my comments. I am happy to answer questions and appreciate the committee's time. This is a very big bill.
You've got this in writing, right?
Yes.
Yes, that's what you just read. Very good. Any questions for Margaret?
No.
All right. Cam, are you staying here, or did you get your, you're up here twice, so you're gonna put your APCIA hat on now, or did
I
you do
am,
that?
for 10 seconds.
All right, you got it.
I'm still Cam Lapine. I still work at Orrin Reno. I also represent the American Property Casualty Insurance Association and the New Hampshire Association of Domestic Insurance Companies. As with last week, we have concerns about the definition in the bill may include workers' compensation carriers. We would request an exemption to specifically exclude workers' compensation for many of the reasons Director Lippman raised for excluding Medicaid. And also the private right of action question as well, is a concern for property and casualty carriers. Happy to take any questions on either of those as well.
I don't have any. Does anyone else have any questions for Cam? All right.
Thank you.
Thank you very much. Let's see, Morgan Halloran. Good.
Thank you, and good afternoon, members of the committee. Thank you for having me here today. My name is Morgan Halloran, and I'm Director for State Policy with the Pharmaceutical Research and Manufacturers of America. Pharma represents the country's leading innovative biopharmaceutical manufacturers. I'm here today to testify in support of Senate Bill 478 because it prioritizes patients by fixing misaligned incentives in the prescription drug supply chain. This bill contains a number of provisions to reform how PBMs operate, but I'm only going to focus today in my testimony on changes to how PBMs are compensated, duty of care, and transparency requirements. The reforms to PBM compensation are obviously desperately needed. PBMs administer prescription drug benefits to more than 289 million Americans, and just 3 PBMs control nearly 80% of the national market. Because of that large share of market power, the way they choose to structure contracts can have a major influence on which medicines patients can access and what they pay. Today, many PBM contracts rely on percentage-based formulas where PBM compensation is tied to the list price of the medicine or the size of the rebate associated with it. PBMs may also collect administrative fees that are calculated as a percentage of a drug's price. Experts, including federal agencies and independent researchers, have found that these percentage-based arrangements create misaligned incentives that may lead to PBMs favoring medicines with higher list prices and larger rebates. When PBMs use these revenue models or spread pricing, they can have incentives that are not aligned with patients, employers, or insurers. They can affect which medicines are included on formularies, whether lower cost alternatives are covered, and how much patients ultimately pay at the pharmacy counter. SB 478 would remove those incentives with a simple administrative fee by bringing clarity and transparency to PBM operations in New Hampshire. SB 478 would reform how PBMs are paid. The bill would require PBM insurer contracts to use clear, flat services fees, creating a transparent and consistent compensation model. These fees cannot be tied to the price of the medicine. This reform ensures PBMs are paid for their actual work, such as claims processing and network management, rather than through percentage-based formulas that can influence coverage decisions in ways unrelated to patient affordability or plan value. SB 478 also bans spread pricing, and today PBMs can charge a health plan more than they reimburse the pharmacy and keep the difference or the spread. This bill ends this tactic so patients, employers, and taxpayers are not overcharged. In addition to PBM compensation reform, this bill also includes 2 other essential pillars of accountability: an enhanced PBM transparency and a statutory duty of care. Together, these reforms address longstanding gaps that allow PBMs to operate with little oversight despite their enormous influence over patient access and costs. By pairing transparency with a statutory duty of care, the bill ensures policymakers and plans understand PBM practices, identify harmful pricing behavior, and incentives are aligned with patient and plan value, not PBM profit. Thank you for your time today, and I urge your support of this bill, and I'm happy to answer any questions you may have.
Thank you very much. Any questions for Morgan? Thank you. Let's see, Kristen Gordon.
Thank you for the opportunity to testify today. I'm Kristen McCone Gordon. I'm the Associate Director for Advocacy and Public Policy for Epilepsy Foundation New England. On behalf of Epilepsy Foundation New England and the more than 13,000 individuals living with epilepsy here in New Hampshire, we urge you today to support Senate Bill 478. First, some information on our community. Our organization supports individuals and families living with epilepsy every day. Through direct services, education, and care navigation, we see firsthand how prescription drug costs affect people's health, safety, and stability. Epilepsy is a medical condition that produces seizures affecting a variety of mental and physical functions and is unfortunately more common than most people realize. 1 in 10 Americans will have a seizure in their lifetime, and 1 in 26 Americans will develop epilepsy in their lifetime. For most people, daily medication is essential to control seizures and maintain independence. However, there is no one-size-fits-all treatment option for epilepsy, and the response to medications can be different for each person. Many members of our community are on several medications for their seizures and accompanying comorbidities. As one can imagine, needing several high-cost medications often has an unsustainable cumulative financial effect for those living with this disease. Even with insurance, out-of-pocket costs can be and frequently are overwhelming for members of our community. This bill addresses the core reason for those excessive costs, how PBMs are paid. You've heard the detail of the legislation. I won't be redundant. We refer to the bill sponsors. But in summary, we support this bill because it provides transparency, fairer pricing, and lower costs for patients. From our perspective in client care, affordability is a critical issue in the daily lives of so many, as we all know. Families routinely tell us in New Hampshire that they struggle to afford medications, and when people can't afford their medications, they may skip doses or stop treatments. For someone with epilepsy, this frequently means more seizures, almost guarantees more seizures. Emergency room visits, job loss, and significant injury, outcomes that harm patients, families, and the healthcare system as a whole. We believe this bill helps make prescription drugs more affordable for people living with epilepsy and for thousands of New Hampshire residents with chronic conditions. So we urge your support. Thank you.
Great, thank you. Now, have you put eyes on the other PBM bill that we heard last week?
I have not recently, so
Okay.
I certainly will.
I would encourage you to do so because there are some overlapping things, but there's some different concepts in there, and I just urge you to take a look at that. Senator Rosenwald was the prime sponsor.
Wonderful. Thank you.
Are there any questions of the committee? Thank you very much.
Thank you.
Peter Bragdon.
Hello again.
Hello
Members of the
again.
Committee, still Peter Bragdon, still representing Harvard Pilgrim Healthcare, who, as you know, the state's not-for-profit health insurance carrier. Just a few things in this bill that are of concern to us. We're a little different than some of the other testimony you may have had. We are not a big national insurance company. We don't own our own PBM. We're a small regional nonprofit. We have to contract with other PBMs, so there's some things that are important to us. From our perspective that may differ. The first item is certainly in section 4 where it bans spread pricing. I think the hearing last week, I mentioned at least for our situation, spread pricing is a considerable factor in cost savings because it spreads the pricing risks, transfers it to the PBM rather than to us. That allows us to keep the pricing down a little bit, as is for the self-insured groups that we administer. They prefer the spread pricing because it transfers the risk away from them. So it's very important to us. I think it was mentioned at the hearing last week that I think it was Connecticut had made changes to PBMs that didn't ban spread pricing, but said that the PBMs had to offer 2 options. One with spread pricing and one without, and maybe that's something that could work with. And I think I relayed my experience as the executive director at HealthTrust, where we had to choose a new PBM, and the amount of work that went into that and the consultants. But there was a lot of auditing and reporting specs within there and consultants that allowed us to see exactly what was happening and compare those prices and making the best decision overall. Because as I mentioned earlier today, as insurance prices go up, people are more inclined to either stop getting insurance or to get more copays and higher deductibles, which means they're less likely to seek care. So it's like that balloon that Director Lippman mentioned earlier. You squeeze one end of it, and it's going to come somewhere else. So we're concerned about the removal of spread pricing. That's very important to us. Let's see, there's a part of Section 6 dealing with the 340B claim, specifically on page 4, line 22. And this may be just not understanding what this says, but it says should not require unique modifiers outside of federal state standards for us to be rebate eligible. We have to know certain things about it, and so we have to put that modifier in the claims, and I'm not sure if that's covered by that or not. So that's something that would need a little more clarification. And then finally, the other piece that we had to be concerned about, that Senator Rochford had mentioned, we are not a bank. Providing interest-free loans to people to meet their copays is just going to be increased cost to us, because not only administratively, but what happens at the end of the year when people haven't paid their dues. It's going to have to be made up for in premium. So, you know, premium should be focused on medically necessary things and certainly not being a bank. That's all I
Very
have.
good. Are there any questions?
Thank you.
Thank you very much. Paula?
Thank you very much, Mr. Chairman, members of the committee. You've had a long day, so I'll be short, and I've had the benefit of listening to people who picked up very detailed things that I totally missed as I was scrolling through the bill. But the bill is long, and it's, I haven't the amendment. Maybe the amendment makes it a little more concise, but let me give you my sense, and I'll pick up on what Peter was saying largely about spread pricing. So as I understand the industry, and it's really peripheral because my focus has been largely on the plans, there are different models that PBMs are using with different companies. So spread pricing model, and there's, thank you, I'm not going to be able to read it right away, but anyway, this pass-through. And then there are probably more recent plans, probably responding to some of the pressure around the mystique and the obscure pricing, that there are fully transparent models. So the market has responded. So I'm saying I think you want to be careful in moving spread pricing entirely to the side. Maybe more organically, you can expect some progress here with transparency. So some caution around that. The other thing that I wanted to pick up on was Peter's last comment, because it's something that troubled me about the drafting of the bill, and that's section 9 on page 6. It somehow has new sections, consumer out-of-pocket smoothing option, and then gets into another issue beyond spread pricing that is conceptually problematic, is the duty of care, which I'll get to in a moment. But the smoothing option, to which I guess there was going to be an interest-free loan, apparently on schedule, if you're on Medicare and you are receiving drugs through a Part D, there is a smoothing opportunity, i.e. you can opt into a situation where when you go to the counter and you're purchasing a drug, you will be able to smooth your out-of-pocket costs over a period of time up to a dollar amount, I think, of $2,000. This comes from quickly Googling around to try and find out what smoothing was. And what struck me about it was, here is a federal program that is trying something very new and has no idea how it's really going to work out, but has more latitude to do so than a commercial operation would. And somehow this is being imported into this proposal. So I would be just advise caution about keeping that in the bill. I don't think it really belongs there. And it sort of resonates with the issue of the secret shopper that came up in your earlier hearing, talking about network adequacy. Again, a federal program, sort of unproven, maybe a good tool. I don't know, as smoothing could be a good tool, but premature to perhaps move to it. So on the duty of care, I think what troubled me was not so much it's coming into the bill, because there could be fiduciary duty, as some other states have gone, but duty of care seems more reasonable. But there's this interesting rulemaking sort of opportunity, or maybe it's a task of the insurance department to sort of define that, and define that as it relates to what is the duty of care to an enrollee, what is the duty of care to a health plan, to a provider, and that's all on page 8. So I'd ask you to look at that as well, and maybe discuss that when things go along with the department as to how they feel with that particular burden, which is unusual. So that's really what I had to say, and I thank everybody that went before me because it certainly lightened my load. Long day. Thank you.
Any questions? You talk about something real quick about the spread pricing, and Peter said the same thing a minute ago, and I kind of have my thoughts on that. But you bring up a concept that perhaps the transparency would be more valuable, so the process is transparent, and then people can see it, and maybe the market would move, with or against spread pricing.
Well,
Would
if you define spread pricing, i.e. the plan is going to be charged more than the pharmacist got paid,
Yeah,
that just doesn't sound right,
right.
but it yields something that, of course, has been utilized over time and maybe gotten distorted in places. I really don't know. I just know that nakedly, spread pricing sounds a little odd. But if you say to the plans, you go into it knowingly, as they all have consultants, go into it knowingly. And also, there are other opportunities. You can do the pass-through. You could do a completely more transparent arrangement. And I think certain plans are actually touting their progress in that regard.
Yeah.
Press releases.
Yeah.
So I think you need to look at those things because it is a business.
Yeah.
And unfortunately, the other thing I was thinking is sitting back there is there's nothing we can do about the top of the model, which is, well, not much you can do at the state level with the drug manufacturers. But I'm sure they're listening to this debate, but they don't really come and participate, sit down with the sound on. How do we get to the real issue of how the pricing happens at that level, which creates in a cascade all of these things that look to the average eye like some sort of distortion, but they're sort of a business reality in the environment in which we live. So.
Yeah. Well, thank you.
Okay, thank you.
All right. Sam and Curtis, you want to come together or you want to come separately? All right.
And I'll go first this week. Thank you, Mr. Chair, members of the committee. Again, my name is Curtis Barry. I represent the Pharmaceutical Care Management Association, which is a national trade association for the PBM industry. And a place I'd like to start is a place where I was remiss in not starting last week to talk about PBMs and their role. PBM stands for Pharmacy Benefit Manager, and they do just that. They manage the pharmacy benefit for a plan sponsor, the people that by and large pay the premiums. Could be the state of New Hampshire, which contracts with the PBM, could be a health carrier, which we've talked a lot about today, could be a self-insured entity. The PBMs do work for all of those. And it's the folks that those plans work for, I think, that is often left out of these discussions. There's been little to no discussion last week or this week about the people that sponsor the plans, the employers, the state. If you create legislation with good intention that makes it more expensive for a plan sponsor to offer the pharmacy benefit, they have choices, and it was alluded to. It could result in higher co-pays or additional costs that they have to swallow. So that's something that you have to gauge. What is the PBM's role? The PBM's role is to make the prescription drug benefit for the employees that is provided to the employees, make it less effective, less expensive, and more robust as possible, covering as many things as possible for the employer. Please keep in mind that role. We also haven't seen the amendment, don't need a copy right now, which may address some of the issues. And I think much of the issues that we were to bring to you today have been covered. I know you received a lot of documentation, both from me and others that outline some different, some similar concerns with the bill. But going to the cost aspect, one thing that I'm at least surprised at sitting here today is that you haven't heard from the Department of Administrative Services. There may be an updated fiscal note. The version that I have is not, there was no fiscal note available, but this bill clearly applies to the state employees plan. If you read the definition of insurer, and then that term is used in several places in the bill, this specifically calls out state plans. So I would, at the very least, look to them for an analysis. Sam's going to speak to another state that had a fiscal note that was attached to one aspect of this bill. One other thing I will speak to in generality that was mentioned by the Department of Insurance is consistency. The document that I provided to you speaks to that this bill in several places creates policy that is created elsewhere in statute, and I think we need to make sure at the very least that those are consistent from 420J, I think it is, and 402N. And then one last thing that I'll point out and let Sam speak to experience in another state is something that I've pointed out in the past on other pieces of legislation. If you hear from a state department, Mr. Lippman was here speaking on behalf of Medicaid or the state employees plan, asking to be carved out because it's going to be too expensive. Logic dictates that it's also expensive for the plan or the plan sponsor. That you can't argue that it won't cost the plan more money here, but it will cost the state more money. The policy applies. If it costs Medicaid money, it's going to cost the plan money. It's just simple logic. So with that, I'll let Sam speak to.
Yeah, thanks, Curtis. Good afternoon, Chair Rochefort and members of the committee. My name is Sam Hollemeyer. I'm with PCMA, which is the National Trade Association for America's Pharmacy Benefit Managers. I'm here today to oppose Senate Bill 478, and I did submit written testimony along with some other material, so we'll keep my comments brief because some of the things I do want to discuss today have already been talked about. And I did share this last week, but I want to say it one more time. No one is required to use a PBM. There is no law that requires a plan sponsor to contract with a PBM. Due to the purchasing power of PBMs and their ability to negotiate network pharmacies, plans hire the services of a PBM to control those costs and do those administrative services. So for my verbal testimony today, I'm going to focus on 4 things: how PBMs are compensated, ERISA, eroding mail order, and conflicting duties of care. And then I have other concerns that are also outlined in testimony. So the language in how PBMs are compensated is in Section 4, and you've heard this term before, delinking, but I refer to it as PBM compensation, and it would prohibit plan sponsors from choosing performance-based arrangements with their PBM and require their PBM to move to a flat fee. It would change the business models on how PBMs negotiate rebates with pharma or drug discounts, and we think it would result in pharma having to offer less of a rebate or a discount when we move to this flat fee arrangement. So Section 4 of this bill is titled Employer Choice and State Plan Alignment. However, we think that this section takes away choices from employers and plan sponsors and forces them into a state-mandated contract arrangement. So we are questioning, why is New Hampshire dictating contract terms and contracts between 2 private entities? So let me go back to the rebates in the other state that Curtis mentioned. So we think that this policy would result in pharma offering less of a rebate, and we anticipate plan sponsors will see increase in premiums. So New Hampshire patients will pay those premiums. So the state of New Mexico considered this exact same policy we're considering in Section 4. And due to the bill making it out of committee, a fiscal note was generated, and I passed out a fiscal note from the New Mexico committee, and it showed that changing how PBMs are compensated would generate a fiscal note of $60 million in 2026 due to the impact on rebates it receives from this policy. Again, that is just the state employee plan of New Mexico. And due to this fiscal note, the bill eventually died. To be clear, this language does nothing to the cost of the drug that pharma sets. It only impacts how plan sponsors pay their PBM. Next, I'm going to go into the ERISA concern. It was mentioned the definition of insurer is expanded to include a federal definition, which we think would rope in self-funded plans. And again, we think that the state cannot regulate those self-funded plans. That's in Section 2 of the bill. Next is on mail order, which is in Section 5, subparagraph 3. It states a PBM shall not require the use of a mail order or affiliated pharmacy when a network, retail, or health system pharmacy offers the same net cost and can meet clinically appropriate dispensing requirements. So we think that this provision is inappropriately applied to a PBM because the use of mail order is a plan sponsor's decision, and the PBM just administers it. Again, we think this is another example of this bill taking away choices of plan sponsors to design their benefit. And then finally, it was mentioned previously, there are conflicting duties of care between the enrollee, the health plan sponsor, and the provider. And we think that this places the entity with whom a PBM contracts with, which is the plan sponsor, towards the bottom of that list. And so we think that it creates a system where conflict is inevitable. Employer versus enrollee, provider versus employer are a few examples. We don't understand how that would play out in real life. And then also it's mentioned that this bill would establish a private right of action in addition to the current enforcement by the insurance department. So again, to wrap it up, I do appreciate the opportunity to testify in opposition to Senate Bill 478. We think that this bill does nothing to lower the cost of drugs in New Hampshire. And in fact, we think it does the opposite, that it will increase in premiums for all of New Hampshire patients that pay for these drugs. No one is asking for these policies other than special interest groups, and we consider the committee to oppose this bill. So I'm happy to take any questions at this time, and thank you.
Thank you. Going to Section 5, you just talked about the mail order aspect of it. We have any willing provider contract or provisions in that. So as I have always understood that, if a pharmacy is willing to accept the terms of the contract, they can participate. So in theory, that was designed, because I was around, I was involved in that when it came in. The whole point of that was to get rid of mandated mail order and open up networks. Is there do PBMs and plan sponsors mandate mail order at this point in New Hampshire?
Again, that's a plan decision that they make with their PBM. I'll have to circle back and double check that with the AWP law that's in place in New Hampshire, but I still was under the assumption that plans could still require mail order, but I can confirm that.
All right, we'll check into that.
Yeah.
Because I thought that was addressed a number of years ago, and but you get it, and I know this talks about cold chain specialty drugs, and those were kind of carve-outs that, but we'll look into that.
Okay.
Are there any questions from the committee for Sam or Curtis? No, thank you very much.
Thanks.
All right. Any other people that want to speak on Senate Bill 478 or to close the hearing?
Too late.
All right, so we're back here next Wednesday morning. So we'll be seeing you all then.